माउस दे दे यार, कौन सा माउस रख।
सिर्फ वो लाइट्स ऑफ करो, वहां के लाइट्स। This is who's login? Speaker login?
Mine. He just put my name, that's all. It doesn't matter. It's important is whose face it is. Muted, huh?
She told to mute.
Okay.
It's muted? No.
Muted. Muted, but you can mute it.
ఇక్కడ వస్తుంది
Muted.
Red
What
వచ్చింది.
mute చేసినట్టున్నాడు. Maybe that guy done it. It's a good thing if that guy's done it.
versus Hyderabad.
Good morning.
Good morning, Raghav.
Yeah, I am glad we're all here this morning, and hope things are okay in Pondicherry and Tamil Nadu.
Yeah, quite fine.
Lovely. Today is the second day, though officially the first day of our conference. This morning we have a CME on why I don't do anymore what I did 10 to 20 years ago. To start and to inaugurate this CME, I request President Panyan to say a few words and officially inaugurate our scientific program. Over to President Panyan.
Respected Secretary General of IASIS, Dr. Nalivaraj, respected President, Secretaries, Executive Committee members of various states, senior colleagues of profession, delegates attending this meeting, good morning to everyone. I feel immensely honored giving the opportunity to inaugurate the CME of IASIS on 2020. The main objective of CME is to provide a platform for the postgraduates and young surgeons and fulfill the need for continuous learning. Yesterday, PT teaching program was a session of par excellence. I thank the organizing team. It gave me so much of good learning and a lot of information for the postgraduates and even for many of us. In this age of fast changing technology, updating and keeping abreast of improvement is inevitable. It is quite possible only through the CMEs. The organizing team has put up another great academic feast in the CME of IASISCon 2020. I could not pass on my thanks and congratulations to the team yesterday due to technical problems. I once again thank the organizing team for this excellent show. With these few words, I am happy to inaugurate the CME of IASISCon 2020. Thank you.
Thank you, Professor Panyan. Before we start our CME, I would start the program by an invocation song by classical vocalist Hemangi Bhagat Nene. This invocation song is invocating the goddess of education, Ma Saraswati.
Jada जगत जननी शारदे जगत जननी शारदे करूं मैं तेरी वंदना करूं मैं तेरी वंदना वीणा पाणि धारिणी वीणा पाणि धारिणी प्रकाशपुञ्ज ज्योत्सना करूं मैं तेरी वन्दना जगत जननी शारदे श्वेतपुष्प श्वेतहंस श्वेतवस्त्र धारिणी करी कृपा मोऽपि मात करी कृपा मोऽपि मात जन जन मन रञ्जना करूं मैं तेरी वन्दना जगत जननी शारदे जगत जननी शारदे जगत जननी शारदे
Thank you. May I request now Professor KJ Reddy, the chairman of the scientific committee of this year's OSSCon 2020. He, along with MV, were singularly responsible for developing, designing, and executing this program. Over to Professor KJ Reddy.
Thank you, Raghav. Good morning. Greetings from Hyderabad. Welcome to Oasis 2020. We have excellent scientific program as well as non-scientific program done under great leadership of Dr. Raghav Dutt and the day and night hard work of Dr. M. Reddy, Dr. Karthik Pingle, Dr. Kaushik Reddy worked day and night to put great shape to this program. And in the history of Oasis, the first time you are doing such a wonderful virtual meeting, which would be new beginning for the Oasis, I think, to revive Oasis from coma. So don't go away, stay with us. We have excellent programs, especially CME is so wonderful topics. So I request everyone to stay on, and any doubts you can, after every talk, you can put one or two questions so that we can respond to you. Thank you once again. Welcome to OasisCon 2020.
Thank you for your kind words, Professor KJ Reddy. Now, before we start, may I request our panelists. Thank you for your kind words, Professor KJ Reddy. Before we start the actual scientific sessions, may I request Professor Nalli Yuvaraj, our dynamic Secretary General from Chennai, to say a few words.
Respected President Dr. Pandian, President-elect Dr. Raghav Dutt, of other office bearers of OASIS and the member states, OASISCon 2020 organizing committee members and delegates. It is a proud privilege to be a part of this inaugural function of CME of OASISCon 2020. I think there are around 1,200 delegates, to be exact 1,238, I was told till last evening, who have registered for the OASISCon 2020. I'm sure of these, more than 800 would be young orthopedic surgeons. I'm sure the CME program would be very useful in guiding them on the ways of managing of a few of the common orthopedic disorders. This CME, as the PG teaching program which was conducted yesterday, is unique in that we are today going to listen to the orthopedic surgeons who are going to share their vast knowledge, coming out with their good and bad experiences. And in a way, they would be telling us why they've changed their management of various disorders based upon these good and bad experiences. I think this is what we need today, rather than talking from the textbooks and giving long lectures. And I think I should congratulate the organizing committee for coming out with such a nice concept. And I'm sure that the program is going to be very interesting. Wish the program all success. Thank you.
Now I would request President Professor Pandian and Secretary Dr. Nali to start the CME with the first talk. Thank you once again.
Yeah. Welcome to the first session of the CME program. I think we are having around 14 lectures, and all these are going to be the experiences of the senior orthopedic surgeons who are going to share with us why and how they have changed their ways of managing various common orthopedic disorders. And I'm going to, I'm sure this is going to be a real treat to in listening to these lectures. Can you have the first lecture by Paul Shelber on crouch gait and cerebral palsy?
Hello, everyone. My name is Paulo Selber. I'd like to thank the organizers of the Orthopedic Association of South Indian States during its 19th annual conference in the names of Doctors Chandan Kir and Mulukutla. I'm going to talk a little bit about crouch gait and cerebral palsy, or as I prefer to call it, flexed knee gait. I'm an orthopedic surgeon. I've been doing cerebral palsy for a long time, and I work at Columbia University, New York Presbyterian, and at the Weinberg Family Cerebral Palsy Center here in New York. I have no disclosures regarding this presentation. I have to disclose that I am a big fan of my three mentors, Dr. Ivan Ferreto from Brazil, Luciano Diaz, Brazil and Chicago, and Dr. James Gage. I'll tell you about the objectives of this little talk. The first one will be about discussing a bit of the history of the treatment of cerebral palsy and what has changed or not in the last few years, and a little bit of our preferred surgical techniques to treat flexed knee gait. In the 70s, I think there was what we call, or I call, polio-inspired surgery. Most surgeries done to people with cerebral palsy in those days were copied or translated from the knowledge that they had gathered from poliomyelitis. In the 80s, gait analysis or three-dimensional gait analysis started, and people started understanding a little bit more of CP. And the concept of sagittal balance and the birthday syndrome were described thanks to Dr. Mercer Rang. In the 90s, gait analysis became a more well-established science, and it spread it across the world. And Dr. Jim Gage taught us about lever arm corrections and the importance of not over lengthening muscles. In this line of time, there was a lot of crouch in the 70s. There was a lot of crouch in the 80s even. And unfortunately, even today, there's still a lot, we still see a lot of crouch gait or flexed knee gait. Flexed knee gait is when the knees don't extend fully and the ankles never plant or flex. What are the causes? Well, there's impaired selective motor control in cerebral palsy, impaired balance, impaired vision, impaired cognition, muscle weakness, which is present in most patients with CP and should never be forgotten. There's lever arm disease when the bones are all twisted and the feet have severe deformities. And there's spasticity and a bit of muscle contractures. What are the types? Well, I personally call flexed knee gait, you could divide it in three types, in my opinion. Induced flexed knee gait, when surgeries don't go well. Primary flexed knee gait, when the patients have never had any orthopedic surgery. And residual orthopedic or a crouch gait, when on the plan of surgery, you start fixing crouch, but after the first set of surgeries, it still remains. What can you do about primary crouch or primary flexed knee gait? I think the most important thing is to do crouch surveillance, to watch, to try and understand what's going on with the children and try and understand where it's coming from. How to avoid flexed knee gait? Well, how to avoid this kind of flexed knee gait primarily, which is probably the most common that we see around the world, which is the induced type. The first way to avoid induced crouch or induced flexed knee gait is to say no to tendon Achilles lengthening in diplegics. We know, as a matter of fact, and for more than 20 years, perhaps even 25 years, that Achilles tendon lengthenings in diplegics is an overdose and produce crouch. And for those who don't believe it or have never seen it, they don't believe it or have never seen it because they have never followed the patients for long enough. This paper presented by this group from Melbourne is one of the most important papers in this area. And basically it shows that when a population-based investigation was done, once tendon Achilles lengthenings were stopped, the amount or the incidence of crouch in this population in Australia has reduced to nearly zero. So the other idea, in my opinion, is to give up on hamstrings lengthenings. And this is despite a current paper produced by the so-called experts in the treatment of cerebral palsy, where they continue to postulate that hamstring surgeries are a needed intervention. I believe hamstrings lengthenings are a very ill-used and poorly used set of surgeries in cerebral palsy. And I'll show you a few things that nobody ever shows about hamstrings lengthenings. This is the current fashion, which is even worse, to lengthen the hamstrings through the skin. And this is even worse when people get the percutaneous lengthenings followed by selective dorsal rhizotomy or vice versa. So these are the real outcomes of some of these surgeries. You see this girl, I don't have her pre-op, but this was about 2 years post percutaneous lengthenings, and she was doing very well. And this is her now 5 years post the percutaneous lengthenings of Achilles, hamstrings, and adductors. And I thank the Association for Assistance of Disabled Children in São Paulo for the authorization to show these cases. This was not done at AACD, but was done in Brazil. They copied from elsewhere. More hamstrings outcomes that are not generally shown is the hyperextension of the knees. And this is the result 18 years post-surgery. you see that this lady seems to have perfect alignment, but then when she's not trying hard to control her knees, they go into her hyperextension and her pelvis tilts forwards. So this is a person that could be walking independently in her adult age, but can't walk because she had hamstrings lengthenings, in fact, percutaneously done. This is another thing that people don't see or don't want to see when we lengthen hamstrings, because there's such an important muscle group to extend the pelvis. The pelvis tends to tilt forwards. And sometimes this is so severe that when these children grow into adulthood, they require fusions because of severe back pain. This is a GMFS3, someone who walks with a walker, who could be walking in a much better position, but had to have this fusion, not because of scoliosis, rather because of severe lumbar lordosis. And this is another result using gait analysis. This gentleman had a little bit of a knee flexion and when he was 15, according to the gait lab, and he did get hamstrings lengthenings. And at the age of 39, his knees never extended, but look at his pelvis. His pelvis is now grossly tilted forwards as opposed to before the surgery when the pelvis was at a normal tilt. And this is what leads to severe disability in adulthood. The problem is that, in my opinion, flexed knee gait does not equal to hamstrings lengthenings. So what do? First of all, we need to correct the levers. If the levers are all twisted, one obligatorily would be in crouch. So these need to be corrected orthopedically speaking. Secondly, we've given up on lengthening hamstrings a long, long time ago. And our preferred surgeries in younger people is about transferring semitendinosus above the knee. We published this in 2006 with the Melbourne group after we introduced it to Melbourne. And this is addressing one of the hamstrings only, which we think is the culprit in most knee flexion deformities. And if that's not enough, and very often it's not enough, we modulate the growth of the distal femur to achieve full knee extension. So now when this is given that we know that this is not panacea, in older cases, we use what we proposed early on in 2000, and we call it supracondylar extension osteotomies and patellar tendon shortenings. And this has been rectified by Gillette and others, and the results, when applied in the right population, are relatively good. Now, this is primary crouch in someone who has a touch of knee flexion deformity and lever arm dysfunction or lever arm disease, and you can see his feet going east and west. This is after semitendinosus transfer. So this is residual crouch. He's purely athetoid and dystonic, so I didn't want to do it all in one go. And this is now 9 or 10 years later, when we had only derotated his tibia after the semi-T transfer. And obviously, this is my favorite case because it's probably one of the most difficult ones that gait analysis helped me to treat. Thank you so much.
Dr. Selber, that was wonderful talk. Can you take some questions?
Yes, of course.
Yeah, I know it's very exciting and very difficult field. A basic question, I just wanted to know, how do you decide when to go for a percutaneous or open or a tendon transfer or a bony procedure? Do you decide beforehand, intra-op?
Well, I think John Davids said it very well. We need to base ourselves on the diagnostic matrix if we can. And the diagnostic matrix is about medical history, physical examination, imaging, gait analysis if we can, and ultimately physical examination under anesthesia.
Right.
I always avoid hamstrings lengthenings.
Right.
I know that hamstrings lengthenings are not the answer, because when you lengthen the hamstrings, the knees do get straighter, and everybody knows that.
Yeah.
But the pelvis tilts forward. And when
Right.
the pelvis tilts forward, it's really, really bad for patients in the
Yes.
long term. So we should avoid that. So when the children are younger, I try to do the semi-T transfer alone.
Right.
And if that's not enough, then I go for the growth modulation or the guided growth. And then only as a last resource, I go for what we started in Brazil, and now everybody does,
Right.
which is supracondylar extension osteotomy in patellar tendon shortenings or patellar tendon advancement.
Right. And what do you think, what percentage of people would need a bony procedure?
When we started doing patellar tendon shortenings and supracondylar extension osteotomy,
Right.
and we presented it for the first time in 2000 at the Pozna, we presented it as a salvage procedure.
Right.
So when everything else fails, we do supracondylar extension osteotomies in PTS.
Right.
And what I've heard and seen over the years now is that everybody goes for it as the first resource, but that's, in my humble opinion, that's wrong.
Right.
We can do the semi-T transfer. The semi-T transfer, in our opinion, is a very, very powerful surgery.
Right.
And we're about to embark and start on a multi-center trial, which India is going to be a crucial part of it, because we have 3 centers in India that will do that. But always start with semi-T transfer, and then if it's not enough, you can do the other things.
Right. I think that's a great information. If any questions, Dr. Nali, Professor Pandian, any questions from your side?
No, I don't find any question on chat box also.
Okay.
Yeah, there is a chat box. What about?
Yeah, even I can't see any questions. So
I can see. I wrote a question.
Probably. Thank you once again, Dr. Selber, for your time, and we'll move on to the next talk.
Dr. Reddy, there's one question in chat box. Can I put
Sure. Go on.
Yeah. So there's this question says that what about the proximal hamstring release? Is it better than distal release and transfer?
Yeah.
Dr. Paul?
Take the question.
Well, it's really, really, really bad, because I think people have to understand that the hamstrings are the 3rd most important hip extensors. We have glutei, we have adductor magnus, and we have the hamstrings. If you release the hamstrings proximately, the patient cannot extend the hips. If you can't extend the hips, the pelvis tilts forward. And really, trust me, and I've seen adults all along in my life with CP, it's not nice to walk with 30 degrees of anterior pelvic tilt. Nobody wants to do that. So why would you release the hamstrings proximally? There is absolutely no indication, in my opinion, to release hamstrings proximately in walking CP. Would you do that to your own kid? Would you release the hamstrings to your own kid? No, if you wouldn't do it to your own kid, don't do it to the CP children. They don't deserve anything less than any other child.
Absolutely. Thank you once again. Yeah, if no questions, Professor Pandian, you can move on to the next talk.
Yeah, we have the next talk on stripped capital femoral epiphysis by Dr. Prasad. I now welcome Prasad to deliver his lecture.
Warm greetings to all of you from Chicago. My name is Dr. Prasad Gauruneni. SCFE is a favorite topic of mine. I practice both in Chicago and in Tirupati, India. The topic given to me was to discuss how SCFE evolved in the last few decades. What changed? A summary slide from me. The incidence in India has gone up, probably a combination of more awareness as well as increased obesity in India. We recognize that SCFE's natural history is not benign. Pain and functional limitations are common and they lead to arthritis. We understand impingement, and SCFE is a prototype for CAM impingement. We also understand that AVN is not iatrogenic. AVN is iatrogenic and not traumatic, even in most of the unstable slips. Newer techniques with oblique screw placement, surgery through safe surgical dislocation, and arthroscopy are making SCFE treatment more interesting and safer. This is a hospital I work in Chicago, Christ Hospital. This is the one in Tirupati. So SCFE, whether you call it the head slipping on the neck slips on the head, it causes anterior prominence of the neck, which causes a deformity clinically and radiographically. This bump in the front is the neck that changes the range of motion of the hip and causes pain and arthritis. The classification of slip changed a little bit. From acute and chronic type of slips, we evolved into stable and unstable, unstable being more at risk for AVN. The grading of slip has not changed much. We still rely on the Southwick slip angle, and still we ignore the translational deformity of the head, the native femoral version, and the skeletal morphology. So you measure the slip angle. Historically, SCFE was treated with spica cast, open bone peg epiphysiodesis, using multiple pins and using various types of osteotomies. People tried to correct slip deformity with multiple osteotomies for a long time. But unfortunately, the outcomes have been poor. So the Iowa study recommended that all grades and all types of slips should be treated with a single screw fixation to decrease the complication rate. We now understand that the natural history of slips is not as benign as the Iowa study suggests. SCFE leads to arthritis and functional problems. And perhaps the poor results from correction in older reports were probably technique related. Example of a 26-year-old cast technician in my hospital, no treatment for a mild SCFE, already has arthritis. 15-year-old had a screw fixation for a SCFE, has arthritis. The 19-year-old, look at all the osteophytes formed for a moderate slip. These are multiple osteotomies people have tried. Fish osteotomy here, base of the neck osteotomy, and Southwick osteotomy to correct the slip deformities. Done osteotomy was described a long time ago, where done shortened the neck to decrease AVN risk, the stretch in the vessels, and reduced it. The problem is the neck was shortened so much in some hips, they became unstable. One of the older osteotomies, base of the neck osteotomy from my university, you can see the deformity caused, secondary deformity, severa, breva, and still could not avoid arthritis. One of my cases early in my career, before I learned how to do surgical dislocation, very severe slip, some arthritis already in a 15-year-old girl. I did a Southwick osteotomy. Joint space improved because a different place of the head is being in the dome now. A lot of secondary deformity. The plate was long, but I followed the principles of deformity correction. So at the end, the joint was preserved for several years. The canal remodeled where the piriformis fossa lined up with the shaft. So it's not bad, but still not as good as doing the correction at the site of the deformity. Then FAI became more recognized, even in SCEPI. Multiple papers from almost 15 years ago described the damage patterns in SCEPI from FAI and found labral and acetabular damage even in mild slips. Mechanism where a prominent neck can impinge on the acetabular labrum, acetabular rim, and cause damage. Even after the so-called remodeling of the neck can still abrade the articular cartilage in the SCEPI. The SCEPI causes cartilage damage. Mild slip, causing labral damage. Here is how a slip can radiographically show the labral damage, pincer damage. Is a raw bone in a slip that can abrade the labrum and acetabular cartilage. That's how this is doing in a 10-year-old child. Damage is starting already. Significant synovitis is seen in most SCEPI hips if you arthroscope them and look inside. And this is a rare example of complete cartilage loss in the 19-year-old I showed earlier. So Dreman sign or obligatory axonal rotation deformity is a surrogate for impingement. If you have Dreman sign, that hip is impinging. And SCEPI leads to arthritis. I talked about this twice already. The so-called femoral neck remodeling happens at the expense of bearing the neck against the acetabular cartilage. That shouldn't be healthy. Gans recommended osteoplasty for milder slips and an osteotomy to correct the deformity in more severe slips. Is one of the severe slips in my practice, bilateral. This child couldn't even sit straight up. He had to cross his legs to be able to flex his hips even to the 60, 70 degrees. He has to use his hands to keep him up because he can't get to 90 to lock his back nicely. In flexion, he didn't even flex to 90 degrees yet. He still had a 70-degree axonal rotation deformity. So it will be functionally very difficult for this patient to do his daily activities. So the issues in SCEPI, the unstable slip cause severe pain, high risk of AVN, and there'll be a deformity. In a stable slip, there's a risk of progression, risk of becoming unstable, and there'll be a deformity. In a heel slip, it's just deformity. All these can have a deformity that can lead to arthritis, in addition to other problems. So Southwick slip angle is still being used, though we know that Southwick slip angle does not show the true degree of deformity because the deformity is an oblique plane deformity. Some people recommend a CT scan or a 3D CT model to look at the deformity well. Start looking at alpha angle. That's helpful to look at improvement with osteoplasty. But what I found is flexion internal rotation, FIR or IRIF at 90 degrees of flexion, is a good measure of the degree of impingement. If somebody has obligatory external rotation deformity, that means they don't have internal rotation, that hip is impinging, and based on the degree of deformity, you can grade the severity of the effect of the slip clinically. So mild slip has no deformity. They can internal rotate to up to 10 degrees. Moderate is less than 10 degrees internal rotation, but the morphology allows an osteoplasty to get to that 10-degree rotation. And anything more severe requires an osteotomy. Again, a mild slip, more than 10 degrees of rotation, no functional limitations usually. The toes are pointing straight, they have normal gait, good joint contact. Inside to pinning is all we need in a stable slip. The older techniques of putting a screw perpendicular to the growth plate physial plane is probably not a good idea because the screw itself can impinge. So we published a technique of putting an oblique screw. Fully threaded screw is ideal. Center in the head is ideal. But the screw does not have to be perpendicular to the physis. It will be very posterior as long as it's in the neck. Center of the head, close to the posterior cortex of the head, neck, lateral cortex of the proximal femur. 3 good fixation points, a 3-point fixation has less failure rate compared to this technique of perpendicular, where they're starting in a weak part of the bone, no buttress of the neck. This screw can allow further slippage to happen without much failure of the screw fixation itself. The moderate slips, these in addition to the screw fixation, will benefit from someone like osteoplasty to correct the deformity, get them back to non-impinging range of motion. So this is a bump here, obvious bump, 12-year-old female, 46-degree slip, so pretty significant slip. But the clinical deformity was only 20 degrees. So she probably has increased anteversion of the femur that's compensating for the slip. And all I need is 20 plus 10, 30-degree correction. This bump seems like it allows me about 40-degree correction. As you can see, if I take from here to here the bone, rotation to improve to 40 degrees. So that's what we did. With the bump down. This is a damage intraoperatively. I did this arthroscopically, so you can see all the damage from the bump rubbing against the cartilage. This is an immediate improvement in range of motion within the first week or two post-op. And this 5 years symmetrical range of motion compared to the opposite side. The severe slip, it's usually more than 50-degree slip angle. The clinical deformity is not amenable to correction with osteoplasty. The joint contact probably won't be adequate even if you can do a good osteoplasty. These are the ones who benefit from a realignment osteotomy. This patient operated in Mumbai. Looks like a mild slip on the AP, but look at this head being all the way back to the neck on the lateral. Clinically, this is the most maximal internal rotation you can achieve at 90 degrees of flexion. There's a 45-degree external rotation deformity. So this is a lateral decubitus position. His head is to the left and his left hip up. So head is to the right and his foot is to the left. I'm standing posterior, doing a trochanteric osteotomy. So elevate the trochanteric fragment with the muscles. This is capsulotomy. Here we're doing cutting the ligamentum teres to dislocate the hip. After dislocation, we're evaluating the head, and the head is moving on the neck, stating that it's loosely attached to the head. It's stable slip, but it's loose on the head. And here, we're developing the flap, cutting the anterior retinaculum sharply. So that's the anterior flap being elevated down the lesser trochanter. That's the posterior flap. The neck is being contoured by nibbling away the callus. Head is reduced under the neck and being fixed with a screw and a pin. This is after healing of the osteotomy with one screw and one pin. The head has healed nicely on the neck. Joint space is good. The trochanter is advanced for good abductor function. It has good offset in the front. And clinically, good range of motion, no impingement and no pain. So this procedure is not easy. A lot of surgeons had a lot of complications. But if I can do it, you can too. Learn it properly, and it will be a great operation for a severe slip. Thank you for listening.
Thank you very much, Dr. Prasad. That was a wonderful talk. Can I have a question for you?
Sure.
Yeah. I know you have a lot of experience in treating these conditions. Could you tell me in your practice, what is the incidence of AVN post-surgery?
Yes, great question. So there are three groups of scaphies we need to talk about. Can you listen to me? Can you hear me?
Yeah, very much. Go on.
All right. So there's stable slips.
Probably you should stop sharing screen. Then
am
we
I
can
sharing
see the pictures.
Well, I don't have anything to show you. It's midnight right now for me.
No. You can talk. Go on.
All right. So in the stable slips, I probably have about 60 stable slips with done osteotomies.
Right.
And I'm not aware of any AVN in the stable slips.
Right.
So the procedure itself is a safe operation if there is no additional risk factors.
Right.
But if you look at unstable slips,
right.
The unstable slips, inherently have an AVN rate regardless of what you do.
Right.
And I have an 8% AVN rate in unstable slips.
8%.
8%.
Yeah.
There, I mean, and I'm not sure of the procedure, but there is an inherent risk in unstable slips of AVN. Some people have 66% AVN rate.
Right.
Even in the lowest number is 5% for unstable slips in other series.
Right.
Now, coming to neck osteotomies, which is a little more severe.
Right.
My initial AVN rate in the first 2 cases was both were troublesome.
Right.
But after that, I don't have any AVNs. So the procedure itself is safe if it's learned properly and done properly.
Right. Okay. You said about Dunn's osteotomy. One more question because there are no questions in the chat box. I briefly worked for John Fixon and David Lightoller. We used to say Dunn osteotomy is never done. What do you think about it?
So the original Dunn osteotomy had some inherent problems.
Yeah.
They shortened the neck excessively because they could not dissect the posterior flap all the way down.
Right.
So, and the second thing is they did not have the option to tension the abductors after they had finished their osteotomy. So the shortening was too much and no abductor tension. So a lot of hips actually subluxated.
Right.
So the one I showed you, though I call it Dunn osteotomy, it's a modification by Reinhold Gans.
Right.
Where the hip is surgically dislocated first, and then you do the correction. So the neck shortening is minimized, and the trochanter is advanced. And I mean, you try to do other measures to prevent instability of the hip.
Right. Okay. Okay. Got it. Got it. Any questions, Dr. Pandian and Dr. Nali?
No, sir. No questions. I think
I can't see any in the chat box, so we can go ahead with the next talk.
Yes. Sending them.
You can invite the next speaker. Thank you.
I request Dr. Raghav to give his talk on early onset scoliosis.
Yeah, can we have the next speaker, Dr. Raghav Dutt, on early onset scoliosis?
Raghav is a spine surgeon and he has a vast experience on scoliosis surgery. I request him to give his talk on early onset scoliosis.
My talk today is on the constantly changing scenarios in early onset scoliosis. What I have done 10, 20 years ago and why I don't practice that method of treating children with early onset scoliosis. Early onset scoliosis by definition is scoliosis under the age of 10 years. This includes any type and every type of scoliosis. Scoliosis in children is a life-threatening condition. They have a shortened life expectancy. They have to undergo multiple surgeries in most instances. There's a huge psychological trauma to the parents as well as to the child and to the family during the course of management of these children. And above all, there is no consensus on the management of these children amongst scoliosis surgeons. Salari gave 11 different case scenarios to 17 extremely qualified scoliosis surgeons, and they all came with different treatment plans, and there was no perfect solution for the management of this complex problem. So what should be your strategy when a child comes like this with a concave fusion of the spine vertebrae? You can see that there are absent ribs and there is thoracic insufficiency. Whichever case comes to you, you should have a clear goal. You should make sure that the curve progression is not progressing at a relentless pace, or if you can, stop the curve progression. In some instances, reverse the curve. Make sure that there's a maximum growth for the spine, the thoracic cage, and the lung. Here is a child who came to me initially at the age of 7, and at 17, look at her. She's got a well-balanced spine, and she has a 26-degree curve. All we did in this situation was just to observe her. So, if you want to treat a patient with conservative treatment, all you need to do is to make sure that they have a balanced spine and you keep a regular follow-up. In the late 80s, we were all brought up on plaster casts, which were popularized by Risser in 1955, and Min Mehta at Royal National Orthopaedic Hospital, London, was the one who actually revolutionized the treatment of children with early onset scoliosis with her plaster techniques. And I was fortunate to be her student. In those days, with or without anesthesia, we used to place these children on fracture tables, on the plaster cast tables, Risser tables, and then we used to apply derotation, traction, and pressure at specified areas and give prepared molded casts and later on convert them into braces. However, in severe cases, these plaster casts would not help. We all know that. When I came back in 94, my patient population among scoliosis children, 75% of them were early onset scoliosis. In 75% of these patients, there was relentless progression of the curve. And we had a lot of patients with thoracic insufficiency syndrome, the worst of all of them. So I knew that some of these patients could not be managed on plaster casts. And because I was brought up on biconvex fusions in my training program in the Western world, I started doing the same. Now, what is biconvex fusion? Here we are fusing the convex side of the spine, both from the front and the back, with the hope that we arrest the growth on the convex side and with the hope that the concave side continues to grow. Here is a child I operated at the age of 18 months. I did a thoracotomy and did a convex fusion and turned her around and did a posterior spinal fusion on the convex side. And see what happened at the age of 7. She has got a shortened trunk, she's bent to one side, and this right hip is subluxating. And this is not good at all. And see the further progression of the curve. The spine has become like a concrete column. It is rigid, stiff, and cannot be bent. Another child, 2.5 years of age, again I did a thoracotomy, excised all the discs, and fused the thoracic spine via a thoracotomy on the front, turn her around. Now this is, you can see here, a case of diastomyomyelia. I excised the bony ridge and then did a convex fusion, biconvex fusion. At 4 years, she continued to progress and the curve got worse and worse. And at 8 years, she's completely off balance. And you can see that the thorax has failed to develop. And in those days, I had no choice but to fuse the spine, which I know was not correct looking back. Another child, she was on oxygen support, thoracic insufficiency syndrome, block fusions on the concave side, absent ribs, underdeveloped thorax. Again, as you can see here, a thoracotomy, that's the lung. I did excise the disc, fuse the spine from the front, turn her around, fuse the spine on the back. And you can see that in spite of that, she was progressing and to 78 degrees. And you can see her chest wall just not developing at all. And at the age of 6, she had an 87-degree curve. Clearly, this means that my biconvex fusions are not working and making the situation worse. We operated on 72 patients up to 2008, out of which 22 of these surgeries were biconvex fusions. 16 of these 22 patients, that's a high number, progressed and progressed. And the progression occurred before 8 years of age. I didn't know what to do. And I knew that this biconvex fusion was making the spine rigid and further correction was not possible without doing complex osteotomies. Perhaps I was making a softer spine into, as I said before, a concrete column. This is because most rapid period of spinal growth occurs in the first 5 years of life. Please remember that. When the spine increases 50% of its length during that time. Between 5 and 10 years, the spinal growth is slow. Fusion in a 5-year-old child can result in a 12.5 centimeter loss of spinal growth. So if I fuse the spine, I'm shortening the trunk of the child. And what is the effect on the lung? This is even worse. The greatest increase in the number of alveoli occurs in the first 2 years of life, and alveolar growth is complete max by 8 years of age. So early spinal fusion leads to stunted growth of the spine, inhibition of normal thoracic growth, and poor lung growth. That would lead to, as for example, a fusion performed less than 10 years had a mean FVC of 41% of normal at maturity, as compared to 68% of normal FVC in patients fused more than 10 years of age. So I had these children with biconvex fusions with stunted growth, compromised chest wall and lung function. When do they work? They also work sometimes biconvex fusions when I instrument them after biconvex fusion. So any secondary curvatures that progress can easily be handled by adding on the instrumentation at a later stage, like in this girl who had a pleasing result at the age of 19 with a good follow-up. So when does it not work? If there's unsegmented bar in thoracic insufficiency syndromes, 60-degree curves in children less than 8 years, and rapidly progressing curves. This is what I learned from my experience. So I thought that because some of these patients were not suitable for plastic arts, I would do growth modulation technologies. Here we do not fuse the spine. We put a couple of rods and stretch the spine on the concave side. Every 2 months we enter, we loosen this domino and jack the spine on the concave side open so that we slowly correct the deformity by jacking open the concave side. Here you can see this deformity got converted to 41 degrees. And as you can see here, another patient who had a curve like this, completely off balance. We put these rods, growth rods, and a very difficult curve could be nicely managed with these growth rods and held in that position by repeated stretching and lengthening of the spine. However, they have their own problems. Growth rods, if you use 3.5 millimeter rods, they break. And as you can see in this child, 80-degree curve, scoliosis with kyphosis, sorry. This was treated with a convex fusion, and then we put a plaster cast, and this all looked good, but a few years down the line, the hooks cut out. And then she started losing power in her lower limbs and losing bladder control. As you can see here, there's a pressure on her spinal cord, and there is the edema of the cord, so we had to get in immediately. We had to do a vertebral column resection, a combined resection, anterior, posterior, osteotomize the spine, correct the deformity. We had to restore the normal thoracic kyphosis to gradual lordosis, instrument the spine after decompression of the spinal cord, and she went on to have a very good result. She just joined medical college. So our own experience with growth rods, we had 27 of them whom we followed for 5 years. Wound breakage was present in 4 years, rod screw breakage in 9 out of 27 patients. So we realized that there are lots of problems with these growth rods, and even from the Western literature, there was a 44.5% complication rate. So again, it made me think. So from plaster cast to biconvex fusions to growth modulation technologies, I'm back to my plaster cast techniques. So today, most of these children, I put them in carefully molded casts, and this is done by spine surgeons, and then put them in braces, and we get good results. We try to hold these curves in these small children as far as possible, and once the child is of reasonable age, we go in and of course do an instrumented fusion after correction of the deformity. You see how this is how these plaster casts are made, and some of these the braces go onto top of the thorax of the trochanter to give appropriate pressure and correction and derotation, and this requires a lot of expertise and technique. And you see how this curve came back almost to a good correction at 6 years of age. Another child, see this, good correction with a well-molded cast, and then even in small children with kyphosis, we correct them and hold them till they grow to a reasonable age when we can proceed with surgeries. So back, life takes a full circle, plaster jackets, biconvex fusions, growth modulation technologies. I am back on plaster jackets, and these are giving excellent results. My advice is strategize, stop, analyze your results, look at your results, and proceed with your surgical care of patients with early onset scoliosis. I thank you for your patient hearing.
Thank you very much, Raghav. That was a wonderful talk. And as you know, Raghav is my partner. I go completely blind if I see any scoliosis case. All cases are done by him. And can I ask one question? Somebody put a question in the chat box that why are you wearing, some of us wearing masks when you are alone in the room? We are a group of people here. That's why you're wearing. If you are alone in a room, you don't have to. My question to Raghav, for a layman orthopedic, general orthopedic surgeon, what do you say? Two things which have changed in last 15 years. What they should watch for and what they should do for layman term.
See, the most important thing is that an orthopedic surgeon should not ever treat a scoliosis patient. That's fundamental. This is a too advanced specialty, and especially the pediatric deformity is a big subject by itself. Now, these children whom we were treating in plaster cast till they grew to an acceptable age, at least 6 to 8 years, suddenly we started doing all these surgical procedures. And then the literature, everywhere you go, everybody was presenting cases across the globe. And then when we did the same thing, we realized that this is just not working. And most of these conferences are not telling the truth. And when I confronted them, and when you study the literature, the complication rates are so high, especially thoracic insufficiency syndromes where the chest wall is not well developed, the lung is not well developed. They keep on going to intensive care units, they come out and the problems are just too many, financial as well as tremendous psychological stress. So what you need to do is what I do now is go back to my plaster techniques. Now we have 27 children under plasters and braces of all types of early onset scoliosis. Now the problem with Scoliosis Research Society is that they put every case of scoliosis as early onset scoliosis. And I have a problem with that because a juvenile scoliosis completely differs from a neuromuscular scoliosis, the way it behaves in children, which has a higher mortality and morbidity during surgical procedures. So I do my very best to hold these curves in plasters till they come to the age of 6, when I can use 4 to 4.5 rods and screws. So that gives me the advantage of these rods and screws not breaking often. And even the magic rods we started doing here, the magnetic control rods, where we don't have to open the spine and we can jack it up, they have a complication rate of 40%. So you can imagine that's an extremely high complication rate. So that's what I tell my Indian colleagues, that it's a good to be a bit backward, observe the failures of your colleagues, and then, always use your own experience rather than blindly following somebody doing these procedures and burning their fingers.
Yeah, thank you very much.
Yeah, Raghav, can I ask a question?
Sure.
I fully agree with your concept of delaying the surgery as much as possible. But don't you think it's going to make it more difficult? Like when you're going to take them a little more, even 2 to 3 years is quite a long period, and the progress of deformity can be sometimes faster. Such situations, don't you think you'll be finding it difficult to correct these deformities?
Yes.
And especially with the lot of advancements in the instrumentations nowadays, is it not possible to take them up a little more earlier, and we can be a little peaceful, no? Like we can assure a better correction if it's going to be addressed
Yeah,
early.
we did that. As I said, we followed up 27 patients with the growth rods, and almost every one of them with 3.5 millimeter rods in young children. We started doing them at the age 3 onwards, and a lot of them broke. And I showed you one which went on to paresis, loss of bladder control, bowel control. The problem, Dr. Nalivraj, is even if you put a growth rod, there is a spontaneous fusion.
Yeah.
Once there is a fusion, it's much more difficult to do an osteotomy. So it's far easier in my hands to do an osteotomy for a complex scoli at the age of 6 or 8, be it a vertebral resection or a PSO or whatever combinations that we do, vertebral osteotomies that we do, the 3 main ones. All that is much easier to do in a virgin spine than a surgery that was done on a biconvex fusion, which is bad in itself. And I completely stopped doing them because they almost all of them had stunted growth. And that was what we were brought up in the 80s, early 80s, and we did these procedures right, left, and center. So today I would certainly use growth rods, but my enthusiasm for growth rods has diminished till at least they can accept 4 or 4.5 millimeter screws. As I said, 27 patients following up for 5 years is a good follow-up. Even if you look at international papers, most of them have 25 to 30 patients followed up for 5, 6 years. So our own results and complications are matching with international complications. So I think any complication rate more than 30% is not good at all. So yes, I use growth rods. I use them today. Even now, but I'm back into plaster jackets, spending time on these jackets, allowing secondary correction of secondary curves, and perhaps either do a definitive fusion or do an osteotomy. That's my change in my thinking.
I think I fully agree with you. I think the experience actually speaks. And it's good that you've learned the art of applying cast offs. That's one more important thing. The younger orthopedic surgeons nowadays do not have that learning on the application of cast. I think that is one thing which has to be learned. And I fully agree with you. Or I think the experience speaks really. Are there any other questions then? The chat box doesn't show any.
No questions in the chat box.
Yeah, if that be the case, we'll go to the next topic. Thank you,
Yeah.
Dr. Raghav.
Thank you.
Yeah. The next is, can I invite Dr. Terence Jose Jerome to deliver his lecture on Volkmann's ischemic contracture?
And don't get used to that. That's
Yes.
what I'm trying to do. Yeah, example, రాయకుండా ఒక వేసుకోవచ్చు.
It's working now.
Good morning. Thank you, Professor Reddy and the entire scientific team of the YRCCon, who has given me a very challenging and at the same time a lot of controversial aspect where we need to focus on. I know it will have a lot of criticism and concept and also a lot of controversies on this concept. Briefly, what I'm going to speak about is the Volkmann ischemic contracture, the paradigm shift, what I do now, which I was not doing 20 years back. I always aspire this famous verses by Winston Churchill, who said, to improve is to change. To be perfect is to change very often. We need to keep updating ourselves and change, especially in this field of medicine. Rational, scientific, and more reliable on the current aspects. So this is one topic which I thought we would share about the changes which happened in the recent years. What we have been taught during these days is a presentation of this girl, 7 years old, who came following a fall, treated with a local bandage, oil bandage, and then who came 12 hours post-injury, no movement. What we would have done initially, what we believed, and what was the treatment, say 20 years down the line. Let's have this slide in your mind. The common understanding was that, as Volkmann clinically said, that it's an emergency. If you don't treat it early, it may cause irreversible muscle or nerve damage. It will affect limb and also the life. He also said that supracondylar humerus in the femoral shaft fracture are the most common precipitating injuries. We do agree with that. The current concept is that we fix the all displaced supracondylar fractures with close reduction, percutaneous fixation. We are not worried about that, and it is not a precipitating factor for a compartment syndrome. Associated brachial artery injuries can be repaired. The most commonly believed perception about compartment syndrome, especially acute, is the timing of intervention. We all believe that 4 hours of ischemia will cause muscle necrosis. Heckman also said that if it is 8 hours, you'll have permanent nerve damage. And as long as we do early decompression, there's a possibility that the limb will not go into paralysis or contraction. Beyond that, there is a definite permanent damage. What we also believed and followed is that if there is more than 8 hours delay and the patient presents with more than 8 hours, because why 8 hours? The review articles and all literature clearly says that 8 hours is the critical time where both muscles and the nerve, they go into irreversible permanent damage. That's the reason why we fixed 8 hours as the criteria. So beyond 8 hours, what we did, we observed it. We did not do any surgery. We also very confident that prolonged ischemia will never reverse the muscle and the nerve damage. Have you ever thought even once, does the exact time of onset of compartment syndrome is what we think? Is unknown. And the time of diagnosis we do at the time of diagnosis is not the time where the compartment syndrome starts. Then how are you sure that only 8 hours or 6 hours or 4 hours is the reason beyond which we should not do? Or are we sure that the onset of compartment syndrome has really started? No. And we also believe that, if you do a compartment release more than 24 hours, there's a high probability that wound will get infected. And there's high morbidity because of septicemia infection. The outcome is very poor, as shown by these authors in 1986 by Rees and 1976 by Sheridan. So let us come back to this slide. So what we could have done 20 years back, we could have we did not. We won't operate on them. We put them on antibiotics. We ourselves are convinced to say that there is no scope in restoration or improvement of vascularity by decompression. We always relied on collateral circulation, which is obviously is not true, which we are going to see in the coming slides. This child would have either developed a permanent contracture of varying intensity. It can be either a mild, as described by Suge, or a moderate or a severe with all compartment involved with median nerve and ulnar nerve ischemia. So this is one picture which I've shown because of late presentations. Irreversible motor damage, severe shortening, contractures, sensory hypoesthesia, wasting with all deformities. There are a few surgeries which we do still follow even currently, and those are the surgery cases which I'm going to deal with. If you have mild contractures, muscle sliding operations as described by Max Page does play a major role. So we have this patient who had mild contracture to have this functional outcome. Moderate cases, this is one girl whom had this sort of deformity in the right upper limb. This was the movement which is in the wrist and also in the fingers, the jog off movement. What we did is, because we did extensive neurolysis and adequate decompression, even at the time she presented very late to us with this deformity, we found the nerves are very thin and hypovascular. We did an extensive neurolysis, and what we found was the segmental, we call as the sigmoid shaped infarct of the deeper flexor muscles. And we also found that because of the long duration of this contracture, the muscles get and the tendons get adhered to the underlying bone because of fibrosis and long duration. So this was the surgery what we do is FDS to FDP transfer to get this functional outcome. In severe cases which I've shown, this is a girl who had who has been left untreated because of delay, and this was the presentation. There is no treatment, left untreated, the muscle develops into atrophy and all these deformities, contractures, shortening, and associated with poor sensory recovery in this patient. This patient also had this deformity, and we need to flex the MCP joint to get the IP joint extension because of severe contraction. So what we did an extensive surgery. We did the four-tailed ECRL transfer to the finger extension, and we did the EIP transfer for the abduction, and also in addition to that, we did a nerve we did nerve graft because the nerve was completely adhered, fibrosed and densed in the adhesions. We did a nerve graft in this patient to get this functional range of movement in this patient. So these contractures are because of sequelae of compartment syndrome left untreated, or what we say is observed because they have delay in presentation. What made us to rethink? This one article by Sundar Raj in 1985, he found that in 196 patients whom he had followed the patients with circular compartment syndrome. They found 59% of them are because of the bone sector causing forearm, going into compartment syndrome. There were no treatment. They did not treat these patients. Even there is a delay. No treatment, no recovery. Interestingly, they found sensory recovery was good. Even despite this ischemic degeneration, the recovery is good. They concluded that sensory nerves can recover and degenerate over a course of time, which they found in 12 months for the hand. So the more intriguing fact is that they did not treat, no recovery, then sensory recovered. There is something which we are really missing. The one aspect which is discussed in 1951 by Hahn, he said that even a small muscle fiber can survive ischemic episode, can regenerate. That too up to 76 weeks of injury. We have missed this point. So we have missed this, and we believe that more than 8 hours and more than 4 hours, we do not operate, we observe it. So what we had a hypothesis is, we do not know how the nerve is going to recover, but there is definitely a guarantee that some sensory nerve recovery occurs, but what is the pattern of motor recovery and how does it occur? You go through all the case presentations. One patient who had a fall, who had pain, initially severe pain, swelling, and then finally deficit. He came to us 6 days, no movement, no sensory, no sensation in the hand. This is the X-ray of this fracture of the proximal ulna. We did an extensive neurolysis. We did a fasciotomy, decompressed it, and this was the intraoperative picture. Surprisingly, the recovery was initial claw hand, combined claw hand at 12 weeks. We did not know that the motor can recover. There's no literature to say that motor will recover if there's a delay. 6 days down the line, we could observe it, wait for the deformity, contracture, paralysis to set, and then operate to have, I say, a fair outcome. Those are the 3 surgeries which have shown have only a fair outcome. But then this is surprising and welcoming a motor recovery at 12 weeks. So this was the combined claw hand involving the median and the ulnar nerve. He had a good wrist extension. The wound had a superficial skin necrosis, which also healed well. What we found was at full motor recovery at 7.5 months and sensory recovery at 12 to 13 months. This is one case which completely changed our the thinking of observe, wait for contracture, operate, and then have a fair outcome, or do a decompression, do adequate decompression. Let the nerves or the muscles regenerate with the capacity, with the available capacity, and also the sensory recovery. So this is the functional outcome of this patient at the final follow-up. So both are equally normal. We do not have any deficit. We don't have any contraction, no shortening, no deformity. The other case is that he had a fall at 24 to 48 hours. He came to us and no movement, no sensation, supracondylar fracture. What we found was the brachial artery was completely injured. We did the brachial artery repair, and then we did a extensive repair and analysis of this patient. And this was the follow-up. We knew that the wound will go for healing problem, where there was a healing problem with this patient. This was the initial moment of the patient. There is some flickering happening because of the extensor acting. No median, no ulnar nerve, initial phase. And this was the X-ray. At 1.5 months, what we could get is this moment. There's a combined claw hand, which is happening at 1.5 months. And then by around the follow-up, subsequent follow-up, he had developed slowly the outcome was favorable because the motor and the sensory was improving. Median was completely improving in this patient in the subsequent follow-up. So at 5 months down the line, it's completely had a complete normal recovery of the median nerve with good opposition and finger flexion and movement in this involved upper limb. So this are all the factors which motivated us to allow the nerves and the muscle to decompress because of the initial surgery, which we did, even there's a delay, gradual delay. This was a follow-up X-ray. There's one more child which I need to present is that this is one child who came to us 2 weeks post-injury. The surgery was done outside for the closed supracondylar humerus fracture. 2 weeks down the line, no sensation, no movement on the right upper limb. So what we found is we did an extensive decompression. We found that infection was a reason for this compartment syndrome. We also found that the cavity was impinging partially through the ulnar nerve in this patient and had a infection in the arm and also in the forearm. We did an extensive debridement, reworked the K-wire, and then we also found that the wound might go for a superficial necrosis, which obviously had, and we put them on nerve stimulation in the follow-up. This was the initial the movement, which appreciated at around 12 weeks down the line. And this was the final follow-up where the patient also had a recent recovery. So this is complete follow-up, and our study is published in the BMJ group of Journal of Pediatric Surgery, where we analyzed the pattern of nerve recovery, motor and sensory in 24 patients in acute compartment syndrome. One patient, almost we had 2 weeks down the line, we had a good recovery to say M3 at the final follow-up, and we are still following. Rather, he also had a good sensory recovery. Had been left untreated, we are very sure that he would have definitely had a severe contracture, and following severe contracture, the surgery would not be that much good to have a reasonable or a fair functional outcome. So what was the aspect which changed is that people have realized from 1990 that the time injury to treatment may not be too restricted to 6 hours or 8 hours. Even Royal in 1990 found that 42.5 hours of injury, surgery and injury time, he had 67% recovery. Donald Bay has found that 91% recovery even at 30.5 hours delay. What we found was in a patient 24 patients of series with a follow-up of 67.3 months, we found that the average of 44 hours a delay of 44 hours ranging from 5 hours to 8 days had 91% of patients had a good recovery, except one who did not have recovery because he came completely late, and even after that doing a decompression, he had M3 recovery and S3 sensory recovery. So motor recovery is there. Even there's untreated or delay more than 8 days in our series. Pain is very important. It's significant because it definitely indicates that there is an ongoing neurological and muscle recovery. Most of the injuries are high energy injuries causing compartment syndrome. What we really found was very interesting. Age or mode of injury or etiology does not have any impact on income. But what is really affecting the outcome is the significant delay of more than 24 hours definitely had an impact on the outcome. So the paradigm shift is that the radial, median, and the ulnar nerve recovery is there. It is very much there, and it takes almost 7.5 and 8.5 months respectively. Sensory recovery is very good. It takes 10 months for the forearm and 13 months for the hand. So to conclude, there's definitely a motor and sensory recovery in patients who underwent surgical decompressions and acute compartment syndrome, irrespective of delay and various etiology. What was thought is that motor and nerve fibers cannot regenerate. Now, what we believe and document is that motor and nerve fibers regenerate after ischemic sequelae of compartment syndrome if treated. Thank you very much. We'll have a lot of questions. Thank you.
Thank you, Terence. I think that's a wonderful talk. That's a big controversy, the timing of surgery in a compartment syndrome. Now you have totally changed the way we think. I think probably every one of us need to try out the delayed decompression, and probably we'll have to see how it works out. Your experience shows the results are good. Hopefully, we all should do and combine and see whether it really works. So, Nali sir, any comments and questions? Sir?
Yes, sir. Yes, sir. I think that's a very good presentation, Terence. I still remember in 2000, TNOA Con at Chennai, we had a same paper, like the determining the time delay and the recovery pattern. And we had again showed the same thing, like there need not be a strict time criterion which can be applied as far as decompression is concerned. Because you can see, imagine, in government hospitals, you always get these patients coming late to the hospitals with no movement or no sensation in the limbs. And we have the same findings. I think it's a very good eye-opener for the younger orthopedic surgeons who are watching this program. And now my questions are, does the muscle regeneration, the nerve recovery, differs in the younger individuals as compared to the adults? Because most of the cases you shown were children. Now, did you find any difference in the recovery pattern, whether it is better recovery children as compared to that of the adults?
Thank you, sir. It's a nice question. Basically, our study involved acute compartment syndrome in the upper limb, especially in children. We are working with the adults, and we have few patients who had acute brachial artery injury, subsequent compartment syndrome. We went and did the nerve, the artery repair, and then we did a compartment release. They are doing well. It is too early to comment on the pathophysiology and the recovery pattern in the adult unless we have a solid outcome and the functional outcome, which we are definitely will come up in the few years to come. As you said, as you rightly pointed out, this fact that acute compartment syndrome, because of delay, should not be the one reason this patient should not get deferred for the treatment. This message has to be spread across the younger generation, whom believed or whom followed the principles which are given in textbooks. We are not there to blame anything there, because we are keeping updating ourselves, and we need to change to the current concept, believing that nerves and muscle will regenerate when there's there's a possibility given, especially by giving surgical decompression and adequate neurolysis. This has to be completely given to the younger generations. As you rightly mentioned, that we need to focus on the difference between the pattern of recovery in the pediatrics and the adult population. As I've also mentioned in the slide, that the pathophysiology and the recovery pattern is completely different from the child and the adult. We are yet to have a comparative study between the adult and the pediatric population. We will definitely have in the future to come.
Yeah. So like the paper I mentioned in 2000, I think it was more of adults only. We were just did the work only in adults, and there too we had very good results. Now one more question is, I don't know whether you can apply this to children. We are going to use the drug therapy also. Like there are a lot of improvements in drug therapy to open up the collaterals as well as the blood thinners we can use. Is this also going to have some effect on the recovery?
Frankly speaking,
probably have you applied all these things in children also?
I haven't applied, sir. I do
Yeah,
not.
in adults, that's what in even 2000 itself we are discussing, that could be one of the factors which can help us in recovery, even if it's going to be delayed decompression.
I haven't tried that.
Yeah. Okay, one more thing. I just saw in the third case, you had gone for closure of the wound there. Do you close them after fasciotomy?
This was actually it was a dilemma before operating. To operate, not to operate, to intervene, or to keep the wound open or left partially closed, or keep the wound primarily closed. It was a tough decision. I completely take your point. It was a tough decision because the child came to us at 2 weeks down the line. Routinely, for any other orthopedic surgeon, they would have definitely have deferred the surgery, because 2 weeks down the line, the fractures are there. The possibility of compartment syndrome going into a complete, ischemic degeneration would have been possibly taken more time. So what made us or made me to think is, what are we going to gain by doing observation, and what are we going to gain from doing a decompression and allow the muscle to regenerate and the nerve to come back or get back away from the ischemia? There's a high possibility that the nerves and the muscles will regenerate when you do adequate neurolysis and decompression. One thing was worrying was the infection. As I rightly mentioned, people are scared about infection. 2 weeks down the line, you operate, you get infected. But what happened was there was an infection inside the compartment. Because I don't say that because of the previous surgery, the factors are moving towards the previous surgery causing some sort of infections. When we opened it, we found that the supracondylar area was completely surrounded by unhealthy, and even we had some discharge around the supracondylar humerus. Meaning to say that the infection has maybe the triggering event for the compartment syndrome, or could have caused, at the time of surgery or post-surgery, causing a compartment syndrome. That also needs to be dealt with. Surgery was done because those are the factors which really convinced us that surgery in these children especially will have a recovery. So we went and did it. After late, we also realized that closing the wound primarily will always have superficial skin necrosis or skin failure. So what we also analyzed, that we used to do a purse string suture, or we used to do a secondary loop, partially close the wound, or even we
लाइव चैट के वास्ते फोटो नहीं आ रहा मेरा.
You can approximate the wound and just put 1 or 2 stitches around the corner. It's just like the incision start from the wrist, goes to the ulnar side, because these are the area where the muscle.
जरा आके बता दो बेटा. Hello.
Put 1 or 2 stitches there. Have a look at secondary, look at 2 to 3 days, and then you decide whether you're going for primary suture or skin grafting. We have moved from primary closure to secondary closure, secondary primary closure, and also we applied skin grafts for patients where the skin was completely necrosed or damaged because of the injury. So there is no strict protocol or strict rule that you need to primarily close. Things have completely moved. Even we have moved from primary closure to delayed closure and applying skin graft. It's all basically depends upon how you feel intraoperatively. For a few cases where we did brachial repair, we did the fasciotomy, but the fasciotomy, like we have a deferred fasciotomy now, these children also, because once we did a artery repair, we didn't find any compartment developing in the forearm. We are not exactly, what happens at the brachial artery. Definitely, we are also beyond our imaginations. It's something like we feel on the theater, the compartment on the forearm, or the forearm, how is supple or more tight or whatever. So these are things which we decide on the intraoperative table. So there is no strict criteria that we should go and primarily close it. We have moved from primary closure to secondary closure and then skin grafts in patients.
Okay, thank you, Terence. I think we're running short of time now.
Can I ask a small question, Dr. Ved Prakash? I'm unable to get
Yes.
my picture there.
Yes, sir. Yes, sir.
What about in very late cases when they have got severe deformity, use of gradual distraction with a Walkman splint? It has worked many times in my hand. Have you tried that? Slow distraction in that position in which you find the claw hand. Have you had any experience in the late cases?
I don't have the experience with the fixator, sir, because what we are doing in cases where who had severe contractions, we put them on splints. We put them on the flexor outrigger splint and extension outrigger splints. Put them on daily therapy. They'll come to us daily. What we can do is get them the stiff joints to a reasonable supple joint, so that all tendon transfer can be advantageous when you do in those patients. I don't have any experience with the fixator.
Yes, I have a series of about, not many, but about 6 cases. All of them seem to recover fair amount of movement, even in late cases. You can use a Walkman splint type of, but the hand part is different from the forearm part, and you put some kind of jack in between on the volar surface.
Yes.
We'll go to the next session, sir. I think
Yes,
we're running a
thank you,
short
sir.
of
Yeah.
time. So thanks,
Yeah.
Terence. Nalli, sir, next speaker.
Yes, sir. Can we, may I now invite Dr. Ajit Kumar to deliver a lecture on Mayer's muscle particle graft and hip fractures.
Good morning. I'm extremely grateful to the scientific committee of OSIS 2020 and to our president, incoming president, Dr. Raghav Dutt, for giving me this opportunity to be part of this scientific endeavor. My topic today is why Mayer's muscle pedicle bone grafting procedure has fallen out of favor in this day and age. As we all know, non-union of fracture neck of femur is a fairly common condition, and it has been so for ages. And probably now with the high-speed lifestyle, the incidence has become all the more acute. And it is a challenge to address this daunting problem. Coming to the options of managing this problem of a non-union neck, the earliest reported cases were like the Femista bone grafting, corticocancellous bone graft, open bone grafting was done. Subsequently, due to the problems of avian in that particular procedure, various muscle pedicle bone grafting techniques were in vogue. And later, the cortical stud grafting of fibula was performed. Some groups of surgeons also published on vascularized fibula graft. In the late 80s, the valgus osteotomy came into existence. And of course, we do have the option of hemiarthroplasty and total hip as well in the given scenario. The earliest procedures of open bone grafting had issues with the increased incidence of avascular necrosis, and failures. And in those days, when fixation devices were of primitive designs, a lot of failures did happen in spite of this procedure. And so various muscle pedicle bone grafting procedures were thought about. The first was Stuck and Hinchy in 1944, who used the vastus lateralis bone graft. It was Judet actually in 1962 who first published about quadratus femoris muscle pedicle graft. However, his series was very small, and it was the work of Mayer from USA who refined this technique and published a large series with very good early results. And it gained worldwide acceptance as not many other procedures or options were available at that point in time. And it became a very common procedure even in our country, and all the senior surgeons of our country during that period were advocacies of this particular procedure. The problem is with this procedure is that it is done in the prone position. So the patient has to be positioned prone on the fracture table. Um, some people even did it without the fracture table, without the imaging, because you can directly visualize the fracture site. However, in the second dimension, you do tend to get certain angular deformities. The disadvantages of prone positioning are that it takes time to set up the patient. The genital care was also a problem in male patients. And of course, most of us are not familiar with the posterior prone positioning, and hence getting used to the anatomy or the orientation itself is a problem. Many surgeons perform this procedure in the lateral position, and Dr. Tanna was one such surgeon who published his case series. However, we did have problems with lateral imaging, and also if you did not pay attention to detail, then you would have imperfect reduction and failure of union in this particular position. Most of these patients have been non-weight bearing for a long time, and hence there is disuse osteopenia, and hence there is a risk of graft breakage. Large gaps need corticocancellous graft from the iliac crest, and hence subtrochanteric fractures were reported in a few series. However, the biggest disadvantage that was still persisting, whether it was open bone grafting or even muscle pedicle grafting, was the incidence of AVN, avascular necrosis, still persisted. This is the trough that is created in the head and neck to position the graft that is sourced from the insertion of the quadratus femoris. It is about the size of 4 centimeters in length, 2 centimeters in depth, and 1 centimeter in width. So you need a slot of that size to accept the graft. And here's one of our cases where the reduction was not appropriate, and hence there was shortening of the neck of femur, and this patient would have persistent limp even if he did unite. A few quick cases. This was a fibrous dysplasia with non-union, did the muscle pedicle bone graft, and he went on to uneventful healing. Here's a young lady who had osteomalacia, insufficiency fracture with non-union. There was a huge gap, and we had to also use iliac crest in addition to muscle pedicle. But because instead of using a DHS, cancellous screws were used, she went on to have a severe coxa vara, which I had to correct with a valgus osteotomy. This was a delayed presentation from the Gulf, comminuted neck fracture, as you can see here. And he also united, but went on to have AVN at about 2 years post-op. Here's another case of AVN with the same procedure. So, and this is a case borrowed from Dr. Sharath Rao, just to show that AVN did occur even in his hands. Okay, and eventually it has to be salvaged by a total hip arthroplasty. This is one case I borrowed from Dr. Manjunath Dargad from SDM Dharwad. one of the few surgeons in Karnataka who is still continuing to do this procedure on and off. And this was the only report I found done in a child, in an immature skeleton. And although he did have avian, he reformed to some extent, and it doesn't have major issues with the hip. Around this time in the late 80s, René Marty from Netherlands published his large series on valgus osteotomy, and he did it even in patients who had changes of avascular necrosis. And post-union, this avascular necrosis did not progress, and these patients did well for long periods of time. And I think only 3 out of his 14 cases of AVN needed a total hip replacement. So this procedure became very popular, and it's widely practiced. And Dr. Magoo from Rohtak was one of the surgeons who popularized it in our country. And now it is done right across the country in almost all the centers. So just briefly, you may or may not do an MRI, depends, because in a young individual, even if there is avascular changes, you still need to retain the head. That is the technique, 20 to 30 degrees of wedge that you need to take and correct it. You can fix it with an angle blade plate or even a DHS, whichever suits you. This is a slightly modified technique to prevent the incidence or minimize the chances of avascular necrosis with this particular technique. So this is an example of a 32-year-old man who underwent internal fixation for neck femur fracture about 6 months ago, and he had continued to have pain and limp. So it was a clear-cut case of non-union, and this was treated with a valgus intertrochanteric osteotomy, and he went on to do well at this particular stage with a good function, with almost normal function of his hip. This is yet another example of a young 19-year-old boy with a missed fracture neck of femur. He could weight bear, and we had some doubts whether it was a malunited fracture, but a CT scan revealed that it was indeed a clear-cut case of non-union. And the MRI did show some changes of early avian in this particular patient, but in such a young individual, you have no other option other than to salvage the hip. And he also underwent a valgus intertrochanteric osteotomy and went to heal very well. And he had excellent function. And although there is some changes of avian here, he has no. So the advantages of a valgus osteotomy are that you can straight away start partial weight bearing. There is no need for a bone graft here. And most important is any rotational or angular deformities can be corrected during the procedure itself. And you can achieve some amount of leg length with the corrective valgus osteotomy. With a valgus osteotomy, you do have certain problems with this particular procedure, and some distortion of the anatomy, some changes in the femoral offset which may persist with the limb, and if you do too much of valgus, they may have a avascular necrosis as well. So my take-home message is the reason why I will not perform Mayer's muscle pedicle bone grafting in this day and age is that it has its problems with positioning, with inability to visualize the site properly with imaging, difficulty in harvesting or problems with harvesting the graft, post-op rehabilitation, prolonged post-op rehabilitation is an issue, and avascular necrosis still persists in spite of using a pedicle graft. And the advantages with the valgus osteotomy is it is a very easy procedure, and even a junior surgeon, well-trained junior surgeon can perform it. There is a much less learning curve here, and you get consistently good results and excellent functional outcome in this particular procedure. Thank you very much for your attention. Well,
Professor Pandian, can I ask Ajit a question?
Yes, KJ, you can.
Hi, Ajay, that was a wonderful talk, my good friend.
Thank you.
As you know, most of the orthoplasty surgeons have moved away from osteotomy of the proximal femur
Right.
for obvious reason, because if you want to do a THR later on, it would be difficult one. What is your advice? What precautions we should take, people who have undergone, especially valgus osteotomy, what are the things we should look out when we are doing a total hip for those people?
I think the most important thing is that the distal shaft should not be medialized. That's where you have problems in your alignment or doing your broaching for your THR. So if the shaft has been medialized, invariably there'll be a need to do a corrective osteotomy or osteotomy prior to doing a THR, and that will compromise your outcomes probably. But if you see most of the X-rays that I put up, and including Dr. Maghu's articles, if you follow, the alignment is perfect both in the AP and lateral views, and it is in line with the axis of the femoral canal, the ultimate healing. So there should be no issues at all in performing a total hip at a later stage.
But they should be familiar. I mean, they should get a good anatomy of the proximal femur we're planning for, because we have to have more modularity, because most of the time neck is straight and may need different types of offsets available on the table.
Sure. Yeah, sure. I think if you're planning a THR, you need to have those things ready. But in a well-performed valgus osteotomy, I don't think the anatomy gets distorted so much.
Right.
The offset may be an issue because the trochanter is distalized, the greater trochanter is distalized. So that you may need to think about, but the broaching and getting your stem inside should not be a major issue there.
Thank you. As no question, can I have one more question? What is the incidence of avian in valgus osteotomy?
Yeah, I mean, most of the people think that the incidence of avian has already occurred at the time of the original injury.
Right.
Whether the surgery itself contributes to that, we don't know. The reason why muscle pedicle came into vogue is the concept that even with avian, the muscle pedicle will help in the healing of the avian.
Right.
But big series have not proven that that to be so. And even in our case, so many cases that I showed, at least 3 or 4 of them had avian in spite of muscle pedicle.
Right.
But in the series that we have about 10 or 12 cases of valgus osteotomy for non-union necks. The young boy that I showed, pre-op itself, he had avian.
Right.
But so far, he is doing well. He has not progressed. And Rennie Marty's article, the 1989 paper, they followed it up, and Raymakers republished it. I think even in IJO, they republished it, the long-term follow-up.
Right.
And the progression has been very, very slow. And it's only in the late 50s and 60s that they opted for THR. In spite of some deformity, I mean, changes in the articular surface and early arthritis, functionally they were fine. And our patients would be even more tolerant to the discomfort, I would think.
Right. Thank you.
I'm sure Professor Ved Prakash will have something to ask.
Okay, we shall go to the next paper.
Okay, thank you.
Thank you, Ajit.
Thank you.
I call Dr. Sharath Rao, former YSS president, to give his talk on proximal tibial fractures.
Thank you very much for the opportunity. What I'm going to do is take out one of my presentations in 2005 in one of the conferences about Shachkar type 5 and 6, then and now, and give that presentation for half the time, and for the next half, do the presentation of what we had given pre-COVID 7 months back. Shachkar type 5 and 6, how we manage. That was a talk in 2005. Always look at skin and soft tissue status. Take Apart from AP and lateral view, take traction films, oblique views, CT scan if available. And we understood the tibial condyle type 5 as bicondylar and type 6 with the dissociation from metaphysis, and the incidence being 3% and 20%. So we used to call it intercondylar, where intercondylar eminence is also broken from the metaphysis. The treatment at that time was lateral plate, what to do on the medial side, screw or X-fix. These were the examples given at that time. 30 years male, RTA, no comorbidity, isolated fracture. We didn't understand much about this particular fracture at that time. Put a lateral plate, locking screw had just arrived in 2005, and put an X-fix involving the femur above and down. After some time, once a little bit of healing starts, take out the X-fix, start mobilizing the knee, and then get this. What happened? We looked at these patients. That was our presentation at that time. Looked at that patients 2 years down the line, this happened. 4 years down the line, this is the X-ray. 7 years down the line, and this is after implant. Very painful knee in a 43-year-old patient. Not acceptable. 34-year-old male, RTA, no comorbidity, isolated fracture. That was the example given at that time. CT scan, we didn't know how to actually look at the CT scan at that time. Just CT scan was available, it was taken, treatment same, lateral plate. We are confident now that we can just put a medial X-fix only involving the tibia, not to go to the femur. Look at what that screw, locking screw is doing. It's actually pushing that fragment out. So that's the situation. And then bone grafting, X-fix removal, and this is what happened. And very happy to show the knee movement at that time, 2005. And this is what happened to him after 5 to 6 years. Knee is arthritic. 38-year-old male fell from a tree. This was the X-ray shown at that time. Lateral plate, medial X-fix. We did not understand about the medial fragment at that time much. Put the X-fix, and this is what happened. And then clear signs of arthritis 7 years later. And then had a patella fracture because of the stiffness of the knee. Had to undergo fixation of the patella fracture. And this is the status of his knee 8 years later. 44-year-old male, RTA, lateral plate, medial X-fix, removed. This is the X-ray shown at that time. And this is what exactly happened to him. Look at his left knee and right knee 8 years down the line. So what were we doing were not justified or not correct. Another example where there is a lateral plate, so medial screw, more confident from external fixator to a medial screw. This is the X-ray down the line. Another example. So then slowly ventured onto the medial side by putting a plate. So lateral screw and a medial plate in a previously fractured tibia. United. When underwent implant removal, now waiting for total knee. Knee is already arthritic. Shattered proximal portion. Okay, we'll put both two plates, one on the lateral side, one on the medial side. Happy to show this movement, and then this is down the line. Look at the left side X-ray and left side knee and the right side knee, already arthritic. And then we thought, why medial plate? Let us go posteromedially. And that was the first time we observed that yes, posteromedial is a better place. And this is X-ray after 10 years of this fixation. and the posterior medial fragment has been identified and then fixed. So these were the fates of some of our medial plates at that time. So the end of that lecture in 2005, this was mentioned as future. When to use lateral and medial plates? What is the exact location of the plates? When is a single screw sufficient on the medial side? What is the indication for a medial X-fix? And these were the dilemmas in front of us in 2005. What happened 15 years down the line? Recent advances in tibial plateau fracture. Now we know every patient, because it's a high energy injury, it's soft tissue involvement, there are skin blebs of different types. You need a joint spanning external fixator. Your strategy of treatment is span, scan, and plan. High energy tibial plateau fractures can be closed, open, or with compartment syndrome. When they are open, irrigate and debride. When they have compartment syndrome, especially when you have a large medial fragment, fasciotomy, all of them will undergo spanning X-fix. And once you develop stable soft tissue envelope, then go in for surgery. You get a CT scan in every patient, analyze the fragments, analyze the depression, and then accordingly select your approach. So you have a 3-column fractures, anteromedial, anterolateral, and posterior. Posterior is again divided into posterolateral and posteromedial. There is intercondylar eminence, and you have tibial tubercle. Approaches have changed. Posteromedial reversal, posterior S-shaped, posterolateral transfibular, posterolateral reversal, or Frosch double approach. We are all familiar with these approaches now. A type of fracture like this in 2020. You will approach the fragment directly from the posterior side, elevate it, put a plate on the posterior side. You get a good articular surface. You find 2, 3, 4 plates in a patient with these types of fractures. You divide them into articular fracture, rim fracture, and column fractures. Address them separately. The articular fractures, the amount of depression, the rim which is injured. You go fragment specific as far as approach is concerned and treatment. All these are the recent X-rays. Take a CT scan, plan your surgery accordingly. Perfect articular surface reconstruction, and you get good movement. Also, we started looking at ligament, tendons, and meniscus. Whenever you have a displacement like this, it is understood that there must be a lot of ligament damage. Examination under anesthesia before you start your surgery. With a lateral condyle fracture like this, you see the medial opening. It is likely that the medial collateral is injured. So you change your plan of treatment. You elevate the lateral side. You buttress that lateral side with a plate, raft screws, then a supporting plate. Once you have done that, elevated the articular fragment, fix the medial collateral ligament, which has been avulsed from the femur. And we have treated the bone, the articular cartilage, the rim, the defect, and the ligament. And the results are always satisfactory. Look for soft tissue injuries, especially lateral collateral ligament injury in these type of cases where the lateral condyle will rupture collateral ligament, which has to be fixed back into the fibular head with a wire or screws along with your fixation of the tibial condyle. Multiple approaches, multiple plates, raft screws, and buttress plates. So total solution management for tibial plateau fractures today. MRI for high suspicion cases. Good clinical examination to look at the ecchymosis present, especially at the collateral levels. Examination under anesthesia to look at the collaterals. Looking for ligamentous and meniscal injuries simultaneously. Examination at the end of the surgery to look at the collaterals and the cruciates is the treatment of choice now. So we have advanced, not only step by step, but with a hurdling jump to this level as far as tibial plateau management is concerned. Thank you very much. Thank you for patient hearing.
Thank you, Dr. Sharath. Are there any questions? I still don't find any questions in the chat box.
Right. Dr. Pandian, can I have
Yes,
question
sir,
for Sharath,
Yes.
my good friend?
Yes,
That
sir.
was wonderful talk, Sharath. You always make these difficult fractures very simple and easy. But can I ask you, in the last 15 years, what has changed in the management of soft tissue and bone? As you know, we all know the soft tissue is a bigger problem than bone, proximal tibial. What has changed in the last 15 years?
Yes, am I audible?
Yeah, very
Clearly?
much.
Yes.
Yeah. Yes, as you said, because you are a joint replacement surgeon, you always think that TKR is a soft tissue surgery. But tibial plateau fractures are not only soft tissue, there is bone and there is also articular cartilage. I think what we are looking today as far as the injury around the knee is concerned, not only the bony injuries, but also you look at the soft tissues, you look at the ACL, you look at PCL, you look at collaterals, starting from the beginning till the end. In high suspicion cases, it is not only CT scans, you might have to get an MRI in high suspicion cases, and especially in young patients. And your approach should be fragment specific. And if there is an avulsion of an ACL or an PCL, that also should get a preference and get the things right. And at the end of your fixation, you do an examination of the knee for collaterals and see whether there is opening and take an immediate measure for all that. So what is called today as total solution for tibial plateau fractures. I think that is what we are looking at least in a patients who have high energy injuries between the age group of 25 to 40 years.
Same continuation, sometimes soft tissues does not settle. How long you think you can wait before you go for a proper fixation?
Maximum we have waited up to 3 weeks.
3 weeks, right?
Yes. So unless you get a wrinkle sign around, I think one should not venture into putting a knife onto their knee.
3 weeks is a good time, yes.
Okay. Thank you, Dr. Sharath, for that wonderful lecture, and it was quite interesting. We'll go to the next topic. May I now request Dr. Ramesh Sen to present his presentation on fat embolism.
Good morning, friends. I'll be talking about fat embolism syndrome. What has changed in last 20, 30 years? We know that our knowledge about fat embolism is primarily from the article of Gordon Wilson, who described the mechanism which can be responsible for that shock and death syndrome. Those who described the major features and the minor features and the laboratory parameters, and they gave us a kind of a scheme of treatment, how to prevent shock and how to establish the syndrome and how to take care of that. And that gave us a knowledge to know about that this is reasonably a condition where there is about 10% of the mortality in these patients. And they gave us a perception that it is primarily the venous sinusoids which carry the fetum droplets from the hematoma into the circulation, which eventually affects our lungs also. They also gave us a biochemical theory that it is due to the free fatty acids from the fat droplets which are coming into the circulation. But the clinical manifestation is an important thing, which is likely to be a tachypnea, tachycardia, restlessness, or a temperature increase. And the most important sign we learned at that stage was the presence of petechiae, the retinal changes, the rhonchi, and there could be neurological signs. We knew that arterial blood gas analysis was the most important thing to tell us about the hypoxemia status of the patient. And there were some hematological and biochemistry findings which were helpful. The X-rays, the typical appearance of snowstorm, was taken as the proof of diagnosis at that stage. But whatever all these investigations were, it was very clear that the gold standard for diagnostic fat embolism syndrome was the clinical one. So our management at the time when I was a PG student was very standard. Whenever we see a patient filling into these GERDS criteria, we will give a traction to the limb, a kind of immobility, we'll give him a respiratory support, we'll observe him till he settles down, or he shifted to ICU and there he settles down. Once he settles down, then we used to take the patient back, operate upon for puncture nailing, and that was the surgery at that time. By that time, the things started to change. The more and more people started doing fixation of these fractures early. And this is one of the studies which saw that if these patients are operated within 5 to 10 hours, the chances can be reduced to somewhere around 0% to prevent fat embolism syndrome. And by that time, the risk factors were also well described in a younger patient who had post-traumatic hypovolemia, who had multiple injuries or bilateral femur fractures, or has a concomitant pulmonary injuries are high risk factors. Then we started knowing about cerebral fat embolism, which will manifest after a latency of after the injury. And we needed to differentiate it from diffuse axonal injuries, and where we had a specific observations and specific clinical things along with the investigations to differentiate this part of it. Actually, MRI of the brain became the standard, again, the gold standard for differentiating fat embolism, cerebral fat embolism syndrome from the diffuse axonal injury with its various features in that evaluation. The CT of the lungs was important to differentiate the fat embolism syndrome from a contusion, from an edema, from aspiration pneumonitis, or from pneumonia. And CT scan was also useful to define those cases which were fulminant in nature with a very high mortality due to the extensive lung involvement seen in these patients. Now, during that time, we were clear that pulse oximetry is a very good dominator of the hypoxemic status of the patient. And if we observe these patients, we can identify the patients who are likely to land up. Likewise, those patients who sustain polytrauma, serum lactate levels were a good indicator. That is what we published about these injuries. With an interest to look for the pathology, we did look for interleukin 6. And we found it does have a correlation, which we published in clinical orthopedic research. But later, just this year, we published another study in which we found it out that it is not only specific to fat embolism, can have in a polytrauma situation also. The literature says a lot about the role of steroids in fat embolism syndrome. So we tried to evaluate. We published 2 review articles on that. And what we found was lack of uniformity in all these studies regarding dose. And then we found out, yes, if we are giving, we have to weigh between the benefit and the risk of giving a steroid. And we found it was more on the benefit side of it. Now, looking for that benefit, Then there came a new kind of a medicine. This is cyclosanide, which is given as a puff, and the difference is it reaches to the lung parenchyma, and we found it out that whether it makes a difference or not. Initially, we took up in 60 patients. It did show the difference, but it was not of a statistical significance. Later, we still kept on working more on the more number of patients, and we found that it reached that level of a significance with the increase in our sample size, and that is we published subsequently. So giving a puff of cyclosanide after the patient injury in a patient who is likely to get a risk could be useful. The question comes, can it be prevented? Yes, timely surgery, as was seen earlier also, can be the best prevention in this kind of a situation. And during the surgery, if you are dreaming, we should do it with a sharp reamer. They have been seen to make a difference in the literature. So if we have a patient and risk, it's better to give him a supplementage, oxygenate him, hydrate it, monitor him. And if needed, today we oxygenate him with a venti mask or a CPAP. And if needed, he will be given mechanical ventilator with the endotracheal intubation. For the fractures, we are likely to put him on X-fix. We may give steroids, and as soon as patient settles, we'll wean him off. The important is to maintain his hemoglobin more than 10 milligram and to guide fluid therapy with the CVP there. The fracture reduction and stability is essential in the day of today, whether we do with the proper ribbing or we do with the as a DCO kind of a procedure, we do it. Now the question is an isolated fracture. If it presents to us with an hypoxemia, the question comes, what to do? Now should we wait or not? What we found, we tried getting these patients immediately to the OT, stabilizing their fractures, and then shifting to the ICU rather than first shifting to ICU then doing. And we found it out. This created a better outcome for the patients because patients were rehabilitated and came back to normals earlier as compared to the initial shifting to ICU, then later on operating pool, and then again looking at it. We also found that 6% hydroxyethyl starch is better than normal saline while giving infusion therapy to these patients. And in the post-operative care, definitely a good care is required at that stage to maintain that hemodynamics. But what is important, if a patient is a polytrauma patient, in this case, we will not get into any major surgery because he's a borderline case for getting the complication. So we will go for a DCU kind of an external fixator kind of a management in this kind of a group. This is a very interesting and a good review which has come up in the American Academy, and incidentally they have picked up 2 of our references also, where they have highlighted that the most important part in fat embolism syndrome is its prevention. So where we are today from that 15 years ago, now in a polytrauma patient, whenever the biochemical parameters or there is a hypoxia, we anticipate it. We try to do the DCO if the patient's polytrauma or stabilize isolated femur fracture at the earliest. We give hydration, we take care to give steroids also, we monitor, and wherever needed, timely we define the ICU care in this group of patients. Thank you.
Yeah, thank you, sir.
Yeah, again, can I, Dr. Panyan, can I ask
yes,
question?
Sir.
Mike?
Yes, sir. Can, sir.
Hi, Ramesh, that's wonderful talk. Still remember our good old days in PGI Chandigarh. Can you just tell us, for a general orthopedic surgeon, can you hear me, Ramesh?
Is Ramesh online?
Ramesh?
Sir, I think Ramesh is not online, sir.
He's not online. Okay.
Yes, sir.
Okay, then we'll forget about it. Okay.
Okay.
Thank you, Professor Pandya.
Shall we go to the next talk?
Yes.
I call
Later,
Dr.
photo converter
to give his talk on knee dislocations.
Okay, knee dislocations, what we did 20 years before and now. So 20 years ago, when the patient of 22 years old male patient presented with a knee injury with the painful swollen knee and not able to walk, and this was the picture which he presented with. We can see that it is very, very alarming. We know that it's a limb threatening orthopedic emergency, and popliteal artery and common peroneal injury are very, very common. When I see this picture, even 20 years before, I know this kind of close dislocations, we know that these patients are very, very dangerous, which we should be careful to know and assess the vascular injury and also neurological injury. And we know that any expanding hematoma, any pulse, any decrease in the pedal pulses, we know that these patients can have a vascular injury. This concept was there 20 years before also, even now, there is no change. The first and foremost to look for the neurovascular injury. If necessary, we do a CT angio, we do the vascular repair, then only we address about the bone injury for the knee dislocations. When we closed knee dislocations, the conservative treatment was advised in 1963 by Kennedy, where just it advised close reduction and immobilization for 6 weeks. In that too, he also mentioned that there are only uncomplicated cases to get a good results. But we tend to follow blindly for a long time. Even the Western world were more advanced at the time. This was a patient which I treated 20 years before. We see the AP X-ray, looks very good. You see the reduction looks very good. We fixed with cross Tiemann pins. But we see the lateral X-ray. You can see that there is a PCL avulsion. You see that joint is completely subluxed posteriorly. But when we see the result of this patient, we even at the time we didn't do an MRI, we didn't do any cruciate ligament reconstructions or a collateral ligament reconstruction. But you see the X-ray on post-op, maybe the final follow-up after 6 months, this patient had a good results. We saw that full range of movements, but X-ray looks good. But we should not forget this patient had a mild posterior subluxation, and these patients can have a degenerative arthritis later date. What we did for fracture dislocations, again, we identified these vascular injuries even 20 years before. We tend to do a vascular repair. We tend to fix the fracture. We tend to get a reasonably good outcome, but not in all the cases. This is the paper which I presented almost 15 years before, which we had analyzed 25 patients. 19 patients were we could follow up. You see that out of 19 patients, 11 patients were just treated with the Tiemann pin, Tiemann pin application. And 4 cases we did a knee spanning external fixator. 4 cases just we did a casting. But we had a very good results at the time. I presented as a good result of close dislocations with more than 110 degrees of movements. When the fracture dislocations, we had around 90 degrees movements. So in these cases, we got stability, but mobility was restricted. So at the time, the concept was allow the soft tissues to heal with the stiffness. So, and we tried to mobilize and stretch the adhesions. We tried to get reasonable movements and we were happy about it. We accepted the stiffness. So stability in the cost of mobility. But we had problems. We didn't do an anatomical reduction. We didn't have a full range of movements in these patients. We didn't address the meniscal and chondral injuries. And of course, many patients present with persistent posterior subluxations that lead to the secondary arthritis, which we ignored it actually. So in all the high velocity injuries, they are all not common. It is very, very common. So what happens when you do a cross pins, the chance of infection, these patients can go for a septic arthritis, then we may not be able to do a secondary reconstructions. Even though with this treatment, some patients presented with persistent instability, as already mentioned, you can see that severe subluxation of the tibia posteriorly, and these patients definitely end up with arthritis. Now we understand anatomy better. And apart from cruciate ligaments, we know that there are other anatomy like posteromedial corner, posterolateral corner. We know that what kind of meniscal tears and how to manage that, including all the repairs of the bucket handle tears and radial tears, ramp tears. And also we know how to manage the chondral injuries. So we became better when we identified the superficial MCL injury anatomy, or we understand the POL, that is the posterior oblique ligament. Then in the posterolateral side, we know that popliteal tendon, lateral collateral ligament, and popliteal fibular ligament, there are very, very important ligaments which we have to identify and do the surgical management. And also later on, the papers had come with good results with ligament reconstructions in the literatures, like this paper where Vangatali reported operative treatment with complete repair of all the torn structures had given better knee stability. So now we identify the knee dislocation is a complex problem. We know that each injury is different and anatomy is the most important here. And with the involvement of arthroscopic expertise and experience, now we know we can manage these cases better than what we did in 20 years before. Especially when you have come to the SEN classification, we know that most important injuries are KD3 and KD4 injuries, which we tend to address now in knee dislocations. This is a patient of 22 years old. Now, if they presented with swollen knee, not able to walk, and this is the kind of picture which we get. And now we should understand any patient present with, even with this picture, we should be carefully look for, this could be a spontaneously reduced knee dislocation. So we should identify the asymmetry of the joint space. Even the minor subluxation should be identified. Any avulsion fractures can give you a clue that these patients may have had a dislocation. So how do we proceed now? We don't apply any more plasters. We do a clinical examination. Even acute injuries, we can have a gentle clinical examination to know whether the knee is stable or unstable. Of course, all the patients require an MRI scan. If the patient has got a fracture, you can also include CT scan. So some cases need an immediate intervention, even in now. So any patients with the knee dislocation with vascular injuries or open dislocation or an irreducible dislocations, then these patients can be addressed immediately. Otherwise, all other injuries can wait for 2 to 3 weeks. This is an irreducible dislocation. You can see this patient is you see the AP view, you can see there is a opening of the joint space. We can see the subluxation. We should suspect this is not a normal joint. And you can see that MRI, this patient got a dislocation reduced with the MCL got entrapped inside the joint. So this is the case which we can do an immediate open reduction. We can remove that entrapped fragment from the joint. We can do a repair. We can address the cruciates at the single stage, or we can address at the later stages. In this case, we address the single stage. We can see that complete reduction of the joint space and both AP and lateral view with very good results. All other cases can wait for 2 weeks time. So what we do for the first week, we put on a brace, allow the knee to quiet, swelling to subside. Then we mobilize the knee after 10 days time with the hinge knee braces. We try to get at least more than 90 degrees to proceed further for the ligament reconstructions. Can we treat knee dislocation conservatively? Absolutely. So there are some indications where even in the low energy injuries in KD2 or sometimes even KD3, you can try conservatively with the posterior supporting brace for 4 to 6 weeks. You can mobilize the knee. Some of them will give very good results. Of course, if the patient doesn't have any obvious instability, especially in the middle and old age patients, especially old age patients, all the KD3 injuries can be treated conservatively. Very few patients will present with instability. So surgical management, what we do now, any patients examine, if they are stable, then we can do a reconstructions, especially after 2 weeks time. We can do it in a single stage or in 2 stages. So depending upon the velocity of the injuries. Of course, staged approach, definitely it's better for the beginners because it reduces the arthropibrosis and especially considering the operating time, considering the complexity of the injuries, better to do a staged procedures for the beginners. But if you're an expertise, then if you are confident, sometimes you can do one single stage because that reduces the cost. And when you do a ligament reconstruction, always we do a PCL reconstruction. That is very, very important because this is what we do now. By fixing the PCL, the tibia comes into the normal anatomical position. You can do an ACL at the same time, or ACL can wait along with the collaterals. We should do a repair or reconstruction in the primary stage. That is the stage 1. This is a patient of 25 years old patient, had an oil treatment, presented late, but this patient had an ACL and PCL tear in the MRI. And also you can see this patient had a LCL tear. This patient got a flipped lateral meniscus. So with now, we know that this patient should be managed. Meniscus has to be addressed because it's a very, very young patient. So in this case, we did a close reduction. It's an KD4 injury. We did an arthroscopic reduction of the meniscus. We did a repair of that. At the same time, we did an open LCL and popliteus repair along with collateral ligament augmentations. So we tend to do a stage 1 collateral ligament injury, collateral ligament repair and reconstruction along with the meniscal management. And after 8 weeks, after getting near range of movements, we tend to do we did the ACL and PCL reconstruction by arthroscopically. We also can compare that now medial and lateral side injuries, that a lot of case series are available. We did our studies of 45 cases of KD3 injuries, and open and fracture dislocations are avoided in this study, and we could publish this paper in Orthopedic Journal of Sports Medicine. So now we understand the anatomy of both medial and lateral sided injuries, and we could present our results too. How do we understand our fracture dislocations? Compared to 20 years before, we understand better. We see this kind of 23 years old patient. It's not a very common injury, but still when you see the X-ray, we think sometimes it's just a dislocation. But if you see very carefully, this patient has got a fibular head avulsion. That means posterolateral corner bony avulsion injury here. At the same time, you see here carefully, AP view, there is a depressed double sign. You can see that depressed fracture. So this patient requires a CT scan. And also the lateral view, you see that complete posterior subluxation. So apart from ligamentous injury, the CT scan helps you to identify there is a depressed anteromedial fracture. You can see that half of the tibial cortical surface has depressed. So this also has got a PCL tear in the MRI. So this patient has got a fracture, LCL bony avulsion, and also PCL tear. So these patients underwent elevation of that depressed fragment, did a bone grafting, did the fibular head avulsion fixations. At the same time, we did an arthroscopy. This patient had a complete radial tear of the meniscus, which we could do a repair now. And we did a PCL graft reconstruction. At the same time, the depressed fragment has been elevated and fixed with the plates. This is the final picture of the reduction. You can see that very good view. So now we understood that anatomy better. Of course, this case, we can do a staged procedure, do the fracture fixation first, and always we try to do a ligament reconstruction at a later date. But this case, we did it the single stage with very good results. We can do an autograft, and also some centers has got a facility of allograft, which is very, very important when you have a multi-ligament injury management in these cases. To conclude, 20 years ago, we did only one treatment for all the dislocations. We treated all the cases are same. Now we understood each dislocation is different. Management includes the repair and reconstruction of the cruciates and also collateral ligaments. We know how to address the meniscus injuries and chondral injuries. Single or two stages doesn't matter, but if you are better to do on 2 stages in most of the cases, now we can do the justification to the injury and patient to get both stability and mobility. Thank you very much.
Thank you, Dr. Sundar. Are there any questions?
Sir, I'm here, sir.
Yes, sir. There. Are there any questions? Dr. Reddy?
Just yes.
Yeah.
Sundarajan, can you hear me?
Yes, sir. I can hear you, sir.
I know. I keep asking this question, everybody. Okay. What do you think? What had changed in last 15 years in the initial management of knee dislocation and later on management? What are the things we should not miss, which we used to miss in the past?
Yeah, I think the past or present, I think we should not miss the neurovascular injury. Of course, that is the prime and foremost examination in any knee injury.
Yeah.
Because many times we see that reduced dislocations. So when the patient presents with an X-ray normal alignment, we should not think that is just a simple knee injury, ligament sprain, should not put on a plaster. That's what we used to do. Any patients come with a knee injury, if X-ray doesn't fracture, we put on a plaster and send them home, come back after 4 weeks or 3 weeks like that. But now the concept is once the neurovascular injuries have been ruled out, then it is important and foremost, even whatever the nature of the injury, even you should examine the patient clinically. Gentle examination can be done. We can do a gentle Lackman's test.
Yeah, I'm in the conference.
Gently examine the collaterals.
Okay.
Then we know that this is a stable knee or an unstable knee.
Yeah.
Now it is an unstable knee, and then we put on an external fixator, we stabilize it. Then later on we'll assess and address all the cruciates and collaterals. Sure. But if it is a stable injury, then we put on a brace. We don't put on plaster anymore. There is no roll of plaster.
That's right. That's the most important thing.
Most important thing.
And, yes.
You blindly should not ask the patient to come on after 3 weeks. So even the day one, we know at least some on examination, we know that what kind of injury is this, whether it's a stable dislocation or an unstable dislocation. Then we can counsel the patient that we will review the patient after 2 weeks. Once the knee becomes quiet, then we try to get the knee movements first. Then we try to address the ligament injuries by doing the arthroscopic management.
Yeah. And one more thing, Sundaran, what is I know you already said for the benefit of the audience,
Yes,
what
sir.
is the sequence of reconstruction you would do? If at all you want to postpone one ligament, which one would you postpone for a later stage?
I mean, the ACL is the least we are bothered. ACL,
Okay.
anterior cruciate ligament is the one. If you want to do it in a second stage, you can do it.
Absolutely, yeah.
There is a slight debate and controversy whether to in single stage and two stage. Single stage, what do you mean by single stage? We do one collaterals address first. At the same time, we address the PCL with or without ACL. That is what we call single stage.
Right.
When you call as two stage, you address the collaterals first.
Yeah.
Then you immobilize the knee with the posterior supporting brace. Then come back after 3 months or 4 months. Then you address the cruciates. That is the posterior cruciate at most.
Sure.
But again, it is very difficult when we don't fix the PCL. Very difficult to maintain the knee without sagging. So that's why if it is possible, if it is a stable injury, we try to address PCL also in a single stage. Then ACL is the one we are least bothered.
Sure. So collaterals are the most important thing for stabilizing.
Yes,
then,
sir.
of course, posterior cruciate.
Yes,
Then
the
you
most
can think about ACL later on.
Yes, the
Thank
last
you.
one. Yes, sir.
Yeah, that's a good sequence.
Yes, sir.
Okay. Thank you, Dr. Sundaraj. For want of time, I think we'll go to the next speaker.
Thank you, sir.
May I now invite Dr. Radhakant Pandey to talk to us on proximal humerus fractures.
Fracture of the decade. It's 6% of all the fractures. Good morning, everybody. I'll be talking about proximal humeral fractures and what has changed in my management in the last 10 to 20 years as I have grown older. Proximal humeral fractures remains the unsolved fracture of the decade. It's 6% of all the fractures. Since a 2006 Finnish study said that since 1970, it has tripled in the elderly population. It's now the third commonest fracture in the elderly. There's a lot of disagreement and confusion on proximal humeral fractures over classification, indications for surgery, fixation techniques. Almost every fixation techniques available in orthopedics has been used in proximal humeral fracture. Hence, none of them is an ideal fixation for all fractures. Now, there's been an increasing trend in surgical fixation about 20 years ago. And if you look at this X-ray, it shows the fracture is healed, the implant is in good place, so you would think everything will be hunky-dory. The patient is not happy. There's restricted range of movement, still has pain. So just because you fixed it well and the X-ray looks good, doesn't equate to a happy patient. So beware. A Cochrane review recently said that surgery for displaced fracture of the proximal humerus may not result in better outcomes than non-surgical management. Now here we have a displaced fracture. One would like to fix it, but we discussed it with the patient and did not fix it, and the fracture went on to heal, and that we have a patient who's happy, has got reasonable function. So not every displaced proximal humeral fracture needs fixing. We all have a collection of these kind of fractures where the metalwork's failed and the surgery has not been performed perfectly. I'm not saying you don't operate on these fractures. There are a lot of fractures which need surgery. I'm talking about fractures like these, where the tuberosity, the head, the shaft are in reasonable positions. Maybe these can be treated non-operatively. So there was this PROFAR trial, and now I can suggest non-operative treatment for displaced fractures with confidence as I have good evidence. So if a surgeon is in equipoise, that is, if he sees an X-ray and it is not sure whether to operate or not to operate, don't operate, because your results will be as good as surgery. So, and these results do not support the trend of increasing surgery for patients with displaced proximal humeral fracture. This is a patient with quite displaced fracture, but the head is in reasonable place, the tuberosity is in the reasonable place, shaft is not too bad. We treated this non-operatively, fracture united, patient has reasonable function and is quite happy with the outcome. So if you do decide to do surgery for certain humeral shaft, proximal humeral fractures, what do you do? Over the years, I have thought putting too much metal work is not so good. So I have moved to minimally open reduction and percutaneous screw fixation. It's a minimally invasive technique with low risk of avascular necrosis infection as you're putting very little metalwork. Now, if you put a lot of metalwork, you cause extensive soft tissue dissection, which leads to stiffness, avascular necrosis, metalwork problem, screw penetration, infection, cuff failure, you name it. Percutaneous screw fixation in my hands causes very little soft tissue damage and very little damage to the blood supply. And it's easy to remove the metalwork. Here's a valgus impactant fracture. All we did was elevate the head, put the tuberosity in the right place, fix it with screw which are put into a set pattern, and the fracture healed with reasonably good results. This is quite a displaced fracture. We again put the head in the right place, the tuberosity roughly in the right place, and temporarily held things with screws, and we had a reasonable outcome, as good as any other metalwork. Now we are using them for fracture dislocations. These wires are temporary. These are all substituted by screws, and at a year's time, the fracture is healed. These screws back out this way rather than going into the articular surface. We published our results, especially the fracture ones in JBJS and the fracture dislocation ones in shoulder and elbow joints. So these are well described techniques, and we've been happy with the outcomes so far. Even for complex fracture dislocations, we use minimally invasive technique with minimal metalwork with reasonable outcomes. Another area where there has been significant advance is the proximal humeral nailing. The current generation of proximal humeral nailing are fantastic, and they cause minimal soft tissue damage, periosteal stripping. They are load sharing rather than load bearing, and most cases do not need external support with low infection rates. Previously, we used to put rush pins. Please do not put them anymore. These advanced proximal humeral nailing are fantastic, and I prefer them for two-part fracture over nailing. Correct entry point is crucial. Now the screws can be locked inside the nail that prevent it from backing out. So in an appropriate patient with appropriate fracture, you get very good results with proximal humeral nailing. Not just any nail, but specifically designed proximal humeral nails. You can put them in three-part fractures also with good reconstruction of the tuberosity. Very complex fractures, you can use these nails with reasonably good results. This is another very complex fracture with reconstruction around the nail with tuberosities healing and good result. Plating. I know it's a very commonly used tool and a lot of people like it. My suggestion is it combines the disadvantage of an extended approach and often in elderly patients, inadequate primary stability due to poor bone quality to allow early mobilization. Tuberosity fixation and reduction is still a problem. Screw penetration is a problem. Please do not use these plates. They are outdated and have no place in modern orthopedics. Use a proximal humeral plate. I generally use proximal humeral locking plates for ununited proximal humeral fracture with bone graft, but you can use them for fresh fractures. This is an unforgiving operation. It has to be done perfectly. The plate has to be below the tuberosity. The screws have to be put in the right place. The reduction has to be good. So if this is not done properly, you end up in more trouble than you started with, and you're not doing justice to the patient. So if you are using proximal locking plate, it has to be perfect. In a good, well done proximal humeral plate, you'll get good outcomes. Complex fracture also, you get good outcomes. It has to be done well. Just because you have a good X-ray does not mean you'll have a happy patient. This is more of a soft tissue procedure than a bony operation. Respect the soft tissue. Plates have a lot of complications, especially in the elderly. They ask me what complication, and I say everything you can think of. Things can go wrong with the plates. It has to be done perfectly. You will see some fractures which cannot be reconstructed by a plate nail, and you'll have to resort to arthroplasty. We used to do a lot of hemiarthroplasties, and this is another area where things have changed significantly. The hemiarthroplasty gives mixed results. The results are unreliable, and it is very dependent on tuberosity healing. The tuberosities don't heal, however well you do the operation, it will not give you good results. It's still quite a useful tool to have in very young patients or in very elderly patients where you just want to give them a pain-free shoulder. The results are variable, but if you do a good hemiarthroplasty and the tuberosities heal, you'll get a very good result and a happy patient. This is the new kid on the block, a reverse shoulder, and the results which are coming out, the systemic reviews and the trials are saying that it is superior to hemiarthroplasty because it gives a reliable outcome and reasonable function result, and can be used just for primary procedures, but can also be used where your internal fixation has failed. You've got nothing else to do. You can do a reverse shoulder arthroplasty, which can give reasonably good outcome. Repairing the tuberosity is crucial, especially for trauma in this reverse shoulder arthroplasty too. The problem is nowadays people are overusing reverse total shoulder replacement, and they're not thinking that something else can be done. We still not entirely certain the long-term results of this procedure, but the medium-term results are pretty encouraging. If you have a very badly fractured proximal humerus with fractured tuberosities, there's not a lot you can do here. You do a reverse shoulder arthroplasty, you get reliable outcome and good function. Even your fixation fails, you haven't got a lot you can do. You do a reverse shoulder arthroplasty, you get reasonable outcomes. Especially in elderly people, nowadays it's the primary method of treatment in complex fractures. We are doing less and less hemiarthroplasty, especially if the patient is fit and active and you want function and reliable outcome. A reverse shoulder arthroplasty is the way forward. So in summary, judicious decision making is still extremely important. You have to have the right patient, the right implant, and you have to do the best for the patient. And mostly non-operative management is what I practice, and I have been very happy, and now I have good evidence to back my management plan. If you have a two-part fracture and you want to do surgery, if you do good surgery, you'll get good results in any fixation, whether you put plate, you put screws, you put nail, but it has to be done well. Three-part fractures are difficult, and you need good technique. And I have used percutaneous screw fixation, and I've had good results because I put little metal work, less soft tissue dissection, less damage to the blood supply, and that gives me slightly better outcomes. You will have four-part fractures which are not reconstructible. With dislocation, without dislocation in elderly patients, where you can't fix the fracture, you have to resort to arthroplasty. And nowadays, more and more people are doing reverse arthroplasty rather than hemi, but hemi does have a role, and you need to be well versed with both techniques. Remember, the rehabilitation is crucial in these patients. It takes a long time to get better. My patient take more than 6 months, 6 months to a year. So you need to warn the patients about this. Thank you very much. Bye.
Yeah, Dr. Pandian, can I?
Yes.
Yeah.
Yes, sir.
Pandey, that was a wonderful talk. Thank you very much for waking up early in the morning and your time. Can you hear me? Pandey? You there? I can see your name there.
Yeah, I'm here.
Can you hear me?
Yes, I can hear you.
Yes, I was saying thank you very much for waking up early.
Yes.
I think it's a long time since we had single malt. Probably next year I'll come and join you.
Yes.
Can I ask you, Pandey? I think I know so many things have changed, and you said very well. We see quite often the various collapse after plating. What do you think? What precaution people should take to prevent that varus collapse?
See, the problem is plating is a very exacting technique. It is a very unforgiving operation.
Yeah.
Plating works reasonably well if the bone is very good, even if it's a locking plate.
Yeah.
If it's a young patient, plating works reasonably well. The problem happens if you have 3 and 4 part fractures.
Yeah.
A 2-part fracture is not a problem. For 3 and 4-part fracture, if you don't put those calcar screws properly, the 2 bottom ones, the varus collapse of head is pretty common.
Right.
Also, if the bone is osteoporotic, so if I have a patient who's more than 65, I generally don't use a plate anymore because the complication rate is very high.
Right.
And if you've done a plating and it fails, it's a disaster because the second operation is never going to be as good as the first operation. So people think they can use a plate everywhere and it's very easy to do it, but it's not. It's very, very difficult operation. You have to get the reduction perfectly.
Yeah.
The medial side has to be reduced properly, and those calcar screws are crucial. And if those things are not being done properly, then you will have a varus collapse. And many times these days, if it's an osteoporotic bone, I put a fibula, intramedullary fibula graft to hold like a peg the head so that it doesn't fall down. But you're right.
I think that's a good tip. Good tip. Yes.
Yeah.
And one more question. I think there's no questions on the chat box. Do you think there is, especially people talking a lot about reverse orthoplasty, the indications people are extending or right indications?
Yeah. As I said in my talk, people are overusing reverse shoulder arthroplasty.
Yeah.
And the problem is we have good medium-term results, but we don't have long-term results. So people are stopped thinking whether we can do something else. They look at a very complex fracture in a slightly elderly patient. They say, okay, let's do a reverse. But I think the pendulum has swung to the other extreme quite significantly. We need to bring it back to the middle. It's a good operation, but yes, I'm absolutely sure that too many of them are being done by some people who don't do too many of them.
Right.
It has to be done by people who do many of them, and it has to be used judiciously. Otherwise, you'll end up in bigger trouble than you started.
Yeah. Yes. Because sometimes we see people with reverse orthoplasty. The biggest problem, though I'm not a shoulder surgeon, limitation of movements is the big problem with them. So I think probably people should keep in mind when are opting for reverse orthoplasty.
Correct.
Okay.
Thank you very much.
Yeah, thank you, Dr. Pandey. I think we'll go to the next lecture on knee arthroplasty by Dr. KJ Reddy.
Good morning. Greetings from Hyderabad. Welcome to OasisCon 2020. We have very exciting academic program for you. I'm going to talk about shifting paradigm in total knee orthoplasty. What I used to do in the past about maybe 15, 20 years ago, which I stopped doing now. Total knee orthoplasty, undoubtedly most successful surgical procedures in modern orthopedics in relieving pain, restoring function. And recently, more numbers are being done. Last year, about 120,000 total knees were done in India. Young arthritic knee was a big problem in the past. Even now, we used to leave them well alone, ask them to wait till they get older, then come back for total knee arthroplasty. Probably I won't do that now. I would offer them a total knee arthroplasty to improve the quality of life. It is because the implants, the technology has changed, and our attitude towards these patients has changed. This is a 55-year-old male fused knee about 15 years ago. He has got a little discomfort, but he wants movements to travel in his expensive cars. Probably I would have reassured him, left him well alone in the past, which I wouldn't do now. I offered him a total knee arthroplasty. As you can see, tibial osteotomy is done, a total knee performed, osteotomy fixed with the screws. It's got full extension and reasonable degree of flexion. This is before suture removal. The other problem was multiple joint involvement, especially in rheumatoid arthritis, both the knees, both hips involved in this case. We used to stage them probably 3 months. So 4 joints used to complete in 1 year, which I wouldn't do now. Probably I would do them in a day or so, probably within 48 hours or 72 hours, provided they are fit. That's a big change. I used to shave the knee, paint with a betadine and put a crepe bandage in the past, which I wouldn't do. Now I would shave them in the operation theater after anesthesia. As you know, shaving early has got contamination of bacteria and other problems, which I wouldn't do now. Obese patients were other problem. In the past, I used to ask them to wait, lose the weight, come back once they lose weight for any replacement, probably, which I wouldn't do now. I would offer them knee replacement, provided they understand the risks involved, which would be better for their rehabilitation. And the big change which happened is anesthesia. I used to practice in the past different anesthesia, which I do now. Probably I used to do general anesthesia or a epidural anesthesia, which I wouldn't do now. Most of the surgeries are done under spinal and femoral block or adductor canal block. If it works well, it's very effective, good for the patients. Most of these are done under blocks. Pain management has changed dramatically because of the blocks, because of multimodal pain control. Prophylactic antibiotics was other thing. I used to keep them in the hospital till the sutures were removed and put them on antibiotics, probably 3 to 4 days of IV antibiotics, then till 2 weeks of oral antibiotics, which I wouldn't do now. I would give them 3 doses, 1 dose pre-op, 2 doses post-operatively. If you're giving longer, it means you're treating yourself, not the patient. There is enough evidence in the literature to say that more than 24 to 48 hours, antibiotics do not help. Probably it will cause more problems. Surgical procedures have changed. Lengthy procedures have become smaller. Probably I would give an incision like this in the past, long incision, big exposure, which I wouldn't do now. It's an incision big enough to put the implants in because of the instrumentation available. Quicker recovery, small incision, cosmetically better, faster recovery, less pain, better rehabilitation. Something like this with stress fracture, osteoarthritis, probably I would have done 2-stage procedure like this, plating and second stage knee replacement once the fracture joined up, which I wouldn't do now. What I would do now, something like this, I would do in a single stage with a stem, which would do very good result. As you can see, fracture completely joined up with good function. The other thing was we are very scared of infection in the past, especially doing revision in these infected cases, something like this. As you can see, necrotic tissue, a lot of pus, debris under the implant. What I would have done in the past, probably I would have offered them a fusion, which I wouldn't do now. I would offer them a 2-stage revision, which I've done initial spacer, followed by second stage revision. 2 months later, when ESR, CRP, everything back to normal with a good result. Drains. I used to put 2 drains, one in the medial side, one in the lateral gutter. You keep them for 48 to 72 hours with associated morbidity. Now, probably I wouldn't use drain. If at all I use a drain, I remove them after 6 to 8 hours. Post-op rehabilitation. I used to put them in the bed, maybe 2 days. Late mobilization. Put them in a splint back slab to protect the wound. We were more worried about their wound healing rather than the rehabilitation of the knee and late rehabilitation, and put them on CPM later on when they become stiff. But now what I would do early mobilization, aggressive physiotherapy, early discharge. I would do daycare, started doing daycare, TCAR procedures, a fast track recovery, which gives immense satisfaction to the patient and very good short-term results. Squatting was other thing I used to say, all the patient, do not squat, which I stopped doing now. Patients are allowed to squat because of the technology, because of the range of movements we're giving to the patients. It's combination of surgical technique, to some extent implants as well. So, and then the take home message, probably some of the indications have changed, which was not there in the past. The practice, I do prophylactic antibiotics have changed. Anesthesia was a general anesthesia, which I wouldn't do now. Long exposures, I stopped doing them. Complex cases, try to do them as soon as possible for a better rehabilitation so that they can mobilize early. And of course, fast track daycare TCARs, and most of the activities are allowed, including squatting, maybe jogging. Some of the sports are allowed, which I wouldn't have allowed in the past. Thank you very much for your patient listening.
Thank you, Dr. Reddy. That was very comprehensive. I don't still see any questions chat box.
Yeah.
Yeah. Is anyone?
You know, when, as you know, I've left joint replacements more than a quarter of a century ago.
Yeah.
Now, with this concept of daycare sort of knee replacement surgery,
Yeah.
are there any dangers? Like what happens if the patient gets an embolism and they go home in the night?
I think
Do you
that's
see your patients whom you send home? Or?
Sure. That's, I think, a very good question, Raghav. The question was daycare procedure. If you send home on the same day, how are you going to monitor them? What happens is in the selection itself, we exclude people who are prone for high complications, and we discharge on the same day, and we arrange hospital at home in their own bedroom. There will be a nurse 24 hours for next 2-3 days. They'll be attending doctor, and they're all monitored by EICU. In Apollo, what happens is we have EICU monitoring any risk or we suspect any complication, it will be attended immediately. And all these patients are located, and we inform the emergency services ambulance people. They should be, in case of complication, they should be taken back into hospital within 20 minutes. We only offer them if they are located around the hospital, time being, because we don't know. As you know, in America, daycare procedure is very common, but daycare procedure, they do 24 hours. They admit today, discharge tomorrow, because as you know, some of the insurance companies do not allow for a daycare procedures. So they keep them overnight, and it's 24 hours. So we call it daycare procedure. But we started doing daycare procedure in the same day, provided they are monitored. Raghav, to some extent, they are better monitored at home because single nurse, one person to one nurse, and there'll be a doctor attending them with Apollo home care. So I think what happens is, because of home environment, home food, especially during COVID time, people are very scared to come to hospital. They're quite happy presently, but we have to be very careful in selecting patients. Someone uncontrolled diabetes, blood pressure, other things, we should not offer them. Young people who are fit to go home, and even every stage we assess them after the operation, after 4-5 years, we assess them, whether their pain is controlled, the blood pressure is controlled, sugars are controlled. After monitoring everything, they're fit, then only they send home.
So you need basically it's like an extended hospital stay with all the precautions taken to meet
Absolutely.
these emergencies.
Absolutely.
I'm
It's
glad.
extended hospital stay. You're absolutely right.
Right.
Dr. Reddy, you said in your presentation, like the daycare procedure, the patient is very happy.
Yes.
Okay. Is the surgeon happy at home after, because he's almost worried, no, like what's happening to the patient?
I know, worried. But what happens is, as I said, why we keep them in the hospital? Because we are worried about the pain. If pain is controlled better, there's no, I wouldn't worry. If any complications, especially we are worried about any myocardial problem or sugar control, but we are happy that if it is monitored well and it's probably suited for people who do not have uncontrolled systemic conditions, who are fit to go home, which is a quite common practice across. I mean, in America they started doing a long time back. So I would be happy. Initially, I was, as you rightly said, I was very anxious, but I realized soon they're better monitored at home with a nurse. Every hour, the feedback is coming to EICU, and every stage intervention being done to them. So I think now I'm not worried surgeon. I would be very happy provided we select appropriate patients for this procedure.
Okay. Are the patient also happy monetary wise, because you have the
very
nurse,
much
nurse is going to be at home, then you have the consultant who is going to visit the house. Monetary wise, are they happy?
Very much. They're more delighted because they're very happy at home, because home environment, their own bedroom, own relatives, own food, not worried about COVID. I know, probably very appropriate during this time. But I would warn surgeons who take up this surgery, they should be very cautious. Even 1% risk, they should not take it. Because, as you know, the economy started mobilizing on the same day. So once we take all the precautions and we mobilize them, we make sure they pass all the tests before sending them home.
Thank you, Dr. Reddy. Thank you. We'll
And
go to the
there
next.
is a question in here, one more, sorry to interrupt. Both the knees would do the same sitting? Yes, I would do both the knees same sitting, but not as a daycare procedure. I would do probably 1-2 days. Presently, I do select it without any systemic complications, single knee as a daycare procedure. If they want a daycare procedure, probably I would give an interval of minimum 6 weeks.
Yeah, okay.
Thank you.
Thank you, Dr. Reddy. We go to the next topic.
There's another question on robotic knee surgery.
Yes. Because we have a lot of time, no?
There's another question on robotic knee surgery.
I don't see that, no? I don't see any question here. Okay. Yeah, we'll go to the next topic because for want of time, because we are at 12:30, we got to go for the next session. So may I now invite Dr. Anil Bhatt to talk to us on brachial plexus injuries.
Respected chairpersons, and hello everyone. This is about brachial plexus injuries and what's happened in the last 2 decades in terms of the management. And we all know that it's one of the most devastating injuries of the upper limb. And most of these are young patients. Almost 70% of these are motor vehicle accidents. They have associated injuries. And out of these, if you see 70% of supraclavicular injuries, 70% have root avulsions, and 70% have C8 when involvement. And 70% of these generally have persistent pain. And this is called as the Naraka's rule of 770s. Patients used to be presenting like this untreated for a long time. If you go back in the last 2 decades with completely flail limb or upper brachial plexus palsy, not treated for a long time. Most of the time they were told to wait, let's see that it will recover and those kind of things. And no nerve surgery was attempted at the neck, even though patients had avulsion injury. CT Milo used to be done those days, and it showed avulsion injuries. Nothing much was being done for these patients. And the option surgeons used was basically in upper brachial plexus injuries. Like we used to do a lot of Steindler's flexoplasty like this. Shoulder used to be sometimes flail, or it used to be fused or arthrodesed, and then flexoplasty used to be done like this. or sometimes latissimus dorsi transfer like this used to be done. And one of the other procedure was a triceps transfer, but all of these had their own disadvantages. The triceps transfer had poor instability at the elbow joint because of the removing of the major stabilizing force. Shoulder, we used to do trapezius transfers, and sometimes finally we used to go for arthrodesis at shoulder and wrist levels like this. Most of these surgeries were inspired from polio treatment and peripheral nerve injuries. Distal tendon transfers used to be done, and sometimes with a painful limb, the patients used to demand actually amputations. None of the procedures addressed the primary cause, which was basically nerve injury, and most of them were salvage procedures of what was done. The clinical outcomes were obviously compromised function, a lot of pain in these patients, in fact, going up to suicidal tendencies in these kind of injuries. Now, the management evolved over the decades from 1970s onwards. With the pioneering work of few legends. Milesi was the first person who went into this in depth and started the concept of what is called as the nerve transfer, where intercostal intercostal nerves were used for transfer to the brachial plexus. The other break came up by Narakas in 1980s when neurotization, the concept of neurotization or nerve transfer came in, and he showed a lot of good results clinically, especially in elbow flexion. So the nerve transfer is transfer of a sparable functional nerve to a non-functional paralyzed nerve, and nerve graft is avoided in these patients. So typically you can do it between the brachial plexus branches itself or from outside, like intercostal nerves are used for transfer into the brachial plexus. The game changer came in 1990s when Oberle's procedure, where he showed that the transfer of an ulnar nerve vesicle to the nerve to biceps, the musculocutaneous nerve, was sutured directly, and that short distance transfer gave very good results of almost grade 4 with a good range of motion in the biceps with a short term of recovery, 3 to 4 months, the biceps recovered. Then the next target was the hand function, where Doyle and his colleagues showed that they can transfer the entire muscle from somewhere else. So free muscle transfer, Grizzlies was transferred for prehensile function of the hand in complete avulsion of brachial plexus. This kind of a work continues now. People use contralateral C7 here to give nerve transfers towards the injured site here, again to get back hand function, thumb and wrist and finger flexion. So this kind of a work is continued even now. So this is a big major paradigm shift from salvage to primary treatment, as in replacing a nerve with a nerve with the help of nerve grafting or a nerve transfer, and replacing the paralyzed muscle with a functional muscle in a flail limb. The most important thing is to differentiate between preganglionic and postganglionic, so that you know what is avulsion and what is a rupture. So avulsion injuries, we should not be telling the patient to wait, and they require immediate surgeries. So in avulsion injuries, basically these are the roots are avulsed from the spinal cord, the anterior horn cells itself. In the chronic stage, they become a big neuroma here, fibrous mass here, and absolutely not salvageable. However, in a postganglionic injury, most of the time happens due to stretch, and they usually rupture outside the ganglion here. And there are options for here where we can bridge this gap with a nerve graft or sometimes even a nerve transfer. So this is the basic practice which happens here. So the preganglionic clinicians especially have to be recognized with classical signs like Horner's sign. Most of the time they are global palsy. We see the winging of the scapula, we see the parascapular muscle wasting, and absent tinal sign and profound neurological pain. So these are the classical signs of preganglionic injury. Now, there are some criteria where we continue non-operative management, especially in postganglionic injury, who show a progressive motor march and there's a progressive tinal sign. You can still wait for these patients. And during that time, during a non-operative treatment in closed injuries, we treat them associated injuries, the arm sling, analgesics, electrical stimulation, mobilization exercises. So these are the things which are followed in the initial, especially the first month up to 3 weeks for the next step of management. Now, when is surgery required? Definitely in open injuries and vascular injuries. You have a patient like this, an assault, definitely it needs to be operated immediately and repaired like this. And a lot of patients do come with an MRI on day 1. MRI is done, which is absolutely useless. So best is done after about 3 weeks from injury, because the initial MRI shows a lot of hematoma and edema, so that the reporting is not good. We don't know what is avulsion, which is not clearly seen. And one of the best investigations is to see the MRI is to see the avulsion injuries, and it gives almost almost 96% kind of a accuracy in this. This is our own publication here. So when you see a pseudomeningocele, you need to have a high degree of suspicion of an avulsion injury, and they require early surgeries. So electrodiagnostic studies are also helpful. It tells you whether there is a root avulsion. If there's a conduction block, it tells you whether it's an axonotomesis or a neurotomesis, and also if there's a nerve recovery. And then you need to add the EMG to get the best picture out of this. But then these are fallible investigations. You need to always correlate clinically, and sometimes incomplete or not reported. Even the MRI reports by the radiologist sometimes might be misleading. And so if the documentation is not correct, then we try to continue conservative treatment and these patients suffer. So the most important thing is a detailed clinical examination is a gold standard so that you correlate that with your investigation findings. Now, what are the indications of surgical management? Definitely preganglionic injuries and then postganglionic injuries without progressive recovery by 8 to 12 weeks. And if there is a non-anatomical return of function, then definitely again, there is an isolated lack of proximal function, but good distal recovery means there is some mismanaged kind of a recovery there. So we operate generally, if the patient is good and general condition is good, best is to operate within the first 2 weeks. A lot of times this doesn't happen. If not, it's better to wait to 8 to 12 weeks as the scar is not mature between 2 to 8 weeks. So generally by about 3 months, we should be taking the decision. And the treatment is based on the classification. Level 1 basically is preganglionic injuries. We go for nerve transfers. And level 2 to 4, we go for nerve grafting or nerve transfers. And if the patient comes late, then secondary procedures like muscle tendon transfer or arthrodesis is always done. The target basically in upper brachial plexus is for shoulder abduction, external rotation, and elbow flexion. For an extended upper brachial plexus, we also have wrist and digital extension. And for a global palsy, we need everything back, along with sometimes sensation and also pain relief has to be planned in these patients. This is an example of nerve grafting. Now, this is an upper trunk lesion, an assault case like this. We see a small gap here, and then so we can bridge that with a nerve grafting using a sural nerve grafts. And that is the function in this patient. So it gives very good results immediately done, and then the nerve grafts help us in bridging the gap there. So very good gratifying post-op results. The nerve transfer classically for upper brachial plexus is spinal accessory to suprascapular to get the shoulder abduction like this. So this is the transfer being done here. The other one is for axillary nerve. So for the axillary nerve, again, we go for a branch from the radial nerve here to the axillary nerve at this point here. And then this is the transfer. These are all short target transfers. The amount of nerve vesicle to actually grow through this is a short period so that the nerve recovery is faster in these patients. So this is the pre-op of the same patient. We have done both suprascapular and axillary nerve. So that is the paralyzed limb on this side. And now he's gained both the abduction and elbow flexion, both the very nicely gained range of motion in these patients. Now, if you come to elbow, again, nerve grafting is an option. Infraclavicular injuries with a lot of extensive fibrosis, we can do the sural nerve grafting here. And we have used almost 15 centimeters. So this is the normal limb, abnormal limb here. Elbow flexion is not there, pre-op abduction and flexion is absent on this patient. And now with this grafting, we have used both radial and axillary nerve here, good elbow flexion and also good abduction of the shoulder. So this is the recovery we see. Now, if you take the nerve transfer, as I told earlier about the oblique transfer here, we have used the ulnar nerve here, and it goes to the musculocutaneous nerve and also to the median nerve here for brachialis muscle. So that gives very good elbow flexion in this patient. So this is a patient example for upper plexus injuries where we have used this kind of a transfer here. This is a normal side, and he's gained very good elbow flexion here because of the nerve transfer and the shoulder abduction also. So these are the good results we get in these patients. Intercostals are also used for elbow flexion and also in global palsies. It can be used for musculars, for intercostal muscles, nerves, 3 or 4 nerves are used for all these for musculocutaneous and for median nerve, and a minimum of M3 power can be expected with this. So this is an example of recovery of biceps where we have used the intercostal nerves here, and that is the recovery you see in this patient here. Global palsy, you see there's nothing here. When everything is avulsed, there's only neuroma here. There is absolutely empty C8, T1, avulsed C7. It's all a fibrous mass here. nothing much can be done. That is the time we use free functioning muscle transfer, the gracilis muscle here, which can be used, the entire gracilis muscle with this pedicle and neurovascular bundle, and that is laid down here, and the intercostals are used as the power here, and the local artery is used for vascularity here. It gives a very excellent results, and in this patient it is powered by intercostal muscles. This is a global palsy, but he's got a good elbow flexion here. That is a gracilis which is contracting now here, and that is the result which this patient has got. There's another patient here. Gracilis was powered by spinal accessory. Patient can hold object. This is the elbow flexion is achieved with this, and he can hold up to about 1 kg of weight with this limb here. So that is the power he has got with this gracilis transfer here. We can use double muscle transfer also, gracilis and adductor longus like this, which has got very good results here because you get better elbow flexion control. It also gives much more power. This function is achieved in about 10 months after the procedure. Sensory reconstruction is another area where primary nerve grafting is done, especially on radial side of the hand. This is the sensation we want. Pain relief is also good in these patients. So we have used here in upper brachial plexus, we have used the ulnar digital branches here towards the radial digital branches here to get good sensations. The newer modalities are electrical stimulation of the nerves. As soon as the repair is done, we do this, or conduit laden with drugs with regenerative kind of properties, and fat grafts of the nerve repair side. These other technology is bionic upper limb reconstruction, especially in upper limb in global palsies. So these are the new modalities here which are being used nowadays. So the need of the hour is basically a good clinical diagnosis, documentation, judicious use of investigations, early referral system for early surgeries is a very, very important thing, especially in avulsion injuries. Long-term rehabilitation program involving surgeons, psychiatrists, psychologists, therapists, and social workers, and multi-center cooperation for clinical research and trials. Development of patient-reported outcome evaluation and scores is also very, very important in this situation. Thank you for your attention.
Thank you, Dr. Anil. That was a great lecture. Really surprised by the amount of the advancement we have in the management of brachial plexus lesions. Because when we were doing a postgraduate studies, we just started to hear about surgeries on the brachial plexus for injuries. And I'm really seeing the advancement, to what an extent we have advanced in the management of these, one of the most difficult problems, I should say, in brachial plexus injuries. In fact, I'm
Anil,
surprised by the response for the sensory nerve surgeries for sensory nerve recovery also. Are they really working, the sensory nerve repairs?
I didn't get you, sir.
No, the sensory nerve, see the nerve procedures to recover the sensation. Does it really work as good as the motor recovery?
Yeah, we expect about S3 kind of a function. Right now, we're doing the very distal transfers and short transfers using the digital nerves. So they are giving much better results now, actually. And almost S3 kind of, they get their protective sensations definitely back. And then the 2-point discrimination, generally, it improves over time. But we're seeing much better results than what we used to see earlier with this targeted kind of transfers.
Yeah, Anil, one question.
Can I ask a question?
Yes, sir. Yes, sir.
So the bigger problem is if there is a partial brachial plexus injury, diagnosis is a major problem. I know you said MRI scan needs to be done 2 to 3 weeks after the injury. Clinical examination, of course, is the mainstay there, but what about nerve conduction EMG studies? Do they have any role in brachial plexus injuries?
Definitely, as in we correlate all these three together. So the point was being told was that the nerve conduction studies and the MRI, they might not be useful on day one. A lot of times we see that patients do get an MRI on day one or NCV is done on day one. Even in peripheral nerve injuries, the same thing happens. So generally for the Wallerian degeneration to start and then, it takes time. So generally we expect changes to be seen by about 3 weeks to 4 weeks. That is when the first MRI and NCV needs to be done. And as you know, the NCV is basically a comparative thing. So we need to again sequentially do this and see what is the recovery which is happening, or if the progression is stopped. So that is when we take the decision. But as of now, when we know that it's preganglionic, there's no point in waiting. There's no point in doing NCVs and MRIs and waiting. We know it's preganglionic, it will never recover because it's an avulsion. Now, if it's post-ganglionic, we again go most of the time by clinical recovery as such. So the EMT and NCB recovery always precedes the clinical recovery, if at all. So unless we want to document that, we basically go by clinical recovery. By 3 months, like even in a child, a birth palsy, by 3 months, the biceps is not recovering. We tell the parents that it might be a case for exploration. In an adult, the same thing happens. So 3 months to 6 months is the time for decision making, not beyond that, because we are losing time. For the nerve to recover right from the neck to the hand, it takes time. So anything which is delayed beyond 6 to 9 months means the patient, by the time the nerves, the intrinsics are innervated, we lose time because of the degeneration of the neuromuscular.
The earliest nerve conduction study should be done at 3 to 4 weeks.
3 to 4 weeks, yeah. So for us to at least sort out between neurotomesis and an axonotomesis kind of a picture. Yes.
Anil, one question, Anil. At 3 months from a global palsy to partial recovery and become static. Now, exploration might lose the function which has recovered. So, how do you judge which one to explore?
I think it also is based on the pattern of recovery. Now, if you have a recovery which is kind of progressive, right from proximal muscles down and it stops somewhere in between, then we know that the recovery pattern is correct. But there is some problem is there in terms of further recovery. So you need to go back and check in terms of you visualize it, do an MRI, or you do a nerve conduction, but tell the patient that that exploration is really worth it in terms of the recovery, the quality of recovery. Now, what is recovered now might not be the good quality of recovery. That's what we see even in birth palsies. The parents are scared because you might lose the movements, what they have recovered. But if you look at the quality of recovery itself, it's not so good. So in that sense, we need to weigh the pros and cons. We need to balance out what is better for the patient and take a decision at that time.
So the chances of losing the recovery which has already occurred, doesn't it reflect bad if you try to explore which is partially recovered?
If it is something like a shoulder which has recovered, which can be always substantiated as in substituted by some other better procedure later on, I think it's worth going exploring, because what we require now is the distal function, the elbow flexion, hand function. So the weight of that goes much more than the shoulder recovery. So that is how the balance should happen. And we tell the patients it's worth exploring. Even if there is some loss in shoulder function, it can always be compensated with some other procedures. That's very important.
Okay, thank you, Anil. I think we're running short of time, sir. We have the last talk.
Yeah, we'll go to the last talk now, the Charcot foot by Dr. Venu Kavartapu.
Good morning. I would like to thank the organizers for giving me an opportunity to share our experience on the surgical management of Charcot foot and our changed concepts. We have a lot of emphasis on the surgical reconstruction of deformed Charcot feet in this country because we know that the global prevalence of diabetes has been on the rise, and this is contributing to most of neuropathic foot deformities and ulcerations, which in turn lead to a high rate of lower limb major amputations. Lower limb major amputations following, for example, trauma is not a big deal. These patients do very well, but a major amputation in a person with diabetes carries a very, very unacceptably high risk of death rate. 10% die before leaving the hospital. 50% develop contralateral foot problems because neuropathy is a bilateral systemic disease, and more than 50% die within 5 years, which is worse than common cancers. So for that reason, in the UK, there has been quite a lot of emphasis on introducing multidisciplinary diabetic foot care to save these limbs and lives. And we at King's College Hospital are very fortunate to have one of the biggest diabetic foot unit led by the diabetologists with support from surgeons. I'm the orthopedic lead for this service, and a podiatrist, orthotist, and a microbiologist. Of course, other members of the MDT contribute to as and when required. So ours is the largest in Europe, oldest as well. It has been running for the past 39 years, and we receive about 13,000 patient attendances per year. And we run combined diabetic foot orthopedic clinics where we receive referrals for Charcot foot reconstructions and other diabetic foot deformity corrections. So our aim is to provide functional limb salvage. And this program was started in 2006 when I joined this unit. And we are a quaternary referral center for the country. So we, in essence, offer complex diabetic foot deformity corrections in our unit. Our aim is to provide a stable, plantigrade, normal-shaped, infection-free, ulcer-free foot so that the patient can mobilize full weight bearing in shoes. You know, the aim is to maintain the ambulatory status of the patient, not to achieve normal mobility. We can never achieve a normal mobility, but patients should remain ambulatory. At that time, we went through the options available, whether an external fixation or internal fixation. So again, Charcot foot problems come with poor bone stock. Even that existing bone stock has very poor healing potential. And many patients come with wounds and ulcerations, problems with skin coverage. And also at that time, the notion was that internal fixation always fails. So the published literature at that time showed high rate of failure of internal fixation. So naturally, we chose the external fixation option. If you look at the literature available in those days, it supports that the union rates were around 70% with an external fixation, a braceable foot around 80%, perioperative amputation rate of about 4% with a list of failures. So, however, that was the best possible option. So we went for an external fixation for all Charcot foot reconstructions. And in fact, we have one of the largest limb reconstruction unit at King's Cross Hospital. So we are very heavy users of frames in the region. So this patient with long-standing deformed Charcot and ulceration was managed with an ring fixator. And most of these patients are heavy, very high BMI, severe neuropathy. They don't feel what's going on in the foot, so they don't appreciate all the weight-bearing related issues. So this patient had breakage of the pin at 5 weeks, and the frame had to be removed at that time because they started developing pin side problems. So we removed the frame. Clearly, no union. A crow walker, Charcot restrained walker was given, but was not manageable. So the patient did not undergo a proper reconstruction. A few other examples, but this example, you know, young patient, high-level executive with diabetes and severe neuropathic foot with ulceration, overloading along the lateral column, beautiful correction with the frame. The corrected picture on the left side, again, the deformity recurred within 3 years. This patient had the frame on for 3 months. So out of 9 procedures we did, non-union was seen in 7 feet. Frame had to be removed a bit early in 6, means less than 6 weeks duration. So, well, this pseudoarthrosis may be an acceptable outcome. But if you look at our experience, we have an open access clinic. All patients are followed up for their life. What we noted was that pseudoarthrosis is not good enough. The deformity recurs with time. If there is no bone fusion, if there is no stable fixation, the deformity recurs. Again, back to square one. So the ideal outcome is to achieve bone fusion and mobility in shoes. So we felt that this external fixation choice is not good enough for our patient in our unit. Well, what else was available? You know, Samarco published this nice study on the benefit from the usage of long segment internal fixation principle in Charcot foot reconstructions. For example, this midfoot Charcot with navicular cuneiform disease receives long segment fixation with normal headed screws that span the whole column, and in fact through the lesser metatarsus as well, inserted antegrade or retrograde, normal headed cannulated screws, but better devices were developed later, and Samarco gave this name Superconstruct. And there was a lot of optimism regarding this, but there were quite a lot of failures too. And we were early adopters, and there were failures, and we published our experience. But however, the learning point from that was that if that durable long segment fixation has absolute rigidity, the success rate is very high. So this is our principle now: a durable long segment rigid internal fixation with optimal bone opposition. And I'm going to share our experience of Charcot foot reconstructions using this principle. Of course, we always had very active vascular management in this group of patients. About 25% of them had preoperative vascular procedure done. Again, very targeted infection control. A lot of these patients, all patients had deep tissue specimens and bone biopsies taken. Advanced wound care. If there's any open wound, we apply vac dressing, occasionally plastic surgical procedure. Multidisciplinary approach is a key, and the medical optimization and advanced multidisciplinary medical care is critical. But this talk is to cover this modern internal fixation principle and our experience with that. So look at this midfoot deformity, Charcot causing rocker bottom deformity, splaying of the base of the metatarsals, and clearly there is excessive loading on the plantar aspect of the midfoot. So this was corrected with wedged bone resections. After the deformity correction, the fixation was achieved using a long locking plate spanning the whole medial column and the lateral column as well. Locking plate provides nice rotational stability as well as axial stability as well. A different example of the midfoot with plantar osteitis of the exostosis. Exostectomy was done, and again you can see that the calcaneal pitch has improved here because we've done percutaneous tendo-Achilles lengthening, which is done in many or most of these Charcot foot reconstructions, because soft tissue balancing, which means releases of Achilles tendon, if required, tibial posterior tendon, peroneus longus tendon. Balancing is also critical. Along with that, wedge resections to correct the deformity. Plantar-based wedge with some medial component here is absolutely critical that you achieve good optimal bone opposition. And now this is a little modern device called a beam intramedullary device along the entire medial column. Provides fantastic primary fixation, primary stability, but the rotational stability is not adequate. So I always supplement with a locking plate over all those joints were prepared. So all those joints intended for fusion have to be thoroughly prepared. On the lateral side, a locking plate, because a small diameter beam was not available in those days, but now small diameter beams are also available. Coming to the midfoot plus hindfoot deformity, this patient who has been wheelchair bound for a number of years. Again, hindfoot correction first using an intramedullary device here. Joint preparation is critical, and the residual midfoot deformity correction is done by doing a separate midfoot osteotomy. Here, the medial column plate has been extended to distal tibia. That is our typical fixation for combined hindfoot and midfoot, because this part provides rotational stability of the hindfoot nail, because the hindfoot nail doesn't provide absolute rigidity in the rotational plane. And this patient, again, remained infection-free for 7 years, has been mobilizing full weight bearing. Slightly more complex, another example, very severe hindfoot and midfoot deformity, previous lateral ray excisions, lateral border ulcer following ulcer debridement, and deep tissue and bone specimen harvesting, microbiological cultures, IV antibiotics. We managed to get rid of the active infection, but the deformity is quite bad here. There is SFA occlusion as well. So SFA occlusion has been addressed first, and then the deformity correction using a long translateral malleolar approach to access the ankle and subtalar joint. That includes the previous infected ulcer. All of that exercise then hind foot correction, stabilization and compression with proximal and distal locking, and residual midfoot deformity with wedge resections, correct, and locking plate fixation on this occasion. And again, the medial column plate is extended to distal tibia to provide that additional rotational stability. And this patient has been, weight bearing for the past 3 years and retained his limb. So we have done 122 Charcot, hindfoot, midfoot, and combined reconstructions in our unit. And a number of studies have been published, but let me share this, not the most recent, but the previous one. The most recent series was about metalwork failures, but my team is currently writing up the full larger series. So this one was published in 2018, 42 hindfoot corrections in 40 patients, mean age 59, many had chronic ulceration, high-grade ASA 3. The mean follow-up at that time was 42 months, and we had 100% limb salvage and 97% fusion rate. 83% patients were able to mobilize independently in shoes, but we still had a significant number of complications, including metalwork failure, infection, and ulcer reactivation. So, however, I'm glad to share our modern internal fixation approach, but the critical component is to provide the patient-centered multidisciplinary approach that is specific to the patient's needs, the patient's deformity, patient's medical comorbidities. With that, I would like to thank you for your attention. Good day.
Thank you, Dr. Venu, for that very good work on Charcot joints. Are there any questions now?
Yeah.
Just one question will permit.
Dr. Pandian, yes. Yeah. That was, I think, previous question. Can I ask Venu? Hi, Venu. Thank you very much for waking up early. Excellent talk. I know you've done a lot of work on Charcot foot. Can I ask you, how long do you wait before you say, because most of the time this union achieving a good fusion is a difficult problem with these people, and by the time it joins up, metalwork falls out. And what is your protocol? How long do you wait before weight bearing? How long do you wait before everything is okay?
Yes. So there are 3 components that help you achieve bone fusion more predictably. Number 1, optimal bone opposition. In the past, we tried very expensive modern adjuvants ranging from BMP, PRPs, and everything. None of them seem to help in promoting healing of Charcot bones. But optimal bone opposition, if you achieve almost nice compression and 100% bone opposition, the bone fusion rate is greater. Number 2, total contact cost post-operatively. Again, total contact cost is a similar type of very custom-made offloading device can provide amazing bone healing response. Number 3, very long segment rigid fixation. That has actually transformed our ability to reconstruct these. They have to be durable, long segment, and very rigid. Rigid, not just an axial, bending, but rotational as well. And again, that seems to work very well. But despite all these, the fusion rate is less in this group of patients, but much, much better than what we thought in the past.
Thank you, Dr. Venu.
Go on,
I think, okay, thank you, Venu. Like, I think we come to the end of the session, rather a long session and very interesting too. And I should appreciate all the speakers for sticking to time, and then they were also sticking to the topic that was given to them. We've seen the change in the scenario of the management of various difficult problems, I should say. Each one of them had their difficulties, and that was a very interesting. So though it was a very long session for us, rather tiring, but it was very interesting, and then that made us sit for the entire session. So I take this opportunity on behalf of our president, Dr. S. Pandian, and myself for giving us this opportunity. We thank the organizing committee for this. So may I now hand over the proceedings to the organizing committee to proceed with the next session. Thank you.
Yeah. Thank you very much, Dr. Pandian and Dr. Nali, for excellent program, great moderation. And thank you all the speakers, especially overseas speakers who woke up early in the morning and answered all the questions. And it was a wonderful session. And thank you for all the participants. We would like to close this session and move on to next session. I will hand over to Dr. Raghav Dutt, our team leader.
Thank you, KJ. That was wonderful. And I'm sure we're all enriched by the quality of talks that we heard since morning. Thank you once again. Every scientific conference should have some non-academic sessions. And this is one of the 4 non-academic sessions. One of them is perhaps a part academic concerning OSS. And today we'll be starting our interview or discussions with Dr. Jayaprakash Narayan. We can start the video whenever we are ready.
Raghav, the secretary and the president have to get in. Shailesh?
Sailesh?
Shailesh, 1 second. Will Raghav, Sudhir and they are not online.
Yeah. Yes, sir. I think problem is on behalf of the Orthopedic Association of South Indian States,
Raghav, shall you ask him to stop? How to do it?
Yes, sir.
Shailesh, there's one Dr. Sudhir need to be given audio and video.
Okay.
Yeah. Sudhir, Dr. Sudhir, both audio, video to be given. Vijay Bhaskar, audio, video to be given.
Fine, sir. I'll do it.
Yeah. Okay. First, you do it immediately.
Start the video.
And then start the Jayaprakash, sir.
Okay.
Vijay, Sudhir and Vijay Bhaskar, both audio, video to be given. Sudhir, login in, login in, Sudhir. Shailesh, Sudhir is there?
MV, they can start the video.
Yeah.
The others can join. The video is about 45 minutes long.
Yeah, you start the video, Shailesh.
I'm not able to see Mr. Sudhir.
Okay, you start the video. We'll ask Sudhir to join.
Don't worry, we'll join later. Start the video.
Start the video.
Fine, sir.
Good evening. On behalf of the Orthopedic Association of South Indian States, I welcome you all to this wonderful evening when we have the opportunity to learn from one of the greatest sons of our soil. We all call him JP very affectionately. He is Dr. Jayaprakash Narayan, one of our own. He left medicine and joined the civil service, and he was a star when he was an IAS officer in the erstwhile Andhra Pradesh, combined state of Andhra Pradesh and Telangana. One day, out of the blue, he resigned. That was a bombshell. All the newspapers, TV channels were all wondering why this man, who is at the zenith of his career, suddenly left his job. He started Lok Satta, I would call it a pressure group, and went on speaking about various aspects of our country, how to develop them, the ills of our country, and the good thing about our country. In 2006, when I in Hyderabad, when I conducted the Association of Spine Surgeons of India meeting, he gave a talk. It was for 30 minutes, and the question answer session went on to almost 1 hour 15 minutes. And Dr. Dubose, who is one of the world's greatest spine surgeon ever, some of you spine surgeons would understand what I'm saying. He got up in the end and he said, I wish we had a few men like Dr. Jayaprakash Narayan in France. That is the depth of this gentleman. It's our pleasure and honor that he's joining us today to have a small chat about what we feel about our country, what should be done to our country, how great we are, why we are not going leaps and bounds in various aspects of our country, be it economy or other things. So I thought I'll ask him a few questions, and then of course he will give us a message to the South Indian orthopedic surgeon community, which is a huge, big community. Thank you, Dr. Jayaprakash Narayan.
Thank you, Raghav, for your kind words. I am honored to be with all of you.
There is a crisis in India. The COVID has unfortunately put a brake on our development, whatever that was taking place. And then suddenly there's a loss of jobs, there's migration of workers, there's a huge emotional issues. So can this crisis be converted to an opportunity for a country as vast and as diverse as India? How do we take India to the next level at this juncture or from this stage?
Absolutely, Raghav. Paul Romer, the great economist, Nobel laureate, he said, a crisis is a terrible thing to waste. And in a country like India, it's often crisis that precipitates reform. If you take the 1991 economic reform, it was not because of a very careful, well thought out structural reform out of conviction. It was a reform driven by compassion. Now, in a way, this crisis also gives us an opportunity. But we must recognize that our economic problems are not because of COVID. COVID accelerated, aggravated it. Our economic problems are structural, partly because of acts of omission, the government's failure to act in building infrastructure, building a framework of rule of law, in giving quality education and skills, building healthcare systems so that productivity is high, so on and so forth. Partly acts of commission, wrong policies, a license permit quota Raj, over centralization, and an excessive emphasis on government's control over the economy and public sector, so on and so forth. Now, we must address these challenges even as we take the opportunities that present themselves in the context of this crisis. For instance, you take the healthcare itself. Now, COVID is a healthcare crisis, apart from being an economic crisis. Now, it's a great opportunity for us to move forward and do something substantial. Maybe we can discuss that a little later. But India is one of the worst in the world in terms of healthcare outcomes. But India can be remarkably good relative to the expenditure that we incur at a relatively low cost. And all of you are great examples of tremendous skills and strengths in our system. But we are not leveraging those strengths to provide decent health care to most of the people at a relatively low cost. Similarly, the Prime Minister talked about land, labor, liquidity, and loss, the fundamental reforms. We must walk the talk. We must remove the hurdles because
Meanwhile,
Dr. Jayaprakash? Dr. Jayaprakash Narayan? Yeah, hello. There is some problem. The program is going so well. I think there's a problem in Delhi, but we will play the video later.
Okay.
And welcome back. And we are now heard by the orthopedic surgeons of South Indian states. Now, I think continuing further to what we were discussing earlier. Now, part of the democratic process in this country, which we are all very proud of, is not delivering. That is the feeling, especially amongst middle classes. The rich are getting the benefits. The poor are getting freebies by the day. Every party is worried about how much Yojana, Pradhan Mantri Yojana, Rajiv Gandhi Yojana, every Yojana of the Congress party, now the BJP also is doing similar things. So who cares about middle classes? What does democracy do for us? That is a question that is there in the minds of most of us. I mean, we love our democracy, no doubt about it.
Raghav, let us look at the bigger picture. You look at the United States now, a country with immense experience and mature institutions and great wealth, is not able to create a mechanism whereby everybody agrees on the election verdict. Even yesterday, the incumbent president said, I don't accept the results, it's all a fraud. Consider what's happening in India. Our constitution makers, only yesterday we celebrated the Constitution Day because 71 years ago, yesterday, our founding fathers approved the Constitution, while 2 months later, we promulgated Republic. They created institutions that will ensure peaceful transfer of power, regular elections, and constitutional authorities of great stature, which can resolve these disputes. And we also improved our federalism, but the problem is the issue you're raising. It is caused by two fundamental problems. We haven't addressed them. The first problem is power is so centralized in this country that people do not any longer understand the link between the vote they give and the consequences that result to their families. You know, a general Bharat Mata or some other grand theme is inconsequential. It may raise slogans, but it does not really appeal to your enlightened self-interest. So from an ordinary citizen's point of view, the recipient of freebies, as you were describing, the election has no genuine consequences which are better than the short-term freebies. And therefore, when the political parties or the candidates offer money in the election, or the freebies which they can understand, I get something free, which is tangible, which is real, I can taste it, I can feel it. In a poor country, they fall for that. Because the things that actually matter to him, the family, they are not delivered through the electoral process. The second reason for this is, power is so centralized in India that your life and your vote are completely different things. Let me give a simple example. I live in an apartment. Supposing the lift does not function, the elevator does not function, I'm not going to keep quiet. It's not about Bharat Mata and Constitution. It's about a daily necessity, and I'm paying the monthly maintenance fee. Until the lift is set right, none of the apartment dwellers is going to keep quiet. And we're not going to choose a leader to run the apartment complex unless we are confident that the lift actually functions well, the electricity is there, local outages are not there, water supply is there, etc. So unless power is decentralized with accountability, democracy will not work. So we have a notional democracy with vote and shout. We have no real democracy where the people understand the value of the vote. Therefore, the answer lies in figuring out a mechanism, creating a mechanism, both of decentralization of power and of defining the role of the state effectively and focusing on that, so that the people value the vote more than the freebies they get or the money they receive. It's not an easy process, Raghav, but who said democracy is easy? We have no choice. We have wasted 70 years. Let me just mention one thing. Even autocratic countries like China, we all know it's authoritarian. Their city governments are far more powerful than our city governments, our local governments. I say it with great deal of pain. Even countries like Pakistan and Bangladesh, which were formed along with us at the time they were part of us earlier, and they were autocratic for most of their post-independence period, and there's no regular democracy as we have experienced in India. Despite that, in Bangladesh and Pakistan, the local governments are far more powerful than in India. Look at Delhi, a live example. Delhi is the only city-state where the local government is relatively more powerful. It's not really powerful by global standards, but it is India's most empowered local government. Delhi Chief Minister is India's most empowered mayor, though weaker than mayors elsewhere. But even that limited but definite empowerment is making the people realize the value of the vote. And in general, you can see the trajectory, irrespective of party politics. I'm not going into party politics. But the vote is no longer determined by either a short-term freebie excessively or the money that changes hands. People are discovering the virtue of government and its functioning. So we have to redesign the governments and empower at least the cities to start with. And we have to redefine the role of the state and focus on things that really matter. It is that failure that made our democracy dysfunctional.
Okay, JP, I have two questions on this. The first question is, if you say that we should decentralize, which I know you're a very ardent fan of that.
Yeah.
Now, with a country where, me and my wife speak different languages. So all of us speak different languages, and we have a million parties in this country. Each party tries to win the next election. They're not bothered about the country as a whole. And we have seen the problems in Sri Lanka due to various reasons, political reasons. We had problems with them. So a lot of these political parties are not going beyond their state level. They don't think of the country as such. Now, if we look at Indian history, as I understand, India was most powerful and at its best when it was ruled by very powerful kings. So in a country as diverse in language, culture, heritage, etc., why not a big, powerful center to control the country?
Raghav, the answer is much more nuanced. Nobody argues against the unity of the country or a strong and effective federal government at the union level. But unity is not uniformity. One mistake many of us tend to commit without thinking deep is unity and uniformity are the same. We are a continental country with 1.38 billion population. There is no way somebody sitting in a big city, let's say in Mumbai, can make all decisions even for Maharashtra, let alone somebody sitting in Delhi making a decision for Hyderabad and Bengaluru and Chennai or your village and a small mandal, because they don't know. It's not that they're bad fellows. They simply don't know. Therefore, the things that ought to be handled at the national level, certainly union government must be adequately empowered, must be strong, must be able to unite the country, because I'm a fierce advocate of unity of India. Just as I'm an advocate of decentralization, I recognize the value of a common market and unity of India. Because if India is not united, we will beat each other up. Our liberties will be at stake, and our economic growth will suffer because the benefit of common market will not flow to the country. I completely agree with you. But it does not mean that Delhi knows what is best for you in your city or your mohalla or your town. They simply don't have knowledge. The second problem with the over-centralization is, if you commit a mistake, an error of judgment, it will affect the whole country. There is no corrective. If 1,000 cities, 1,000 local governments are allowed to function on their own within a broad umbrella, I'm not saying they can be anarchic, but within a broad policy framework, then the cost of innovation is very low. The benefit of innovation and therefore the emulation of best practices is easier. You are not afraid that you commit horrendous mistakes. Look at demonetization. It was a well-meant thing. People of India supported. It was done badly. Of course, there's no choice but to do it at a federal level. But the problem is it was done badly without even finding alternative currency in place. When I take away your currency, I must give you valid currency because it's valid money. Without even printing that currency and putting it in place in advance, we simply demonetized. There was some error at some level, at the federal level. But see the horrendous consequences. Or 100 other things. You cannot make decisions for the whole country at one place, except those areas where the decision making has to be national. There's no choice. Otherwise, why is China, an autocratic country with Communist Party monopoly, allowing the cities to govern themselves? Because they realize Within the broad policy umbrella, the government is far more effective locally if they're empowered, provided there is accountability. So there is no reason to believe that the unity of India is in danger if you allow diversity. At the same time, there must be a broader policy framework. There must be a sense of national unity that must not be compromised in circumstances, because take Yugoslavia, erstwhile Yugoslavia. The moment the nation was allowed to dismember, the kind of violence unleashed, the bloodshed that was seen, and the liberties that suffered and economic consequences were horrendous. Therefore, I believe national unity is paramount. But unity is not uniformity. We must never commit that mistake.
Okay, then, we feel to an extent the politicians have failed the country, but I'm beginning to believe that the judiciary has failed this country even more. And I cannot imagine that there is no doctor in this country who doesn't work hard. You know that. You've been a doctor yourself. And the Chief Justice of India comes out and cries that he is working hard. I cannot believe this. I cannot believe this. And when we hear that hundreds of doctors died in this country for taking care of COVID patients, right? And we have seen how brutally our soldiers were killed on our border recently in Ladakh. Why are these people saying that they're working hard? You don't become Chief Justice not for nothing. You are put on that pedestal to work hard, bloody hard. And if we say that, we are put in jail for contempt. And the second question, is there democracy in our judiciary system? They are appointing themselves. It's a coterie. Like it or not, we have elected democracy as our country to rule our country. Are they not accountable to the parliament? And they're objecting to it. And when it comes to cases, it is so bad. The quality of judges is bad. Their judgments are bad. They're reversed every alternate day by the Supreme Court. Why are they not taking care of their own system and cleansing the system? What do you think of this?
In fact, quite by coincidence, in the next couple of months, I'm organizing a national conference on this subject of rule of law. What needs to be done? I entirely agree with you. No, the popular notion in India is that all politicians are bad, bureaucrats are better. And over time, even bureaucrats are bad, courts are bad. But the truth is that we are all victims of a vicious cycle. All organs of state, all elements of government, they are dysfunctional in this country. The courts are not immune from that. And therefore, a series of steps that are required to ensure speedy and efficient justice, which is accessible. Partly it is the courts failing, partly procedural problems, partly inadequate empowerment, because in a vast country of our size, we have far too few judges. We have dilatory procedures, and we have very expensive processes. We have to change all that. It's a very complex thing. The crime investigation part, the prosecution part, the trials part, the procedural laws, the civil procedure code, and a whole lot of things we need to change. Second, you raised the issue of the judicial.
मैं आपकी वीडियो प्ले कर दूं क्या अभी?
मत करिए.
Okay, fine, sir.
What happened is, because we are angry with our politicians in general, we gave too much of respect to the courts and too much of a role to the courts in areas which are not their province. The courts must do their job. The government must do its job. And there must not be unnecessary overlap. At least overlap should be minimal. Unfortunately, because the people are increasingly reliant on courts, because they lost faith in the political process and in the bureaucracy, the courts have started believing that they are actually bureaucracy and the political government rolled into one. They have forgotten their role, and they're trying to interfere in day-to-day executive functioning, which has grievous consequences. Firstly, a government has to deal with 100 issues at a time, not one issue. Courts have the luxury of examining one issue at a time and taking 5 years. Secondly, the courts can pretend that all resources can be deployed for one case to be popular, but there are 100 things. There's always shortage of resources and multiple issues to be addressed. And third, by blurring this jurisdiction, the basic principle of separation of powers is violated, and therefore you are misoperating the Constitution. On all these grounds is bad. As a part of this, the courts have gone to the extreme extent of saying that they will appoint themselves. There is no democratic country in the world where Any organ of government appoints itself. Ultimately, in a democracy, you must be accountable to people in some form or the other. The legislature and the executive must have a role in appointing judges. And that's why my organization and I have been in the forefront of the fight to create a National Judicial Commission. It was my advocacy. We put together a great team of eminent jurists, Justice M.N. Venkatacharya, Justice J.S. Verma, and Justice Krishna Iyer. And they came up with a model, and that's how the National Judicial Commission was created by the 99th Amendment to the Constitution. Unfortunately, the courts have quashed that. In my judgment, the court's order is wrong, but one day the nation will discover that. But I believe that this is the third short point I'd like to make. While there are many things wrong with the judiciary, we have to be very cautious about our approach to improving the judiciary. We still require an independent and strong judiciary because that is the last bastion to protect the liberty of citizens. And therefore, while we criticize them when they are wrong, we must do it with great dignity and with our understanding of the deeper institutional framework. Because the individuals may be wrong, but institutionally we need a strong court, because if that fails, there's nothing else left in the country. Therefore, we must figure out a mechanism to persuade the political parties and bring a consensus in the country, and in a pragmatic way to bring about change. And we are in the forefront of that effort. That's the reason why this year we've chosen the theme of rule of law. We are bringing eminent jurists, lawyers, the police officers, the civil society, and of course the political leaders together to look at institutional mechanisms to make our judiciary function much better. But you're right, it's not one organ or the other. All of us are in this together, and we are all victims of a vicious cycle.
JP, I'll ask you a question then. Now, who should tell them? For example, Nirbhaya case, it touched the conscience of this nation. Children went on the streets. There were candlelit marches all over the country. This girl was brutalized. And when I heard from my colleagues from Delhi, what was done to this girl, they put a jack in her internal organs and twisted her intestines. They were in the court. And our Chief Justice says, when he was asked, when will this case come up? He says it is some 10th or 13th or 17th on the list. It will come when it will come. If this is what the Chief Justice of India says, should I as a citizen keep quiet for fear of being, being called contempt of the court or whatever? Two guys kill each other in some Rayalaseema, some corner of this country, and that case comes up first. A child who in a free country should be walking free, and the duty of the nation to protect this child, they were caught, kept in Tihar jail for months and on. Can't the judge call this case and do a continuous hearing as they do in US and UK and all these Western countries? If that is not done, another girl, the same thing happens, Disha case in Hyderabad, and when then they are shot dead, people are openly coming out and giving sweets to the police. And believe me, this time it was men who were protesting. Unlike women in Disha case, more men came out on the streets and protested what happened to this young doctor. Now, in this situation, are not individuals of the nation bigger than the institutions? And why are these institutions sleeping? This is not justice at all, in my view. My heart burnt.
No, I think many in India share your anguish and concern. There's no question about it. But if you view it from an individual judge's point of view and court's point of view, annually there are about 30 to 40,000 murders registered in this country. There are about 32,000 rapes registered, 32 to 35,000 rapes registered annually. There are many other cases. Now, when the Prime Minister of India, former Prime Minister, was brutally assassinated, it took 18 years for the courts to convict those fellows. There cannot be a more heinous offense from the national point of view, from a major leader and a former Prime Minister being assassinated. So, our judicial processes are absolutely dilatory and very weak, and there's no rule of law. And our conviction rate is only about 25 to 30%, and without confession, conviction rate is as low as 10%, the lowest conviction rate in the world. So we have a serious problem of rule of law. Now, in a particular case, it's natural that society sometimes vigorously responds and they want some instant justice. But my appeal is, unless we look at the bigger picture and create a mechanism for all the cases to be addressed very swiftly and efficiently. Merely because in a particular case, because of popular anger, we try and do something very quickly, it will not address the real challenge, because not every case, many cases may be as heinous, as serious as the Nirbhaya case or Disha case, but they may not get the same public attention. You cannot every day hope for the whole country to rise up in revolt and the case to be taken seriously. We have to actually make the rule of law work in this country. Our trial courts are the most important. It's not the Supreme Court that should deal with that. The trial courts, that's where we have to strengthen. The judges' number, the procedures, the cluttering must be removed so that the small case can be handled at the lower level, what they call people's courts in America, or the small claims courts in the UK. In fact, I myself was instrumental in creating a law in this country with popular consensus in the parliament, the local courts law, which is not operated adequately even now, though the law exists. So we have to make many things happen. And I absolutely agree with you that rule of law, the faith in rule of law, the confidence that people can be protected and the guilty will be punished swiftly, and civil cases will be, the disputes will be resolved fairly and efficiently and at a low cost. It's absolutely critical for social harmony and peace, for a sense of security and for economic growth. And we have failed spectacularly. And the failure is not merely that of the courts, it's that of the governments, because we are not devoting enough resources, enough number of judges, enough resources. In India, we have, for every 2 judges, 1 prosecutor. It's absurd. United States, for every judge, there are 10 prosecutors. To give just one instance for this, there are so many things wrong. We have to set many things right and very quickly. I completely share your sense of urgency, but unless we look at it together, holistically, and build a systematic approach, institutional approach to improve delivery of justice, merely emotional outbursts, however important they are, to understand the people's aspirations and therefore to address them, unless we do it professionally and intelligently and based on past experience and best practices, we will not be able to do justice to the cause.
A lot of panelists. Vijay Bhaskar, you want to ask any questions before I move on to, I have millions of questions to ask JP, because my mind gets clear when I speak to him over the years. Vijay Bhaskar? Okay, before they come on, I just want to ask you, do you think we are backward as a democracy because of too many parties? Do you think we should have a 2-party system like we have in United Kingdom or in USA? What do you think? Too many parties, every million parties in this country.
In truth, Raghav, if you take a state as a unit, because state is a unit of politics, the nation is merely the aggregate of states in our system of elections. US has a direct election of the chief executive at the national level. Therefore, by compulsion, the parties have to come together. In our country, you must take the state as a unit in general. And if you take states, in most states, there's actually a 2-party system operating. The fierce competition for power is between 2 parties in almost all states. The second issue is, you take the United States. Barack Obama was unknown to the country. But in no time, a competent man, a capable person with ideas, leadership qualities could emerge as the leader of the party, because you have created a democratic institutional mechanism for people to rise in power. You may or may not like Donald Trump. Donald Trump was a nobody earlier in the Republican Party. But in no time, he could emerge as the leader of the party and won the party. In India, we have not created internal party democracy, structures where any citizen can play a meaningful role in a political party, persuade the members, rise to power, and then get public mandate and bring about change. As long as that is the case, if political parties are bastions of individuals and certain families, they are private estates, feudal fiefdoms, I think they require more competition, not less. So the real challenge is, how do you make political parties true vehicles for people's participation? Today they are not, they're operating like private companies. If you do that, if you democratize political parties, leadership choices, the candidate choices, then I believe that you don't require so many parties. But right now, all these parties are so dysfunctional, they must be a challenge to their monopoly.
Okay, now the next question, and these are all my personal views, that this country, the politicians of all parties made sure that education is kept as low as possible. They made sure that the country's masses are not educated so that they can play their caste-based politics, the religion-based politics, and minority cards and all that they have been using for the last 70 years. So don't you think that the most important need of the hour is to, especially education in the rural areas, now that the cities have picked up quite significantly, and also education of the girl child?
I agree with you 100%. If there is one singular failure in India in implementing the spirit of the Constitution in the past 70 years, it is a failure in education. I don't know if many of the eminent doctors and others, they know the facts, because you're all the products of the best of our society. You rose despite our education system, not because of our education system. So oftentimes, those who are successful in our society don't realize how rotten our education is. Let me give you one or two statistics. In a global survey among 74 countries to measure educational outcomes at the age of 15, India ranked second from bottom. The only country worse than India in that list was Kyrgyzstan. Many of us cannot even identify it in the atlas. Kyrgyzstan. I went to town about it to shame our politicians and bureaucrats to look at what's happening in the country and to find out means of improving it. The government's response was shocking. Instead of improving education, they said, henceforth, India shall not participate in this survey called PISA survey. Like ostrich, we pretend that everything is okay. We do not even open ourselves to global comparison. 50% of youngsters between 14 and 18 years of age, this will be shocking to those of you who are not familiar with this. 50% in India today, 2020, cannot look at a watch and read time. I'm not exaggerating. About 75 to 80% can tell you the hour. Right now, my watch shows is 1 hour, 20 minutes in the afternoon. 70-80% are able to say something about 1 o'clock, but 1 hour, 20 minutes, only 50% of those between 14 and 18 years in India are able to tell time. Only 15% can put the appropriate weights. If you go to a market and want to weigh, let's say, 2.5 kilograms of brinjal, only 50% of the young people of India know how to put the appropriate weights. It is that bad. But the good news is the demand side is very strong. Every family, Hindu, Muslim, rich, poor, urban, rural, every family wants to give the best to their children. They're willing to spend disproportionate amounts to help the children. They're willing to sacrifice a great deal. As long as the demand side is strong, I'm using two expressions, there's no time to go into detail, but two expressions. If you define success intelligently, not your stupid examinations, rote-based or copying, but define success intelligently and measure success honestly and efficiently. And if you do a few other things, then in a very short period of time, our education will improve dramatically. First, we must recognize our education is a thoroughgoing failure. A few people are doing remarkably well in the country and outside, despite the education system, not because of it. We talk about our best doctors like all of you. We talk about Satya Nadella, Indira Nooyi, or Sundar Pichai, and we pretend that that's because of our education. No. Only 1% of our kids are comparable to the global norms. About 15-20% are well below global norm, but they can improve if an opportunity is given. But 80% have no future whatsoever. But the good news is recently, the national education policy has come. And I had the good fortune of playing some role in that. Kasturi Rangan committee invited me to advise them and also to offer remarks. And I peer reviewed in advance the report, and those inputs are taken into account. It's a very decent report. It understood the problem. It diagnosed it rightly. It provided a very robust and credible roadmap. If you actually now start implementing it, while it's already late, it's never too late. We can, within a reasonably short period of time, significantly improve educational outcomes. I completely agree with you. It's not entirely the politicians failing. They didn't pay enough attention, but it's a much deeper problem. Our society also must take care. It's not merely our children, but everybody's child. In a caste-ridden society, we must not think that the servant maid's child should be satisfied with substandard education. We must recognize that every child is entitled to have her potential fulfilled. And I think there is an opportunity now. We are spending enough money. Money is not a problem as a country. If you take Andhra Pradesh, Telangana, 80 to 90,000 rupees per child is spent per year for school education. Many of you will find it shocking. Many of us do not spend that kind of money. I never spent even 1/5 of that for my child's education. 80 to 90,000 rupees per child per year in school. So money is not the issue. And we can do a lot, and I hope we are beginning to do a lot with the new education policy.
Just to continue on that, before I let Dr. Ved Prakash ask the next question, this is the most dangerous question in this country, the most sensitive issue, right? I'm a supporter of reservation. Once you become a doctor, Dr. Ved Prakash, just 2 minutes. Once you become a doctor, you are the cream of the society. Why are you getting a reservation in post-graduation seats? And how come the Supreme Court of India says that, yes, even in promotions, they should be given reservations? Is that not demoralizing the people who work very hard, people who are achievers? That is one question. Second question, why should a doctor's child get reservation again? Why should a minister's son get a reservation? Why should a IAS officer who became an IAS officer on reservation or quota, again, his children become, get the benefit of reservations? Why can't we restrict one reservation per one family? Number one. Number two, once you get it, only to a certain extent. That way we can spread reservation to large sections of our society. And we know the politicians will not do it, and the intelligentsia are too scared even to talk about this. What are your personal views, Dr. J. Prakash Narayan, on this?
They're not really personal. I made them public and repeated. Perhaps the only one in India with some standing who made these views very public. I agree with you that some form of affirmative action is necessary in an equitable society. But the way it's done is actually hurting the very sections who are supposed to be benefiting. As you said rightly, an IAS officer, a minister, a doctor, if his child gets all the benefit, then the poorer families in that very community are actually not getting the benefit. That's not the intention at all. So there is a room for rationalization. One short comment before I come to the rationalization principles. The courts are not entirely guilty here. To be fair, the courts have consistently tried to bring some balance in this. But the largest number of constitutional amendments in India are on the issue of reservation. Every time the courts try to bring a balance, immediately the parliament comes in to amend the constitution further. So I don't remember the exact number, but probably 15 to 20 times out of the 103 times the Constitution of India was amended, the largest number of amendments were on the reservation issue. Repeatedly to try and undo the court's decisions, they are doing it. Because the politicians lack courage. Because it's not even popularity issue. Actually, if you do it right, it will be popular with the poor people. The three principles I believe that will be popular and necessary for the country are A, as you said, not the family, but if somebody already got a significant benefit, became a doctor or an MLA or an IAS officer or something else, or somebody is already has accumulated money honestly through entrepreneurship, then his children must be taken care of by him. The benefit should go to the other poorer members of the same community, not this family. I think the vast majority of the poor will actually support it because they are the ones who are going to benefit. Second, the ones who don't get reservation, we must measure merit much more intelligently, not in the crude way that we do. A child of a poor laborer from a so-called OC community in a village going to a ramshackle school, doing reasonably well, 85% without copying and with deep understanding of the subject. The son of a collector who gets 90%, we think 90% is about 85% nonsensical. We must give weightage to people with disadvantage. A reasonable weightage, no longer any quotas, is not possible. We already got the 50% everywhere in the country. But make sure that their real merit is measured appropriately. But the third and most important thing, reservations are about higher education and employment. The real foundations are extraordinarily weak. School education, we already discussed that. If school education actually is good, like in China, like in many other countries, if every child is guaranteed a certain quality education, irrespective of the circumstances of birth, then within a few years, every child can compete with any other child. The issue of reservation becomes less and less important. Progressively, you can reduce reservations every year. And within 15, 20 years, they become inconsequential. These three measures together will be popular or achievable will actually address the challenges without compromising on competence and merit. But politicians don't want to take the hard decisions because they're afraid to take even minimal risks. Therefore, a certain status quoism, inertia is playing a role. It's not even politically sensible. It's just inertia. Dr.
Vidprakash, you want to ask a question?
Ask the question which I was about to ask, and that is, when is merit going to get implemented in this country?
Dr. Vidprakash, as we discussed, if we raise the issue with evidence, making the poorer sections who are actually the losers, ultimately it's not you and I and our kids who are suffering. If our kids don't get an opportunity, we find other ways. We spend more money, maybe spend abroad, we'll do whatever it takes. Who are the ones who are actually suffering? The poorer kids, because of poor education at school level. Because the few opportunities, never reservations available are going to the first generation beneficiaries, perpetuating them for their next generation. The moment the poor understand that, and if you build an argument, then there will be support from the vast multitudes of India for rationalizing reservations. Then the politicians will have the courage. In this country, that effort is not adequately made. We are making it a discussion among people like us. And if you go to show reservations, typically, one second, what happens is the people who don't get the benefit of reservations are against reservations. The communities that get the benefit are for reservations. It's a zero-sum game issue. As long as it's debated as a zero-sum game issue, you will never find a resolution. We must honestly and openly look at the issues, find the evidence, and show that the formula that you're proposing actually benefits the poor, the disadvantaged, genuinely. Then slowly but steadily, political will be there. And in India, that work is not done by the media and the civil society, let alone political parties. The media and civil society also failed in India. We made them holy cows instead of honestly discussing them. Yes,
again, coming back to this education.
Okay,
go ahead. Please go ahead. Sudhir, go ahead.
For just a continuation for the same, for the poorer who want to get married, don't you think they need a good health? And where is the facility for them to give good health? That means your system of hospitals and whatever you call about medicine and all that is so faulty that it is in the hands of few people who are exploiting it.
You are absolutely right, sir. Actually, today I wanted to discuss healthcare, and Raghav prohibited that. He said, no, you will not speak about healthcare. We'll speak about general issues. Let me take a minute. You opened up the opportunity for me with due apologies to Raghav. We are actually lucky. While our healthcare outcomes are among the worst in the world, let me give just two numbers. All of us are familiar, but sometimes we forget the public health perspective. Every day, 2,000 children below 5 years of age are dying in India. Most of them are preventable deaths. Every single day, 2,000 deaths. Only one other statistic I'll give. They encompass all the failure and the pain of the failed health system. 5 to 6 crore people of India are becoming poor every year. They were not poor on the first day of January in the year, but because of healthcare problems, either because of lost income on account of sickness or the cost of healthcare because there is no proper healthcare system available to them, they are impoverished by the end of the year. Every year, 6 crore people. That means if you improve healthcare, within 5-10 years, even if you do nothing else in the country, there will be no poverty in India. Now, the good news is, all of you, and I'm not saying it to please you people, despite all our problems, we have phenomenal strengths. Our pharma industry is a world champion. If tomorrow COVID vaccine, whatever vaccines become ultimately acceptable, India is going to be the biggest manufacturer and supplier for the world. I have no doubt about it. There are at least 2 companies that I know personally, there could be more companies, which can each produce 1 billion vaccine doses in a year. There are very few companies in the world that can produce anything anywhere near that. Our pharma company is a world champion. Our healthcare sector, what you're all doing, the interventions you're all doing, you take a hip replacement, take orthopedic problem. The average cost in India, if I'm not mistaken, is about 5% compared to the global cost with the same safety and success standards. We have achieved remarkable success. We have many strengths in this country. We have done a lot of detailed work. In fact, I'm the author of the National Health Mission. I spent a lot of time looking at that. I wanted something equivalent to National Health Service. The then Prime Minister said, look, that's too far, let's do something smaller. So they came up with the National Health Mission. But we came up with a model now. If you spend 90,000 to 1 lakh crores per year, that means 0.5% of the GDP per annum. We are right now spending 1.3% of GDP, union and states together, which is already the lowest in the world among large economies. 1.3% public expenditure on healthcare is the lowest in the world. If we just add 0.5%, but wisely, you can't do more. I wish we could do 5%, 6%. It's not possible. There's no point having pipe dreams. If that much is spent wisely, with a proper family care system, with a gatekeeper for referral, and a good tertiary care system, secondary care is increasingly being addressed by various models of insurance-based public-private partnership, whether Arogyasri or Prime Minister's Ayushman Bharat, whatsoever, you can improve them and make them uniform. If these two things are appropriately, intelligently, even that limited expenditure will significantly give outcomes at a low cost for us. Some of us are fighting for that, and I want the medical community. No, you are some of the greatest experts in the world. My appeal to you is go into health economics and health systems, not merely medical care and expertise. Unless public health systems are improved, the healthcare outcomes in India will not improve. I totally agree with you. Education, we are already spending money, but outcomes are terrible. Healthcare, we are not spending money and outcomes are terrible. But in both cases, the outcomes are bad, but the problem is different. Education don't require more money. We are spending 8.8 lakh crores in India in education. And already 50% of the kids are not in public schools. So we're not spending less, we're spending a lot of money, but it's unproductive. Healthcare, we're spending very poorly, and we have to spend it productively also. But I entirely agree. Without addressing these two sectors, you cannot make a difference. All constitutional democracy are meaningless if these two services don't reach every single human being in the country.
What prevents it?
I totally agree with you. I'm totally with you. There's absolutely no doubt.
Sudhir, our president of Telangana Orthopedic Society,
Sir,
Dr. Sudhir.
Hi, sir. I was about to ask the same question, sir, because of the healthcare budget allotment is very meager.
You're right.
That's what my sir has asked you. And one more thing, the recent Gazette notification has come down, allowing the Ayush surgeons doing all the surgeries. I don't know whether it is a.
I was quite surprised myself. No.
That's what, sir. And
I don't know without
NMC has come up, sir.
Ayurveda and tomorrow you will say homeopathy, Unani. I don't know unless you go into details about regulation. I think it's a big challenge for the country. I'm not opposed to indigenous systems being integrated, but let me take the second question first. I'll come to the first question later.
Sure.
A lady called Tu Yu, at the age of 84, she got a Nobel Prize in 2015, a Chinese national. What she did was, we all know now artemisinin therapy for malaria. She was the person who validated that after 8 years of intensive study. She got that molecule from Chinese herbal medicine, validated it through modern research techniques. And today, deservedly, she got Nobel Prize. I felt very proud when she got Nobel Prize. That's the right way to do it. Not ham-handedly saying that some Ayurveda or some other homeopathic remedy, you do it and it's a panacea, and from cancer to COVID, it will cure. And I'll allow everybody without proper training to do surgery on unsuspecting patients. That's the wrong way. Integrate. Don't have separate menus of options. If you have typhoid, there are no two medicines. There's only one medicine. It is a bacterial disease, it requires antibiotic. If you say homeopathy as a remedy, you can do whatever you like. Something as a remedy, it's nonsensical. If it's an autoimmune disease, if it's some other problem where there's no clear remedy and we don't have any answer anyway, I can understand alternative systems. So this understanding of various systems of medicine, I think, is extremely flawed, and the government is completely guilty of ignorance. Then to come to the first question about budgeting, I totally agree with you. And there are consequences. And I think there's a reason why doctors should care, not merely from public health point of view, as Dr. Ved Prakash is arguing. It is important for medical profession. There is increasing mistrust in the community of doctors. 30, 40 years ago, when Dr. Ved Prakash joined practice early on, 50 years ago or 60 years ago, whenever it was, doctors are worshipped as gods. Even when I graduated, in general, when I was a house surgeon in a hospital, doctors were treated as gods. Today, doctors are treated with great suspicion and contempt. Why? The government's failure to build a viable healthcare system, that anger is now transferred to the doctors in the white coat. The people don't know where the fault is. After all, medical care is very expensive. If the government fails to do what it ought to do from the primary care to secondary care to tertiary care, then private sector, if it comes in, no matter how compassionate you are, there is a cost. I'm sure orthopedic surgery today, with all the modern technologies and imaging and so on and so forth, the capital cost is so intensive. The skill promotion is so costly. There is inevitably cost. The patient is now transferring that anger to the doctor instead of understanding the problem is with the healthcare system and the government's failure. And we are all becoming victims as medical professionals. There is a reason why, out of enlightened self-interest, the medical profession must fight for a viable healthcare system built by the government. And I hope that in each of these conferences, while you do a wonderful job in looking at clinical practice and the best practices and propagating them in modern technologies and interventions, I hope that from this professional point of view, the trust between the citizen and the community and the profession, I think it's important that every medical conference focuses a bit of attention on the public health systems and be seen to be champions of public health in the eyes of the people. It is important for the profession itself. So I completely agree with you. It's a disgrace. We are the worst in the world. It's absolutely unacceptable.
Dr. Jayaprakash Narayan, it's never enough talking to you. And I'm a big fan of you, you know that. But I urge my members of the Orthopedic Society to get on to the website of Lok Satta to see the activities that they do, the pressure, which I always call them a pressure group. This is what our country needs. We need pressure groups to put pressure on the judiciary, the bureaucracy, the legislators, all this. This is very important. I'm sure we will be interacting with you in future too, and I'm so very glad that you're here. Your entire Sudhir, one second. Yeah, you have to be very brief. We have crossed the time by 7 minutes.
I'll take this question. I'll take about 30 seconds to make a concluding statement.
So the question is that we are the other private practitioners. We are providing 7% of the healthcare services in India, and we don't get any subsidy. We are being taxed 35 types of taxes for us, sir. And still the people ask us to give all we are serving in the very low cost rates. And even then the agony is on us, sir.
I completely agree with you. I completely agree with you. I sympathize with you. And I have gone on record repeatedly, even against the Government of India Act about nursing homes, which Telangana government very unwisely and without understanding simply adopted it blindly. It violates the federal principle. It imposes enormous burden on nursing homes. I don't know if you guys are aware. If it's implemented, everything you do will be regulated by some bureaucrat somewhere. So I totally agree with you. But one concluding statement, if you permit me briefly. No, we are a work in progress. We messed up in some ways. We did well in some ways. But I'm a great optimist. We have huge resources and tremendous technological advances today to be able to make a remarkable difference with limited resources in a short span of time. And sometimes we overestimate the problems. We underestimate our capacity to address them. Sometimes we underestimate the difficulties. We overestimate our capacity to achieve short-term results. No. The other day, Bill Gates said something very, very interesting, and I completely agree with him. We often overestimate our capacity to bring about big change in the short term. We underestimate our capacity to bring about big change in the long term. We think in 3 months, everything will change. It never is true. We forget in 10 years, a lot can change if we do the right things today. If the trajectory is changed a little bit, over time, that becomes very vast. A last point from our own profession, a great example. I'm very fond of getting inspired. Now, each time I feel a little down, I remember this story. There was a man called Ignaz Semmelweis, born in 1819. I think he was born in Hungary, but ultimately went to Austria because in those days, Austro-Hungarian Empire, the seat of empire was Austria, Vienna. So he was He went to Vienna and he was practicing medicine in those days. He discovered, like many of his contemporaries, that about 30 to 40% of women were dying in or around childbirth. That was the kind of mortality that was seen at that time. Not always during childbirth, but often because of infections after childbirth. But remember, those are the days when the word infection was not known. Bacteria were not discovered. Sterilization was not known. That's the context we're talking about. So they call it puerperal fever. By repeated experimentation, someone has discovered that if only you washed your hands properly, what we now call sanitation and sterilization, before attending on a patient and before going to the next patient, the mortality rate came down from 40% to 1 or 2%, a dramatic decline. He did not know why, but it was real, empirical. He set out to educate the doctors. Tell the doctors, I don't know why, but if only you wash your hands properly, very few people are dying. Let's please do it. It is not the people of Europe. Remember, the doctors of Europe in the 19th century, the men of science whose job it was to save lives. I'm saying men because in those days only men were doctors. Not one doctor said, let us verify. They all laughed him off. They said, you're asking us to wash our hands? What rubbish is this? They branded him insane. He was actually institutionalized. He was put in a mental asylum in Vienna. And in those days, you know, if you are branded as mad and put in a mental asylum, you were beaten up. He was beaten up badly, injured. Finally, after being released from that asylum, he died of those injuries at the age of 46 in 1865. That's the bad news. Societies sometimes take time. Only a few wise individuals understand what is right. But look at the good news. Within a generation, the celebrated names that we all now worship, Robert Koch, Pasteur, Lister, the man known for hand washing and so on and so forth, they all came within a generation by 1880s, inspired by Semmelweis. Medical world changed. Sometimes it takes longer, we can accelerate it. But please, I beg of you, because Raghav, I can see a lot of anger. I fully justify that. A lot of anguish is necessary, but despair, there's no room for that. We can dramatically improve things. I'm sure Dr. Ved Prakash can tell us, because he's more experienced than most of us, even during his half a century or more of experience, how much things have changed. Yes, they must change a lot better. We can accomplish a great deal more, but we already accomplished quite a bit. We can do a lot more if we do a few things sensibly. And healthcare professionals world over and in India have done a remarkable job against heavy odds. I think we should be the harbingers of hope, not of despair. And there's a lot more to do. If we do it right, with our resources and the current technology, we can make miracles happen. And I hope the medical community will do whatever it takes to make it happen in healthcare sector and in all the other sectors we discussed across the board. Thank you for this wonderful opportunity. I wish you all
JP, I sincerely thank you on behalf of the Orthopedic Association of South Indian States. I know time is, we have surpassed the time by 15 minutes, but that happens every time I get you onto my conferences. There are lots of guys who are ready to ask more questions, but I'm sure it will be another day, another time. I can't thank you enough from the bottom of my heart. Thank you.
I'll be happy to address those questions on internet, by email, drjploksatta@gmail.com, drjploksatta@gmail.com.
Okay, sir.
You can log on to the website, fdrindia.org, fdrindia.org. You can follow me on Twitter, jp_loksatta.
I'll put it up in the conference website. We will do that.
Yes, sir.
Thank you once again. Good day. Thank you.
That was good.
Good morning. Good afternoon, sir.
Good afternoon, sir.
Yeah.
Good afternoon, sir.
Good afternoon, sir.
Good afternoon, sir. I think Kiran, moderators have come.
Good afternoon. some disturbance is going on.
Vijay Bhaskar sir.
Sir, good afternoon.
Good afternoon. నేను కౌశిక్ మాట్లాడుతున్నా. Sir, you need to go to Hall D. D for Delhi. వినిపిస్తుందా? Vijay Bhaskar వినిపిస్తుందా? You need to go to Hall D.
Yeah, I'm trying.
Yeah. So you log out and we'll give you a different code to log into Hall D.
Everybody go to Hall D. Not everybody. Sorry, not everybody.
Shailesh?
I'm in Hall D only.
Shailesh, you are there? Shailesh? Shailesh?
Yes, sir. Yes, sir, I'm here.
Yeah, I'm not getting. Shailesh, can you hear me, Shailesh?
Yes, sir. Yes, sir. Hello. Hello. Ready, sir? Hello.
Yeah, hello.
Yes, sir.
Shailesh, you can hear me?
Yes, sir, I can hear you.
Shailesh, inka mute lanu. Shailesh mute.
Sir, I'm hearing you. Is I audible?
And idhar judu. Only the moderators will be there. Everybody else will.
Oh, मुझे सुनी नहीं पा रहा तेरा हेडफोन ही खराब है.
Yeah, hello.
Hello. Yes, sir. I'm listening, sir.
Yes, can you hear me?
Yes, sir. I'm listening.
Sir, Dr. VKV Prasad is there?
Shailesh, start the session. Keep only the moderators and start the Hall A free paper session.
Sir, Dr. VKV Prasad is there?
VKP Prasad.
Yeah.
I'm checking.
The first moderator.
No, that is a different hall. Vijay Bhaskar, you have to come out, log out of this hall and go to another hall, Vijay Bhaskar.
Oh.
That's what I'm saying. Shailesh, in this hall,
Yes,
Dr. Gopi Shankar and Manoharan, I think, are the
Yes, sir.
moderators. You can start the session and log out everybody else.
Okay, sir. Fine.
Right.
Log out everybody else. बाकी सबको पहले वालों को हटाना है ना.
अभी आया था. अरे वो आवाज आ रही है अंदर काम हो रहा है.
Shailesh, other than Dr. Gopi Shankar and Dr. Manoharan, everybody else needs to be reviewed and only the free paper persons will be available.
Fine, sir. Fine.
Yeah.
Please start.
Start. We're getting delayed.
Yes, sir. Hello.
Gopi Shankar sir and Manoharan sir, thank you for accepting to be with us for this session, sir. So we welcome you to OS Conference 21. Yeah, in two minutes, we will start the presentation, sir.
Okay, sir.
Sure, sir.
Thank you for giving this wonderful opportunity to chair the session in this virtual OSS Con 2020.
Yes, sir.
With this short introduction, I think we can.
Yes, sir. Sir, each paper is 8 minutes, sir, and 2 minutes for discussion, sir.
Okay, sir. Okay, sir.
Sure, sir.
Shailesh, start the first paper in this and remove all the other people from this thing, Shailesh.
Hello all, I'm Dr. Nikhil Punugoti. Firstly, I would like to thank OSSCon team for giving me this opportunity. Today, I will be presenting our paper on locked compression plating versus retrograde intramedullary nailing in the treatment of periprosthetic supracondylar knee fractures. This is a systematic review and meta-analysis. I also would like to thank team members who have contributed to this study. Looking at introduction, periprosthetic distal femur fractures are highly challenging injuries as they are usually associated with high morbidity and mortality. Traditionally, these fractures are fixed with locked compression plating. More recently, Biomechanical studies suggest that retrograde intramedullary nails provide better outcomes when compared to LCPs in treating these fractures. Aim of our study is to examine the clinical outcomes of LCP versus intramedullary nails in treatment of periprosthetic distal femur fractures. In the process, we would like to provide most up-to-date analysis. We will specifically compare operative time, knee function, time to union, non-union rate, and revision rate between the two groups. Coming to methodology, literature search and quality analysis in this study was done in accordance with the PRISMA guidelines. This is a flowchart demonstrating literature search. We have searched Medline, Embase, Cochrane Library, and Google Scholar from January 2000 to May 2020. A total of 1988 articles were screened, of which 10 studies were deemed eligible for our study. This is a qualitative analysis chart of the 10 studies involved in this study. Overall, there are 10 studies included in our study. All included studies were published between 2008 and 2019. A total of 531 periprosthetic fracture cases were included in the study, of which 320 are treated with LCP and rest with intramedullary nails. Coming to results, as we've discussed earlier, this study looks specifically at operative time, knee functional score, time to union, non-union rate, and revision rate between the two groups. Data from 10 studies is pooled into RevMan software to get appropriate forest plots for the outcomes of this study. This is a forest plots for operation time, which includes 3 studies and shows no difference between the two groups. This is a forest plot for knee functional score, where 4 studies have compared functional scores between LCP and nails. Even this study doesn't show any significant difference between two groups. Time to union, which is considered as a favorable outcome, it shows a trend towards favoring retrograde intramedullary nails, but still the results are insignificant, making both the groups comparable. Complications among these fractures are assessed by non-union rate and revision rate. Both of them have showed that there are equivalent outcomes between both the treatment groups. To our knowledge, this is the most up-to-date meta-analysis to compare LCP with RIMN fixation for the treatment of these fractures. Menigini et al., Gondalia et al., and McKinnon et al. Suggest that intramedullary nails provide good biomechanical stability. There is minimal soft tissue disruption, making healing better when compared to LCP. The results from our meta-analysis do not support the theoretical advantage of retrograde intramedullary nails over LCP. And we think there are few drawbacks with intramedullary nails, like they can be used only with open box design processes and non-stem femoral components. When there is fracture comminution, we may not be able to use RMN in all cases. Large et al. Has hypothesized that intramedullary nails may not adequately fill the metaphyseal flare and therefore allow toggling of the distal fragment. Looking at the complications between two groups, Ibrahim et al. And Shaw et al. Are systematic reviews. They have suggested that LCPs have lower complication rates when compared to intramedullary nails. Whereas Ristevki and Shin et al. Have suggested no difference in complication rate between LCP and RMN. Our study also has suggested that there is no difference in the complication rates that like we've seen in the forest plots. We were able to pool common complications in LCP group and in intramedullary nail group. And top 3 common complications in LCP group are hardware failure, malunion, deep infection. And top 3 in nails group are malunion, hardware failure, painful hardware. It is sensible to understand that malunion is common complication of intramedullary nails because it uses a indirect fracture reduction technique. Looking at the conclusion that there is no significant difference between LCP and RAMN in terms of operative time, functional score, time to union, non-union rates, and revision rates. There are a few limitations of the study, like we needed more high quality data to be included in the study. Full weight bearing status and time to return to activity were not included in our study comparisons, as only a few studies have mentioned about these outcomes. Newer methods for treating periprosthetic distal femur fractures like nail plate technique and distal femur replacement are not included in this study, as still the data in the literature is minimal at this time. Recommendations from our study are that we need higher quality randomized control trials and prospective studies comparing LCP and RAMN to get more robust conclusions at a later date. Both techniques should be considered as treatment options at the moment. Surgeons should analyze on a case-by-case basis and decide the most appropriate technique. These are the references of the studies which I've quoted in the presentation earlier. Thank you all.
Nice presentation. Hello, am I audible?
You're audible, sir. You're audible, sir.
Yeah, my paper is open for discussion now. Any questions are arrived?
So there are no, I think there is the chat box. Nobody has asked the question, sir. Would you like to ask questions, sir, as the moderators to the
Yes, sir. I would like to ask 2 questions to the presenter.
Yeah.
So, how do you identify the implant, whether it is an open box implant, that is femoral condyle? For choosing
Nikhil, unmute yourself. Nikhil, unmute yourself. Yeah. Now
yes,
answer
sir.
the question.
How do you identify that based on the implant stickers only will be able to identify it, or is there any way to identify the open box femoral component?
I think we should know the implant before deciding on what kind of femoral implant they've used, sir. Okay. We definitely should know, because there are few open boxes which can only take 7 mm thickness nail and few which can only take 8 mm thickness nail. So we should definitely know the implant design before doing a RAMN. Otherwise, after taking an approach, we may have to shift to plating.
Okay. So next question is what will be the ideal position for your retrograde nailings? Ideally, we'll be doing in 30-degree flexion. But in case of post-operative knee joint, when you are doing in 30-degree flexion, your insert will get damaged during insertion of the nail. How to avoid that?
I think we'll still be able to do it with 30 to 45-degree flexion, sir. Okay. But it's a difficult procedure to do the nailing. That's why you need an expertise and practice to to do these techniques. And that's why we thought nailing has, even though it is published and it is said that nailing is biomechanically better, is difficulties, we still think plating is much better than nailing.
Any other questions, sir? Gopi Shankar, sir?
If there are no questions, then I think we'll move to the next paper.
Yeah, we'll move to the next paper.
Shailesh, play the next paper.
Good morning. I'm here to present healing complications associated with single lateral distal femoral locking compression plate in management of unstable distal femoral fractures. As we all know that the management of such fracture is a challenge to an orthopedic surgeon because of the soft tissue injury, unstable fracture pattern. Distal fragment is short, hence there is difficult rigid fixation leading to fixation failure. Distal femoral locking compression plate is becoming a standard method of fixation because of its superior biomechanics and prevention of varicocele. Still, fracture healing and revision surgeries are important clinical issues. And the literature is full of varus malunion, implant failure, non-union, deformity, and stiffness. And about 0 to 32% cases, healing issues and revision rates are there. The risk factors for poor outcome are the advancing age, fracture personality, closed or open fractures, quality of reduction, post-medial combination gap, and unstable fracture pattern, unstable fracture fixation. So we conducted an study with an aims and objective to identify the risk factors for failure of osteosynthesis using single lateral distal femoral locking compression plate. Our secondary outcome measures were malunion, delayed union, and infection. The material methods, it was a prospective study from July 2014 to June 2018. We included fresh femoral fractures in adults, that is skeletally mature patients with AO types 33, A2, A3, C2, and C3 as described by Wade et al. Closed and open compound grade 1 and grade 2 fractures were included. We excluded type B fracture, that is Hoffa fractures, pathological fractures, compound grade 3 fractures, and stable fractures. AO classification was used to classify the fracture. We work up the patients with AP and lateral radiographs of the knees, including the thigh. We also done CT scan in thin patient to reveal the fracture personality. Patients were operated on plain table, either closed or open reduction works. The first step was the reduction. The intra-articular component was reduced using open technique, and metaphysiodiaphyseal component of the fracture was reduced either by indirect or open method. The second step was the plate positioning after the traction of the fracture, and care was taken avoiding of the off-centering of the plate. The final step was the formation of the final construct, in which 4 well-spaced bicortical screws are used in the diaphyseal component, and distal screws are placed in such a way that they are parallel to the articular surface. Utmost care was taken to prevent primary loss of reduction. In the upper panel, if you see, because of the pulling of the proximal fragment by the plate, there is a gap has developed, which may lead to healing issues. In the lower panel, it is not present. Evaluation methods are used the radiological criteria for the quality of reduction in the form of medial gap, plate length, working length, alignment. For the outcome, functional outcome, Shadgard and Lampert criteria was used. According statistical analysis, appropriate statistical tests are used for analyzing the results, and less than 0.05 p-value is of statistical significance. Coming to the result, 43 patients were available for the study. Out of them, 4 were lost up and 39 patients were available. Out of them, 15 cases were extra-articular and 24 were intra-articular communicated fractures. Closed fractures were 29. 23 patients were having high velocity and injury. Mean age was 67.4 years. Mean follow-up was 20 months. All fractures united except 3 with revision. Mean union time was 21.3 weeks. Mean shortening was 0.5. Varus malunion was seen in 2 patients, implant failure leading to non-union in 3 patients, delayed union was seen in 3 patients. According to the Shaxgard and Lambert criteria, excellent to good result was obtained in 69% of the cases, and the failure was noted in 5 patients. According to the statistical analysis, the various variables out of them, posteromedial comminution and quality of reduction were of significance. Coming to the exhibits, this was a 19 years male patient with comminuted fracture and stable fracture pattern plated with indirect technique. If you see that there is a varus reduction, posterior sag is there, and the plate is relatively short, and the patient presented at 3 months of surgery with fixation failure. The patient was revised with a long nail and the fracture united. Another patient, 75 years female, presented with compound grade 2 comminuted fracture and unstable pattern, which was plated, debrided and plated. And if you see, there is a medial comminution which is not buttressed, and the poor patient was having poor bone quality. Finally, the patient presented at 6 months with the fixation failure, with the fatigue failure of the implant. Patient was revised with the new plate, and it resulted in union. Another patient, 25-year male with unstable fracture pattern, he was plated. If you see that the primary loss of reduction is there, there is a development of gap, posteromedial gap, because of the pulling of the fragment. And the patient luckily resulted in union, but with a varus malunion. Because of the presence of the posteromedial gap, it resulted in varus malunion. If we analyze our healing issues, in all the cases which we have encountered, either there was a issue with the reduction, or there was a posteromedial gap, which resulted in healing complication. Coming to the literature search, what the literature says, the healing issues are related to the quality of reduction, plate positioning, primary loss of reduction, medial gap, shorter place, or either too stiff or too flexible construct, which lead to healing issues. The strength of our study are that it has a prospective one, relatively large follow-up, and valid evaluation tools are being used. The limitations are less number of patients, no control group, and confounding factors. So we propose further research studies to improve the surgical technique and augmented fixation in the form of double plating, primary bone grafting, or nailing. So our recommendations are proper reduction, proper implant positioning, avoiding varus, avoiding any posteromedial gap. If it is there, then we should buttress it with another plate, and creating a mechanical environment for healing of the fracture. Long plate, especially in unstable fracture pattern, should be used to avoid fixation failure. Thank you very much.
Yeah, that's a good presentation. How many patients had bone loss medially?
Hello.
Yeah, how many patients had bone loss medially? Open fractures.
In our case, 5 cases, sir. Posteromedial gap in
What was
5
done?
patients. In that case, initially, bone grafting was not done, and it was noted in 5 cases there was posteromedial gap. We should have done bone grafting in that. In these 5 cases, in 3 of them there was a fixation failure, and 2 of them there was a varus malunion because of the gradual collapse of that.
So why you didn't thought of having double plating or any augmented fixation in your primary fixation itself to avoid this? You made us a conclusion, no? So like augmented fixation is required.
Augmented fixation is required when there should be an augmented fixation when there is a posteromedial gap. If it is not buttressed, then there are chances that there will be healing issues, either in the form of fixation failure or gradual varus collapse, because these fractures used to go into varus collapse. So either they will be uniting in varus or they will be going to fixation failure. So our recommendation for that is that if you on OT table you found that there is a posteromedial gap, which it should be buttressed, or if not buttressed, it should be grafted in the next 6 weeks or 8 weeks.
Even though there is a posteromedial comminution, still we can go get a good result with a long lateral column plate. So that situation you should not use a short segment plate.
Yeah. If you are having a long medial combination, but there is a limit for that. If there is the combination is very long, then again there are chances that even the longer plate will fail, as clearly seen in our first case. That it was almost what the length of the plate was maximum or the OT table what we were having, and even that failed because of the if there is a long medial comminution. Usually in these cases we do indirect reduction most of the time, and on OT table you found that the reduction is okay, but when you actually see the final post-op radiograph, there is some sag, there is some varus. So these results in this. So whenever there is a long medial comminution, it should be taken care of either at the injection surgery or later on. So to avoid some healing issues like that.
Yeah, when you have the long segmental comminution, better implant will be the intramedullary implant.
Yeah, better implant, but if it is going up to intra-articular area, then there will be problem, because C3 fracture in A3 you can go for long intramedullary nails, but when there is intra-articular comminution and you are having 2-3 pieces of the condyle, then there will be difficult to do nailing. You can buttress the whole of the you can span the nail, but distally there will be a poor hold, and there are chances of failure. So in such cases, some are doing augmented fixation in the form of putting these tense nails from the medial side and plating from the lateral side. Again, if you do double plating in this index surgery, the chances of this loss of hematoma, soft tissue injury, there will be more. So there may be an increase of infection. So if in minimal, what we can do is that doing this lateral long plate, and if there is a posteromedial gap, either doing grafting at that time only or putting some tense things to avoid varus collapse. But it should be seen in serial radiograph. If the fracture is not uniting at that phase, then we have to intervene before the failure of the implant, failure of the surgery.
Yeah, still even though there is a type C1 or C2, if intra-articular comminution is intra-articular fracture is very simple, we can make it like extra-articular fracture by fixing with interfracture screws, and we can do a nailing.
Agreed.
So that will be like a minimal invasive surgery if you are good at nailing. So otherwise, whichever the surgical procedure you are well trained, you can go ahead with the fixing it. Okay. I think if no more questions, we can move on to the next topic. Next presenter. Thank you. Thank you for joining this.
Thank you.
Next speaker, please.
Yeah, next speaker. I think next audio can be joined.
Good morning, everybody. I am Dr. Aditya Mukadam from KMC Manipal. I'll be talking about variables affecting functional outcomes in floating knee injury. This study was done under the guidance of Dr. Sharat K. Rao, Dr. Munappa Naik, Dr. Sandeep Vijan, Dr. Mahesh Kulkarni, Dr. Saurabh Shetty. So basically what is floating knee was described by Blake and McBride in 1975. It is a high velocity injury with a complex fracture pattern. It is associated with other injuries, and it has got an unpredictable functional outcome. It can be classified based on Fraser or modified Fraser classification, or based on the location of fracture, extensor apparatus involvement, associated injuries, open injuries, segmental fracture pattern, or ligamentous injuries. So this study was basically designed to evaluate the association of different variables affecting the clinico-radiological and the functional outcomes of floating knee injuries. The Fraser classification is type 1, where the both extra-articular fractures of both the shaft of femur and tibia without any articular involvement. Type 2 is the articular involvement, which is subdivided as type 2A, where there is a femoral shaft and tibial plateau fracture. Type 2B, where there is a fracture of distal femur and shaft of tibia. And type 2C, where there is a fracture of distal femur and tibial plateau. Modified Fraser classification was given by Ran et al. Type 1 is an extra-articular fracture. Type 2 is when an articular surface is involved, which can be type 2A with a simple articular, type 2B with a complex articular, and type 3 is where the patella is involved. This study was basically a retrospective study where subjects were analyzed from Jan 2013 to December 2016. 89 patients, that is 90 total floating knees were considered. All the skeletally immature and pathological fractures are excluded. Functional assessment was done with a minimum 1 year of follow-up, and Karlstrom and Olegrude functional outcome criteria were used. The management protocol for floating knee injury, after ATLS, there were 44 stable and 45 unstable. Stable diaphyseal fractures were managed by antegrade nailing, DCP, LCP, or XFIX LRS. Metaphyseal fractures were managed by periarticular LCP or antegrade nailing. Epiphyseal fractures were managed by periarticular LCP, screw fixation, or conservative management for some. Unstable 45 patients were treated with a damage control orthopedic, that is spanning X6, associated with vascular repair in 7 patients, and primary amputation was done in 3 patients. What were the variables analyzed? So age and gender, side, open or closed, segmental, union status, whether united, delayed union, non-union, interarticular fractures, where the variable analyzed. The outcome variables was compared with the knee stiffness, shortening, malalignment, and that were used to consider the functional outcome. Data was analyzed by SPSS software using chi-square test, and p-value of less than 0.05 was taken as significant. These are the Karlstrom and Olegrude criteria for functional outcome, which include subjective complaint from thigh or leg, subjective complaint from knee or ankle, walking ability, work and sports, and objective criteria, that is angular rotational deformity, shortening of the limb, and restricted range of movement at hip, knee, or ankle. So based on these particular findings and values, you can classify them whether as excellent outcome, good outcome, fair outcome, or poor outcome, where generally none is affected in excellent outcome, mild to intermediate restriction in good outcome, severe impairment in fair outcome, and rest pain or major functional improvement, or when the patient has to use a cane or crutch, that is considered as the poor outcome. So analysis of result, total male to female ratio was 81:8, right in 73, and left limb affected in 17 cases. All had a history of road traffic accident. The mean age was 34.34. Patella fracture was present in 17 cases. Open tibia was 55 cases, and open femur were 38 cases. Segmental fracture were 16 each. Associated injuries. So associated injuries were basically other fractures, head injury, pelvic injury, chest injury, facial, spine injuries, and other cases. These were the results of bony union. So as we can see, 42 tibia fractures showed mean union by 5.4 months. So they were considered as united. 29 tibia fractures showed mean union by 10.34. So they were classified as delayed union. And 12 fractures required additional procedures, and the mean union time was 20.75. So they were classified as non-union. For the femur, we can see 43 femur fracture within 5.44 months were united. 24 fractures had delayed union, and 16 fractures showed non-union. Coming to the analysis of segmental fractures, so in tibia, 9.05 was the mean time for fractures without any segmental fracture, and for segmental tibia fracture, the mean time was 10.06. So that was statistically insignificant. For femur fractures, without a segmental, the mean time was 8.68, and for segmental femur fracture was 14.3. The p-value was less than 0.05, and so segmental femur fracture was statistically significant for delayed functional outcome. Considering open fracture and union time, for tibia, as the open tibia fracture, the union time went on increasing from open type 1, 2A, 3A. For open femur fracture, the mean union time was similar. Considering additional procedures, so total 38 additional procedures were done. Bone grafting for femur in 12 cases and tibia in 9 cases. Also refixation, bone transport or LRS application, tendon transfer, amputation was required in some cases. So segmental fractures required more of additional procedures. Coming to the analysis of results, the complications were immediate complication in 29 cases, which include vascular injury in 7 cases, bone loss in 7 cases, and some cases amputation, fat embolism, ARDS. Delayed complication 22 cases comprising of osteomyelitis of tibia, knee instability, foot drop, osteomyelitis of femur, or implant failure. So when we analyze the functional outcome against the Fraser classification, we found that there were equivalent results in excellent, good, fair, and poor categories for all the Fraser classification. So there was no correlation between Fraser classification and Karlstrom criteria. So at the end of the study, we concluded that the risk factors having significant association with outcome variables were open tibia fracture or open femur fracture, intra-articular fractures, additional procedures which were required mainly for segmental fractures, spanning X fix or segmental fracture had an unsatisfactory functional outcome. For extent, this is the example of 25-year-old Fraser type 1 who had an excellent outcome. Another study of Fraser type 2B who had a fair outcome. So at the end, we can discuss that floating knee injury is a high velocity injury with a male predominance. Associated injuries are common. Early management should be based on damage control orthopedic principle. Stable fixation will help us for early mobilization. Retrograde nailing has shown as some advantage. Non-union joint stiffness and infection are common complication, and asymptomatic knee instability may be noted. Regarding this study, it was a retrospective study with a shorter follow-up. A longer follow-up can help us to identify degenerative changes. But the strength of the study was it was a large center study, a single center base with a standard protocol and a team of trained trauma surgeons. At the end of the study, we can conclude that the poor prognostic indicators for floating knee injury include open tibia fractures, segmental femur fractures, intra-articular fractures, and where additional surgical procedures are necessary. So our ideal classification system for floating knee should consider the soft tissue, ligamentous and open injuries and the complexity of fracture pattern as well. And surgical treatment method can affect the impact outcome. Thank you.
Dr. Aditya, what is the timing of surgery post-injury?
Sir, it was done within 24 hours for most of the cases.
Most of the cases,
Yeah.
Okay, fine.
For unstable cases, we waited for the patient to stabilize. After that, we managed. For stable cases, it was done within 24 hours.
Okay, fine.
So in this, any of your cases, did you analyze any systemic variables like anemia has influenced your outcome, like that?
No, sir. Only regarding the
has added on to the non-healing.
No. Anemia and other variables weren't analyzed, sir. Only knee stiffness, shortening, malalignment, and bony union was analyzed.
Because anemia as well as malnutrition is also having the major role in this type of polytrauma fractures.
Right, sir.
Yeah, even in a single bone, if you get two fractures, so one fracture will go for a union earlier and one will go for delayed union. Like that, in a same limb, if you get two fractures also, the same happen. One fracture you will be getting a nice compression, and one fracture will not get a nice compression. Okay, because both the femur and tibia, when it is fractured, when you are fixing either femur or tibia, the first bone, you will not be able to give a good traction. So in that situation, sometimes the fracture reduction will be compromised compared to the second fixation.
Okay, right, sir.
Yeah. Any more questions from the audience? It was a nice paper and nice illustrations. So we can move on to the next presenter.
Shailesh, next presentation.
Shailesh, sir.
Good morning, everyone. Myself, Dr. K. Gnanashankar, second year PG in NIMS. I am presenting a paper on outcome of distal femur recalcitrant non-union. Introduction. Fractures involving distal femur are relatively common. The routine modalities of treatment, even in best chance, lead to delayed union and non-union in about 20% of cases. The causes may be multifactorial, an unstable intramedullary nerve, or a short surface plate leading to less elasticity in biological mode. The external causes may be iatrogenic instability or compound nature of the injury or infection. Once a non-union is established, the outcome of management mainly depends on establishing the cause of non-union and correcting it. One has to address and increase the contact area of the non-union, stable internal fixation with good compression at the non-union site with correction of the alignment along with addition of biology to the non-union. Therefore, diamond concept. Diamond concept deals with four factors: mechanical environment, biological environment, vascularity, host factors. Mechanical environment. We need to provide a good mechanical stability at the fracture site. In biological environment, we need to provide osteoinductive mediators, osteoconductive matrix, and osteogenic cells. In vascularity, we need to maintain good vascularity to the limb. In host factors, we need to address the comorbidities of the host. If we tackle these four factors, we can achieve a good amount of union at the non-union site. Radiographic features. Radiographic features of non-union. There will be marked sclerosis at the non-union site. There will be a medullary canal is closed, and there will be diffuse osteoporosis of both fragments, and fracture gap persists and widens due to unsuccessful bridging. Aim to evaluate the outcome of distal femur recalcitrant non-union. Patients and method. 15 consecutive established non-unions of distal femur who attended the Nizam Institute of Medical Sciences between 2016 and 2018 were studied and classified using the NUS criteria. Based on the criteria, they are evaluated and operated. The patients are followed for a period of 2 years and evaluated by Shadkur's criteria for functional outcome post-operatively. Inclusion criteria. Patient with distal femur fracture in whom initial fixation does not lead to union. And age group is 20 to 50 years. Exclusion criteria. Patient with proximal middle third non-union are excluded from my study, and age less than 20 years and more than 50 years are excluded from my study. NUS scoring. I evaluated my patient preoperatively with this NUS criteria. It includes quality of bone, open or closure fracture, number of previous interventions, and invasiveness of previous intervention, adequacy of primary surgery, Weber and check group, and bony defect, soft tissue status, age of the patient, diabetes, blood test, therefore ESR, CRP, infection status, drug history, and smoking status. Each aspect has given a particular score, and after adding the all scores, we need to multiply with 2. This lead to total NUS scoring. And if the NUS score is too high, it indicates we are dealing with a non-union of more severe variety. And if the NUS score is on lower side, it indicates we are dealing with a less severe variety of non-union. I evaluated my patient post-operatively for functional outcome with Shadkur criteria. It includes 3 groups: excellent, good, failure. In excellent group category, the patient need to have full extension, no greater loss of flexion, more than 10 degree, no valgus or varus rotational deformity, no pain or perfect congruency of the joint. For good, a loss in length or greater than 1 inch is accepted. 10 degrees of valgus or varus rotational deformity is needed. A loss of flexion no greater than 20 degree with minimal pain. And in failure category, there is joint incongruity, valgus or varus rotational deformity greater than 15 degree when flexion was less than 90 degrees. Case series. Case 1. A 37-year-old male patient who had come to our OPD with complaints of pain and instability while walking over the left distal thigh. He had history of RTA, 2-wheeler versus 4-wheeler, and sustained injury to left distal femur. He was initially operated at outside hospital by interlocking nailing femur. He presented to our OPD with this preoperative radiograph. Here we can see the implant has broken at the junction of the proximal part of distal locking screw, and the nail, which is the least site of resistance for the implant to break. And the distal part of distal locking screw is also broken. This is immediate postoperative radiograph. Here we have performed a retrograde supracondylar nailing for distal femur. This is a postoperative radiograph at follow-up 7 months. Here we can see a good amount of callus seen on both AP and lateral radiographs. This is the latest follow-up radiographs. Here we can see a good amount of union on both AP and lateral radiographs. This is a walking video and knee range videos at the latest follow-up. Coming to next case, case 2. It is a case of a 48-year-old male patient who had come to our OPD with complaints of pain over left thigh, right thigh with difficulty in walking. The patient had history of RTS, skid and fall from back, and sustained right distal femur fracture. He was initially operated for interlocking nailing femur at outside hospital. Later, the implant has broken, and the patient underwent another surgery. Therefore, implant removal of nailing femur and DCS was performed for distal femur fracture. Now, he has come to our OPD with this preoperative radiograph. Here we can see in the thigh with knee, AP and lateral radiographs, the implant has broken at the non-union site. This is his postoperative radiographs at follow-up of 2 months. Here we have performed a interlocking nailing femur along with supplemented with DCS plate extramedullary. Here we have performed ipsilateral iliac crest bone grafting at the non-union site. This is latest follow-up radiograph. We can see the bone graft has consolidated very well and union is achieved at the non-union site. This is his knee range and walking videos. Coming to next case, case 3. It is a case of 37-year-old male patient who had come to our OPD with complaints of pain and swelling over left distal thigh with discharging sinus over the left distal thigh. He had history of RTA because of skid and fall from back and sustained left distal femur fracture. He initially operated at outside hospital with distal femur locking plate. Later, the implant got exposed and the implant was removed at the outside hospital itself. Now he has come to our OPD with this. Now he has come to our OPD with this radiograph. Here we can see there is non-union present at the left distal femur site on both AP and lateral radiographs. We had done Ilijaro for the left femur Ilijaro for this patient. This is immediate postoperative radiograph. Here we can see a local bone grafting done at the left distal femur non-union site. This is the latest follow-up radiograph. Here we can see the bone graft has consolidated very well, and the union is achieved at this non-union site. This is his walking video and knee range videos at the latest follow-up. Results in our study, non-union scoring system ranges from 18 to 80. Mean NUS value is 40 preoperatively. Functional outcome was measured using Sargreaves criteria. Out of 15 patients, 11 had excellent result, and 3 had good, and 1 had fair results. Discussion: fractures of distal femur are caused by low energy trauma in older patient and high energy trauma in younger patient. NUS recognizes 4 groups of severity. 0 to 25, usually the problem is mechanical, and 26 to 50, the problem is both mechanical and biological, and 51 to 75 may need bone grafting, and 76 to 100, these patients may go for amputation, arthrodesis, or process implantation. These are my references. Thank you.
The paper is open for discussion. Any questions from the floor? If no question means I can ask one question to the presenter. In your third case, what is the shortening to the patient?
It is 5 centimeters, sir.
5 centimeters. Since you are used the Ilijaro as a treatment option, why didn't you convince the patient for lengthening to give a equal limb?
Yes, sir. We are planning for him lengthening, sir.
No, you would have done that time itself. You would have used non-union site. You could have distracted, and distraction would have produced a callus, and by the time you would have achieved length also. So
yes, sir.
Maybe, yeah. Because with the short limb, again there is a chance for him to have a frequent fall, and he will break again. That union is not sound enough to load it. So I suspect. So again, maybe refracture can happen. So again, treating the refracture will be very, very difficult.
Yes, sir.
Yeah, you could have utilize the opportunity that Ilijaro. If any other device, the lengthening option is not there. But in this Ilijaro, you would have utilized as a single surgical option. Okay.
Okay, sir.
No more questions. I think we can go to the final topic. Yeah.
Myself, Dr. Raju Mayani, postgraduate from Nizam Institute of Medical Sciences, Hyderabad. I am presenting surgical outcome of periprosthetic femur fracture following hip-arthroplasty. Coming from the introduction, periprosthetic femur fracture after hip-arthroplasty, either hemiarthroplasty or total hip-arthroplasty, they are very difficult to treat. Commonly seen in elderly patients with osteoporotic bone. Often they caused by the trivial trauma. They occur either intraoperative or postoperative period. Vancouver classification is a widely used classification system for the periprosthetic fracture. It provides the level of the fracture and well fixed or loose fixed component. These are the Vancouver classification system. It provides the anatomical location of the fracture and the existing bone quality and well fixed or the loose fixed stem. Surgical treatment has the advantages of early mobilization, reduced length of hospital stay, and thereby we can prevent the complications such as systemic and local complications. Surgical management has the challenges of why? Because there is a fracture in and around the processes and iatrogenic injury while removing the cement in cemented arthroplasty and a difficulty in achieving the stability of stem and osteoporosis. Our aims and objectives to analyze the factors which predisposing to the fracture in this patient and also to assess the outcome following the treatment and to know the prognostic significance of osteoporosis. For this, we included patients of periprosthetic femur fracture irrespective of age, gender, underlying comorbidities, and type of arthroplasty which was performed. We excluded unfit patient and conservatively managed fractures. Materials and method. This is a retrospective clinical radiological study. We analyzed 25 cases of periprosthetic femur fractures who were operated in Nizam Institute of Medical Sciences between January 2017 to 2019 November with a minimum follow-up of 1 year. To understanding purpose, the study participants were classified according to the Vancouver classification. As per the literature, open reduction is wiring recommended for the type A injuries, whereas for the type B1 and type C injury, open reduction and definitive internal fixation. Whereas the reduction totally partoplasty with the long stem recommended for the type B2, B3 as well as B1 with non-union. Goals of surgery to achieve the fracture union, prosthetic stability, and restoration of anatomical alignment, rotation, and length, and bringing back up the patient to the pre-injury status. Achieving of the fracture healing is very difficult because of cortical thinning, stress shielding, and osteolysis, and other factors which related to patient. Here I am presenting a case report of 70 years female with intercapsular fracture neck of femur who went through the modular bipolar hemiarthroplasty. She underwent through the uneventful post-operative period up to 6 months. Later 6 months, she presented with fracture around the stem in relation to stem, Vancouver type B fracture. We went through the definitive internal fixation after assessing the stem stability intraoperative and after verifying the evidence of any stem loosening in the radiograph. These are the immediate post-operative images, and these are the latest follow-up images. These are the clinical image of the same patient. We commonly preferred post-operative protocol, static quadriceps exercise and sequent pelvic lifts from the 24 hours of post-surgery, and gentle knee range of motion exercises from the third post-op day onwards. And weight bearing is different from case to case. Is individualized based upon the radiological union. In addition to this, we conduct a regular clinical radiological examination during each visits. Results of our study: among the 25 cases, 17 were female, 18 were male patients with ratio of 2.1 to 1, with mean age is 67 years. Underlying etiology for the fracture, slip and down is 16, minor traumatic accidents are the 3, and atraumatic mechanism is 7, intraoperative fractures are 5. Interval between the surgery to post-operative fracture is 3 days to 6 months. Uncemented stems are 18, cemented stems are 7. Totally partoplasty is 20, hemiarthroplasty 5. Mean follow-up is 1 year. Type A injuries are 9, type B injuries 11, type C injuries are 5. When assessed radiological assessment by using of Beals and Towers criteria, excellent results reported in 11 cases with stable processes, whereas 9 were good with stable processes with less than 5 mm subsidence, with 2 results were reported in 2 cases, and 3 were excluded due to death or due to other medical problems. Clinical assessment done by Barthel Index of Activities of Daily Living. As per this, 16 were independent and 3 were minimally dependent, 2 were very dependent. There is no total dependency. Assessing of the functional outcome by the Harris score, excellent result reported in 5, 10 were good, 4 were fair, 3 were poor. Most of the from discussion, most of the study subjects were female. All are postmenopausal women with significant osteoporosis, and most of them are 60 to 70 years age group patients with mean age of 67. Trivial trauma is the most common mode of injury in study. Common predisposing factors for the fracture in our studies: advanced age, female gender, osteolytic lesion, osteoporosis, rheumatoid arthritis. The results of one study, they analyzed 20,859 orthoplasty cases. They reported incidence of 0.3% of chances of fracture in cemented orthoplasty, whereas the incidence is 5.4% in uncemented orthoplasty. Osteoporosis is the major independent risk factor for the occurrence of the fracture. So we treated the 4 cases out of 25 cases with teriparatide injection and calcium and vitamin D supplementation given to the all. A study reported that 16 periprosthetic fracture in 450 orthoplasty patients. They found that preoperative osteoporosis was the major significant of the fracture risk and subsequent outcome. Periprosthetic fractures common on the femoral side rather than the acetabular side. They are common reason for revision surgery apart from aseptic loosening, infection and dislocations. Vancouver type is the most common post-operative periprosthetic femur fracture, whereas the type A is the most common intraoperative fracture. We treated type A injuries with SS spiral, type B injuries with type B and type C injuries with a definitive internal fixation with using of plates and screws. Type B, B2 and B3 injuries we revised with totally replacement. So we concluded that osteoporosis is a common preceding factor and also major prognostic factor which determine the treatment outcome. Identification of the patients who are at risk, especially female gender, multiple comorbidities, especially in the revision cases. either dietary or supplementation, medical supplementation of the calcium and vitamin D is essential. By this, we may reduce the chances of the burden of subsequent fracture in them. So while dealing the periprosthetic femur fracture, the bone quality and intraoperative stem stability is the main issue. So whenever proceeding before radiological assessment for any radiological evidence of the any loosening or and also assessment of the intraoperative stem stability. Why? Because we can miss. There is a chance of missing stability assessment of the stem stability in the plane radiograph. So definitive intraoperative assessment of stem stability is essential before going for definitive internal fixation to revision totally partoplasty, especially type B injuries. These are my references, and thank you.
Doctor, did you try to analyze what was the initial pathology for which either THR or bipolar was done?
Sir, totally out of 25 cases, there are 5 totally partoplasty cases and 20 were hemiarthroplasty cases, sir. So most of them were, most of the cases we did not fund any.
What was the indication for THR or bipolar?
Five THR cases. Rheumatoid arthritis is the sorry, sir. Sir, bilateral arthritis secondary to inflammatory arthritis like rheumatoid arthritis are 4 cases, and 1 case is traumatic arthritis of hip, and rest of 20 hemiarthroplasty cases all were like traumatic intracapsular fractures, sir. And in them 4 cases are in them 11 cases have multiple comorbidities, sir. Sir, getting some disturbance. Hello, sir. Sir, am I audible, sir?
Yeah. Hey, you are audible. Go ahead.
Hello, sir. Hello, sir. I'm audible, sir.
Yeah, you are audible, man. Carry on, carry on. Okay.
Hello, sir. I'm audible, sir. Hello, sir.
Yeah, you are audible.
You are audible. Don't worry.
Hello, sir.
Yeah, Raju, you are audible. Are you able to hear us?
Sir, your voice is not clear, sir, to me.
Problem for you, probably.
Your side internet is a little bit low.
Okay, I think next sir, I think.
I think if no more questions, I think we can wind around this first session.
Sir, you can start the second session also.
Yeah,
sir.
we will start the second session. Yes, sir.
Start the second session with first paper.
Hello, sir.
Yeah, Dr. Raju, I think you can. Your study is very well done. I think thanks for participating. Okay.
Next.
Yeah, what are correct time lone పెట్టేసిన హౌలా కాదు చెప్పట్లేదు కరెక్ట్ టైం లోనే
Raju, your mic is on. You are shouting at somebody. It's not good. Shut your mic.
Dear friends, I am presenting this topic on contemporary knowledge in the treatment of intra-articular fractures. To introduce this topic, this is a topic of great concern because of intra-articular involvement where there is high morbidity, and the results of treatment of intra-articular fractures are inconsistent. Therefore, we need to relook at these fractures and have some newer understanding. We need to see the joint as an organ, and it represents an end-stage organ failure. Obviously, it is due to the impact of the energy that is transmitted to the joint as well as the mechanical and biological responses. The current treatment tends to go for restoration of joint congruity with great stress on surgical restoration, and we have invasive procedures and sometimes devastating complications. There are a certain unanswered questions, that is, what is the articular reduction quality we have to achieve, at the same time how to assess this reduction, and also why certain joints and regions within the joints behave differently in intra-articular fractures. So there is a proposed mechanism that, as in polytrauma we deal with, the first hit phenomena also involves injury to the cartilage, thereby leading to dysfunction and death of the cartilage. And this dysfunction subsequently leads to failure of cartilage metabolism and joint degeneration subsequently. The second hit phenomena is, once the treatment is done, if we have chronic incongruity or instability, there is overload and malalignment, there is increase in the contact stresses, which can go up to 300% if the step off is more than 3 millimeters. And there's variability in joint thresholds, and therefore we need to look at improved biological interventions. And surgical second hit is also proposed due to the soft tissue stripping as well as joint denervation and the surgical complications that can occur. So just to take us back, the normal adult chondrocyte in a unstressed state is quiescent in a hypoxic environment and generally has got little collagen matrix and mostly type 2 collagen. And the chondrocyte, along with the synovial cell, produces lubricin and hyaluron, which are useful for the joint function to have a smooth cartilage, low friction, and helps in loading the joints uniformly. The mechanism of chondrocyte necrosis is, once there is damage or injury or death of the chondrocyte, it releases oxygen-free radicals just next to the fracture site, which in turn activates the pro-inflammatory mediators, and many cytokines, tumor necrosis factor alpha, interleukin 1 and nitric oxide are released, and they stimulate cell and matrix degradation. This leads to loss of bone density, gradual increase in subchondral bone thickness, and loss of cartilage. Subsequently, the OA changes start due to the shear forces, which start at the cartilage surface, and here the chondrocytes, which are little away from the fracture site, start proliferating, and there is cluster formation and increase in matrix protein and matrix degeneration. This leads to matrix remodeling with calcification of the deeper layers. The degradation products release chemokines, alarmins, and adipokines, and all these together produce an inflammatory response like that of an immune disease. So therefore, an innate immunity is also an active player in osteoarthritis. The risk factors involved are, there is severity of the injury, the incongruity of the surface, the instability of the joint due to the capsule ligamentous injuries, as well as intra-articular structures and menisci, and surgical excision, and age. As age advances, the thickness of the cartilage comes down and the reparative process also suffers. Osteoarthritis, for some reason, is very high in plafond fractures and also in tibial plateau fractures, which are malaligned, and to an extent in acetabular fractures where dome and posterior wall are involved. So we need to ask, is joint congruity, stability, and alignment, does it prevent OA? And if incongruity leads to poor clinical outcomes, these two questions we need to keep in mind. How do various fractures behave? If we see distal radius fractures, conservative treatment as well as closed pinning give comparable results, yet we tend to operate distal radial fractures. Tibial plateau fractures also, 10-year survival rates of conservative and surgical treatment are similar, but a malaligned tibial plateau fracture of more than 5 degrees leads to significant OA. Malleolar fractures all in dislocation, the results of conservative and operative treatment are similar, and however, the complication rates add to the surgical treatment. Tibial plafond fractures, unfortunately, do not behave well with conservative treatment, and surgical treatment is the treatment of choice. However, both ways, 70% of these cases develop PTOA in the long term. Acetabular fractures also undisplaced or minimally displaced, but dome and posterior wall fractures are prone to develop PTOA to the tune of 25% by 7 to 12 years. So the issues that we need to understand are that joint is an organ and that all intra-articular fractures are not similar. Within the joint itself, there are differences. End-stage joint failure is due to cartilage failure, and there is no definite treatment to prevent PTOA, and presence of OA does not mean poor clinical outcomes. Conservative management is to be advocated for distal radial fractures, tibial plateau fractures, well-aligned and malleolar fractures, whereas surgical management is better for plafond fractures. The results of conservative and surgical management for acetabular fractures, dome and posterior wall are equivocal. Irrespective of the type of management, PTOA is high for plafond and acetabular fractures. Minimally invasive surgery mitigates these issues to some extent, but the role of intra-articular and intracortical PRP is being explored more and more. And now we consider that subchondral bone and the cartilage form one unit, and therefore we need to tackle both the subchondral unit. Therefore, intra-articular as well as intracortical PRP is being advocated. Thank you very much.
I think it's a wonderful conclusion by Professor Sir. Thank you. Thank you for concluding it like with your vast experience you have taken this paper. So what is your
Because
you want to give for the younger generations? Like
yes, the reason why I chose to write on this, make a presentation on this is the desire to operate everything is basic in the mind of every orthopedic surgeon. But unfortunately, we can do much better in many fractures with good conservative treatment. And if we look at the long-term results, ultimately we find that both conservative as well as surgical treatments, and sometimes conservative is even better than going for surgical treatment. And we need to understand that it is not one solution for all fractures or all joints, intra-articular, especially when we are talking. The time does not permit us to share so much of data, but I've just tried to concise it that if your fractures are well aligned and intra-articular, still you can get away with good results. And osteoarthritis radiologically does not really mean bad outcomes. And so unless we understand these things, we will continue to operate. Luckily, minimally invasive procedures have given some respite to this deterioration in the joints. And now, as we understand, the subcortical bone and the underlying cartilage, they form a single unit. We are doing a lot of PRP work in intra-articular, but now they are advocating intracortical, so that you target the subcortical area under an image guidance, and then we inject PRP into those areas, and we may have to do more than 2 sessions there. And there they claim that the results of good healing are very, very encouraging. So we need to have a rethink about the pathophysiology there, and that should guide us towards good treatment. That is the message I want to give.
Yes, sir. You have given a very good message to the young surgeons, those who want to operate all the intra-articular fractures. I think we have to revisit our thought.
Yes,
Yeah.
that was the whole idea.
Yes, sir. If you put your signature on the patient, whatever the end result, if any negative results, the patient is going to blame you. So I think we are taking the points are well taken, sir.
Yeah.
Thank you for this. Nice
Thank you.
paper.
Thank you very much. Thank you.
We'll move on to the next paper, sir.
Yes.
Good morning, everyone. I am Dr. Jia Sailesh Babu, doing my postgraduate in KPV, Common Medical College, Trichy. And I take this opportunity to thank our beloved professor and HODs, Dr. Kalyan Sundara sir, and my co-guide, Dr. Kumaresh Bari sir, for helping me bring out this paper. And as you all know, distal tibial fractures remain one of the most substantial challenges that confront the orthopedic surgeon. This is mainly because of the vascular as well as anatomical characteristic of the affected area and the soft tissue injury, which makes it highly difficult for managing these fractures. And despite the progress of surgical procedure, outcomes are always not excellent, and therefore there is no gold standard treatment for these fractures. And recently, the use of external fixator has come back and is now indicated for open fractures with severe soft tissue compromise. And now the treatment options include definitely external fixator, open adduction internal fixation of tibial guidance fracture once soft tissue injury has subsided or wrinkle sign has appeared, and delayed open adduction internal fixation. And since it is still a controversial topic, we propose the concept of hybrid external fixator as a definitive management. And the aims and objectives to assess the functional radiological outcome of these fractures treated using hybrid experts. And inclusion criteria included age over 18 years of age and with the distal tibial fractures, and the patient should be able to walk before the injury, and open fractures are also included. And exclusion criteria included polytraumatic patients with distal tibial fractures requiring prolonged ICU care, and patients with bilateral pylon fractures are excluded, as well as open fractures with vascular injury. Study protocol, study centered, which was done in Department of Orthopedics, Trichy, and the study duration was around 2 years. And it is a sample size of 25, and the analysis was done using SPSS software. And taken around 25 patients, most of whom were around 31 to 50 years of age, and 80% are males and 20% are females. And male predominance was mainly due to, as the most common injury was road traffic accident. Road traffic accident cases included 19 cases, almost 80% of the cases, and there were 5 cases of fall from height and 1 case of heavy object, fall of heavy object. It is work spot injury, and almost 60% of the cases were open fractures, and all on admission, all cases will be treated using ATLS protocol. Initially, IV broad-spectrum antibiotics will be administered. Neurovascular assessment will also be done, and then patient be shifted for external fixator. And the patient who had complete follow-up will be taken up for analysis. So this is a case of distal tibial fractures with articular intra-articular extension, and this is anteroposterior as well as lateral. So we'll be using an hybrid external fixator, which is connected to a linear external fixator. 2 KVs will be used. 1 KV will enter the fibula posterolaterally and exit the tibia anteromedially, the first wire, and the second wire will be inserted from the posteromedial aspect to exit the tibia anterolaterally, avoiding the fibula. And both the wires will be connected to a ring, and the tensioning will be done using a tensioner. So this is initial stabilization of the fibula so as to obtain acceptable alignment, and then this is the first K wire which is being inserted posterolaterally to exit via the anteromedial. And once these 2 KVs have been inserted and connected to a ring, and then the system will be stabilized using half fins. This half fins will be placed onto the anteromedial aspect of the tibia. So this is the intra-articular CM, intraoperative CM image. This is the post-operative, immediate post-operative images. Post-op protocol, a post-op splint will be placed for around 48 hours to prevent any equinus deformity, and weight bearing will not be allowed until 6 weeks, that is until radiological signs of union appear. And healing is determined by the presence of bridging callus in at least 3 of the 4 cortices. And once adequate healing is confirmed, the external fixator will be removed and the below knee synthetic walking cast will be applied. And 4 weeks later, this will also be removed. All the patient will be followed up for at least 18 months. So this is the preoperative image, and this is the intraoperative. First, initial stabilization of fibula, And once this has been stabilized, it will be article fragments will be stabilized using 2 K wires and connected to wiring. And this is the final post-operative image. And this is 1 month follow-up. After 2 months, we have removed that external fixator as well as the K wire. And this is the 6 months follow-up. This is the functional look. So we have treated this management for 25 cases. And we have obtained almost 65 cases with excellent good results objectively. As well as subjectively, we have obtained around 70% results with OVD and Bailey score. And the complication, the most common complication which was obtained was, seen was pin trap infection, which was almost seen in almost 64% of the cases. And joint stiffness occurred in 24% of the cases. And one case went in for infection. So the aim of the surgery, distal tibial fractures, as I've already said, as one of the most difficult fractures to treat. The aim of the surgery is to obtain anatomical reduction, providing stability, as well as to union of these fractures. And the present study was taken to determine the efficacy of a hybrid external fixator in treating these fractures. Our study had an average age of patients with 43.6 years, and we had a 64% of open fractures. And our study had an average fracture union of 21.12 weeks. And the type B fractures had prolonged the time for union mainly due to metaphyseal bone defect, which required a primary bone grafting. And hence, the delayed union might be due to more number of compound fractures, hence not using bone grafting primary. And our study had a comparative time to union in weeks, that is almost around 21.2 weeks. And comparison of results of our study with that of others showed almost 75% of good to excellent results. So advantages include it can maintain hybrid XFix can maintain length and alignment while spanning the communicated region, and it can also use olive wires from opposite direction to help in achieving interfragmented compression and articular connectivity. Limitations include difficulty in radiographic visualization of articular surface with fixator in situ, and the inability to dynamize the construct, and it can also provide enough stability for early weight bearing. Therefore, the weight bearing has to be delayed for almost around 6 weeks. So, thus, hybrid external fixator is an effective treatment management for the treating hybrid distal tibial fractures, especially open fractures, in terms of union time and complication range, which is comparable to other studies. Thank you.
The paper is open for discussion. I think you have presented well. So, Dr. Shailesh, what is the take on regarding Elizero fixation instead of hybrid fixation in this distal tibial fractures? I think you have to unmute yourself.
Hello. Sir, in Elizero fixator, the whole limb has to be immobilized, sir, and the patient complaints is very poor when compared with the of a hybrid fixator, sir. And and Elizero fixator, the patient complaints mainly is the main problem here in Elizero is non-compliance of the patient, sir. And hybrid fixator itself is a very good alternative and compared with the of an Elizero fixator.
So I think it is a wrong message saying that Elizero fixator patient is not.
Jamal, you are on video, so
complain.
Be serious.
Hello.
Yeah, Elizero is an excellent tool. Okay. So in comparison to hybrid fixation, Elizero is giving more stability. Okay. Even you can allow the weight bearing as soon as possible, that you cannot do it with hybrid fixation. Then how you are saying this hybrid fixation is superior to Elizero, and Elizero will be more cumbersome?
So since the fracture is metaphyseal as well as an intra-articular fracture, hybrid XFix itself is enough. That's what we felt.
Yeah, even
we actually tried 2 cases.
How many wires you are used in the distal fragment?
3 wires we have used, sir.
Huh? 3 wires.
3 wires, sir. 3 wires.
So is the 3-wire fixation is enough to have the fixation rigid? So how many cases you are extended your fixation to the calcaneum?
Sir, we haven't explained any case or any fixation to calculate, sir. We have just fixed only the distal fragment and we have supported it with a linear X6 in the proximal aspect, sir.
Okay, okay. So even if you like connecting the anyway upper segment, you are going to put a sand spin only most of the time. When you use
Yes,
the
sir.
Illusidro also, you will be putting most of the areas with the pins only, hybrid pins. So in that
Yes,
situation,
sir.
instead of connecting the rods, if you connect a ring, so it will be
Yes.
circularly more and more stable, and you can allow the patient to weight bear also, and you can avoid the angulation, whereas mall union or rotational mall union also with the fixators. If the fixation is going for delayed union, you can gradually compress the fracture site. That cannot
Yes,
be
sir.
done with your hybrid fixation.
Yes, sir.
Okay.
Yes, sir.
Any other questions, sir?
So there are no questions in the chat box also, sir. We can go to the next paper.
Okay, okay. Then we'll move on to the next talk by
Thank you,
Dr.
sir.
Ashraf Jamal regarding
Thank you, sir.
suprapatellar approach. Okay.
Morning to one and all. Welcome to my presentation. I'm Dr. Ashraf Jamal. Let's move on to the presentation. Tibia is the most commonly fractured long bone. Out of the treatment options available, intramedullary nailing with locking stands out to be the standard care for the shaft of tibia fractures. Exclusively, the proximal third tibia fracture always never fails to surprise the surgeon because of its unique difficulties in management. Herewith, I am presenting my observation and analysis of the novel suprapatellar approach for the specific entity. Let's move on for the presentation. On your screen are some of the nasty fractures of tibial shafts left over with the short proximal fragment. Wonder how to manage? Understanding the deforming forces of any fracture helps in expertise management of it. Throwback to the proximal tibia anatomy. Dynamic deforming forces across the knee joint, results in a specific expected displacement of the fracture fragments, which results in highest malunion rate of 80% in some series. The anteriorly placed extensor quadriceps results in apex anterior deformity, which is exaggerated by the hamstring tendons over the distal femur. The unopposed medial pes anserinus pull leads to valgus deformity in the coronal plane. The peculiar osteology of the proximal metaphyseal tibial canal is wider than the distal diaphyseal canal, which leads to the large mismatch between the size of the nail and tibial canal, which causes a wedge effect over the distal fragment, leading to the deformity. Landing with the problem to be solved, achieving the entry point stands out first. Tibial canal isthmus is just lateral to the midpoint of the tibial plateau. Achieving the ideal entry point is of prime importance. Any insertion medial to the ideal entry point will lead to the exaggeration of valgus deformity, further damaging the anterior horn of the medial meniscus. Ideally, the guide wire should pass parallel to the anterior cortex of the tibia to negotiate the apex anterior deforming vector. Second comes to positioning the limb. Conventional 90-degree flexion of the knee joint will exaggerate the apex anterior deformity. Fracture reduction and maintenance by various armamentariums in our army, with our army. The wide metaphyseal canal leads to wedge effect while negotiating the fracture with the nail. Among the choice of implant between extramedullary and inframedullary. Out of various solutions for these problems, the semi-extended positioning the knee explained by Dr. Torrenta et al. And followed by the novel suprapatellar approach as proposed by Dr. Dean Cole helps in reduction and maintenance of the fracture. Blocking polar screws, unicortical temporary plating, external fixators, and newer nail systems with multiplanar oblique locking options and more proximal Herzog bend. Our choice of solutions among the list is semi-extended positioning the knee, suprapatellar approach, and expert tibial nail system. Justification for our choice of suprapatellar approach are ease in achieving the ideal entry point, better reduction of the fracture and maintenance with least assistance, prevention of the secondary deformity, preventing the injury to the infrapatellar nerve, avoiding further soft tissue damage for the at the incision site, better knee function. These advantages are patellofemoral arthritis, knee sepsis, and arthropfibrosis in some cases. That's a short brief on the subject. Let's move on to the presentation per se. Aim is to observe and the functional and radiological outcome of suprapatellar approach, and the objective is to analyze the outcome, assess the critical length of the proximal fragment to achieve good results. And the cases included are more than 16 years, and fractured tibia, extra-articular with short proximal segments, stiff knee in extension. And the exclusions are less than 16 years of age, more than 70 years of age, intra-articular fractures, associated comorbidities, and neuropsychological ailments. After all proper evaluation, 67 cases were selected for the study. All cases are operated with suprapatellar approach with fixed protocols and followed up for 1 year. Outcomes are assessed with X-rays taken at each visits, and functional outcome is assessed with lower extremity scale, functional scale, lysome score, and knee range of motion at first, 6th, and 12th month. And moving on with the surgical techniques. After proper evaluation, the actual size tibial X-ray, AP, and lateral view are taken, measured, and appropriate size implants are chosen. Placing the position on the OT table with semi-extended knee with bolt step under the knee joint. Skin incision is marked, and 5 centimeter skin incision is placed 3 to 5 centimeter above the superior pole of patella. Suprapatellar pouch is accessed, splitting the quadriceps longitudinally, and the knee joint is accessed with the help of trocar and sleeve, thus easily hitting the ideal starting point. After fracture reduction, guide wire is inserted parallel to the anterior tibial cortex. After serial limbing, nail is entered and locked after perfect reduction. And that's the fracture united without any malalignment at 12 months. And this is the achieved knee range of motion at the end of 12 months. On observation and analysis, most of the patient, more than 50% of the patient goes with good, excellent functional outcomes. Lysome knee score. More than 50% of the population had more than 100 degree of knee range of motion. And there is a least incidence of complication with anterior knee pain less than 8%. There is no recorded septic arthritis or malunion rate. More than 50% of the population had good functional knee range of outcomes scores and knee range of motion of 111.5 degrees, least incidence of complications, and the average distance of the proximal fragment from the articular surface is 110 millimeter, ranging from 90 to 140 millimeter. 5 patients had open fracture and bone loss, who were managed secondarily with augmentation plating and iliacus bone grafting. And the limitations are short follow-up, small sample size, other injuries are not considered, and not a comparative study. Thus, I conclude by recommending the suprapatellar approach with its ease in achieving the entry point, better knee function, least incidence of complication, least fluoroscopy time, least injury to the soft tissue. These are my references. Thanks for the patience. Hope you enjoyed the presentation. Thank you.
Yeah, nice presentation, Dr. Jamal. So, do you assess the patellofemoral joint damage post-operatively, either scopy, putting scopy and visualizing?
Yes, sir. We didn't do actually any imaging or scopic assessment. We did only functional scores using knee range of motion and asking the patient with the visual analog score using pain scores.
Okay. So in this presentation, just for the completion sake, I'm asking. So in the initial slide, apart from your name, the study done where it was not at all mentioned. So the details of the study was not mentioned, like who is your co-author, like so that and all. Yes. It is basic for the. Okay. Sure, so correct, in your when you show the cases, no, in that proximal reaming was done without sleeve. Is it advocated? or you will
No,
be
sir,
using
actually not. Sir.
sleeve?
We have a special sleeve, sir, which extends from the suprapatellar pouch till the knee, the entry point, sir. It is protected sleeve. After we will start dreaming only after reaching the starting entry point, sir. Before that, we don't dream. Yes, sir.
Okay, any of your case got infected in open fractures? 5 cases you did in open fractures.
Yes, sir. Infection, open fractures, we had injury site, sir. There is no septic arthritis as such as per recorded, sir. Infection over the surgical site and the wound site, open compound wound site we had, sir. That's been managed with secondary wash and IV antibiotics.
Okay.
Yes.
Okay, no more questions. We can proceed with the final topic for this session. I think the co-host can play that video. Okay.
Hello everyone. My topic for paper presentation is functional outcome of suprapatellar approach for the treatment of complex tibial fractures, a prospective study of 48 cases. And the study was performed in Mahatma Gandhi Medical College and Research Institute. Tibia is the most commonly fractured long bone, and the complex tibial fractures includes proximal tibial fracture, tibial plateau fractures, segmental fractures, open fractures, and distal tibial fractures, in which the soft tissue injury will decide the line of management. And infrapatellar approach, metaphyseal region is generally more cancellous bone with a large medullary cavity and a less thicker cortical bone. And this infrapatellar approach can cause rotational and angular malreduction. The proximal fragment will go into extension in proximal tibial fractures during the flexion of knee, leading to procurvatum deformity. And distal third fractures will go to varus or rotational malreduction during standard nailing technique. This is a picture showing the same with an infrapatellar approach showing procurvatum and valgus deformities. And all positions require more knee flexion, which makes a fracture site angulation. To avoid this, in 1996, Tornator and Collins introduced semiflexion tibial nailing through medial parapatellar approach for the treatment of proximal tibial fractures with a knee flexion in 10 to 20 degree. And 2011, Jakma et al. Has proposed suprapatellar approach which has an easy advantage of easy performance and less risk of patellar tendon and infrapatellar nerve injury. And this suprapatellar nailing is getting popular nowadays. And merits are knee flexion will be less than 30 degree throughout the procedure with the control of proximal fragment will be easy and less number of assistants are required. And CM positioning will also be easy and high entry point is also possible. Demerits are to prevent to prevent damage to patellofemoral joint, infection to the joint, and injury to the intraarticular ligaments. Aim is to analyze the functional radiological outcome of complex tibial fractures treated with intramedullary nailing using suprapatellar approach. Secondary objectives are to analyze the advantage of this approach over standard approach and to analyze the extended indication of intramedullary nailing to analyze the incidence of anterior knee pain. Materials and methods prospective studies done from June 2016 to May 2019, which included 48 consecutive cases coming to our hospital with complex tibial fractures. Inclusion criteria are metaphyseal tibial fractures, grade 1 and 2 open fractures, age of more than 18 and less than 70 years, abrasion over infrapatellar region, segmental fractures, and comminuted tibial fractures. Exclusion criteria was grade 3 open fractures, pathological fractures, mentally ill patients, and comminuted intraarticular fractures. Demographic data, mean age of 41.75 with a range of 18 to 70 years, male to female 30 to 16, RTA is to fall 40 is to 8, and right is to left is 28 to 20, close to open is 39 is to 11. Distribution of fractures, proximal tibia extraarticular 22, simple intraarticular 8, distal tibia 12, and segmental fractures are 6. And this is an operative technique showing the patient in supine patient with knee inflection of 20 to 30 degree with an incision of 3 centimeters over the supramiddle corner of the patella, and following which the entry point made just medial to lateral tibial spine in AP and along the anterior cortex in the lateral. This is the trigen meta nail with approximately 4 locking options with a 10 degree bend in the proximal end. And distally also we have 2 locking options. And intraoperative images showing the positioning and point reduction clamp to reduce the fracture site. And all cases were operated within 48 hours from injury. 2 case blocking screws were added. 1 case required additional derotation plate to improve stability. Drain used in all cases. Post-operatively, patient mobilized with walker support. Gradual weight bearing allowed after serial radiological healing. All patients were followed up at 4 and 6 weeks and then in 3, 6, and 9 months. During follow-up, patients were evaluated according to lower extremity functional score system with a score of maximum of 80, and lower the score is a greater disability. The minimal detectable change is 9 scale points. The minimal clinically important difference is 9 scale points. Percentage of maximal function is LAFS score by 80 into 100. And mainly depends on the activities, whether it is extreme, quite a bit difficulty, moderate, little bit difficulty, and no difficulty. And results are all patients are we're having complete follow-up at 6 months to 18 months. Average time taken for healing is 12 weeks, 8 to 20 weeks is the range. Delayed union was noted in 3 cases, and all segmental fractures were noted at the end of 20 weeks. Infection found in 1 case which is superficial, malunion in 2 cases with varus of less than 10 degree. Deformity, no cases noted, no limb length discrepancy, knee stiffness in 2 cases managed with intensive physiotherapy, anterior knee pain in 12 cases kneeling, 42 cases had good to excellent outcome, and 6 cases had fair outcome. And complications, 1 case had a screw back out of, and anterior knee pain was found in 12 patients, knee stiffness in 2, no case reported with implant breakage or loss of reduction. Intro of instability or fracture site was found in 1 patient, which was treated with additional derotation plate. Illustration of cases. Case 1, 24-year-old male with an RTA, diagnosed type 4 tibial plateau fractures with a diaphyseal extension, treated with tibial trigen metanail, and the patient at the follow-up 8 months, showing improvement in the ROM. And this is the range of movement at the 1 year follow-up, where the patient has is able to squat and sit cross legs without any difficulty. And this is a patient, 53-year-old male, treated a segmental fracture, treated with trigen metanail, with a good follow-up and good ROM at the follow-up. And this is a case 3 of 49-year-old male, a proximal tibial fracture, treated with trigen metanail. These are the follow-up pictures showing the same, where the patient is able to do all the activities without difficulty. And 54-year-old male with a proximal tibia fracture, treated with trigen metanail and a derotation plate. The follow-up, this is the pictures of the follow-up. And this is an open grade 2 tibia fracture, treated with the trigen nail. And 2.5 months post follow-up, where the patient had good range of movement. And discussion, intramedullary nailing was to be with intrapatellar approach as a gold standard for diaphyseal fractures. Metaphyseal fractures were difficult to treat with intramedullary nailing. As a proximal fragment will go into extension while flexing the nail into more than 90-degree infrapatellar approach. Parapatellar approach and high entry point were reduced with this a quite bit. This is an article showing suprapatellar nailing surgical hints, where Gelbke et al. He's proposed that suprapatellar nailing is a safe surgical technique over infrapatellar intramedullary nailing. This based on the previous study was based on cadaveric study, and Jakma et al. Performed a 1 to 2 centimeter midline incision, suprapatellar incision, and no protection sleeve was used, which led to patellofemoral joint injury, which was reduced in our study using protection sleeve. And Morandi et al. Described a percutaneous lateral suprapatellar approach through a 1.5 centimeter transfer incision at the supralateral corner of patella. And Sanders et al. Have initially reported a clinical and radiological results of tibial fractures after suprapatellar nailing, which found excellent tibial alignment, union, and knee joint ROM. And suprapatellar nailing could significantly reduce total bed loss, postoperative knee pain, and fluoroscopy times compared to intrapatellar approach. And it is a very good alternative approach to treat special type of fractures. Intra-articular proximal tibial fractures can be treated with nailing to allow early weight bearing compared to plating. And incidence of anterior knee pain cannot be avoided with this approach. Meticulous closure of arthrotomy and quadriceps does not cause significant power loss in quadriceps function. Limitations are small sample size, shorter follow-up period, and are not a comparative study. And the status of cartilage over patella and trochlea post-surgery has not been evaluated. These are the references for the study.
Shailesh, give video access to Ritvik.
Yeah. The paper is open for discussion, sir. Actually, in chat box, there was one question: is the suprapatellar approach is done only for the proximal tibia, or any other fractures also can be managed? So, what about Gopi Shankar, sir?
What was the incidence of anterior knee pain in the study?
What, sir?
Incidence of anterior knee pain in the study.
Rutvik, can you answer this?
Ritvik, incidence. He's asking incidence of anterior knee pain in your study.
Did you assess the anterior knee pain in the study?
Rutvik, you are not audible. I was in this study, he has told the anterior knee pain is 12 cases. Yeah.
Okay.
Shailesh, Ritvik voice is not there.
Ritvik, Still you are not audible, man. Dr. Ritvik.
Sir, you're able to hear me, sir, no?
Yeah, now. Yeah.
12 cases of 48 have been reported to have a
Little bit louder. Yeah.
Speak louder, Ritvik. I think his connectivity is problem, sir.
Yeah, I think, sir. For that question and answer chat box, I want to add, for the suprapatellar approach, I think it is very comfortable for all the level of fractures. Especially it is made for proximal tibia fracture, but it can be extended to segmental fractures as well as even distal tibia fractures. Since the position of the limb will be very it will be in less than 30-degree flexion, so less number of assistant is required. So C-arm positioning is also very easy, AP lateral. So whenever you want to change the position of the C-arm, you can easily change. No need to change the limb position. But in an infrapatellar approach, you will be changing the limb position, so you may tend to lose the reduction. Yeah.
If there are no further questions, I thank Dr. Gopi Shankar and Dr. Manoharan for accepting our invitations and conducting the session successfully. Thank you very much, sir. Thank you very much, sir.
Wonderful opportunity, sir.
Yes, sir. Thank you.
Thank you
I think now after another 5-10 minutes, the inauguration will be going on in the same hall here, sir.
Yes, sir.
You can have to log in with your respective login accounts.
Sure, sir. Thank you.
Thanks, one and all. Sir. Right.
Yes, sir. Thank you. Thank you.
Yes, sir. దాంట్లో జాయింట్ మీటింగ్ అనండి సార్. అవునా? 1 minute. కిరణ్ ఏఎస్ రావు పెడితే లాంచ్ మీటింగ్ అని వస్తుందంట. లాంచ్ మీటింగ్ అని వస్తుందంట లింక్.
MB, am I with you now?
అది లాంచ్ మీటింగ్ క్లిక్ చేయండి సార్.
Log meeting. Launch meeting. Where the hell is that? Can you hear me, MB? No.
My video is not coming.
Sir, can we start the inauguration music?
Video, I can't see.
Just stop the video for a second, please. Okay. Good afternoon, everybody. We welcome you to the 19th Annual Conference of the Orthopedic Association of South Indian States. This is the inaugural function, and welcome to one and all. Let us start with a prayer. You can play the video of the player.
शङ्करा प्रभृतिः देवै सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेष जाड्यापहा निःशेष जाड्यापहा जगत जननी शारदे जगत जननी शारदे करूं मैं तेरी वंदना करूं मैं तेरी वंदना वीणा पाणि धारिणी वीणा पाणि धारिणी प्रकाशपुञ्ज ज्योत्सना करूं मैं तेरी वंदना जगत जननी शारदे श्वेत पुष्प श्वेत हंस श्वेत वस्त्र धारिणी करी कृपा मोपि मात करी कृपा मोपि मात जन जन मन रंजना करूं मैं तेरी वंदना जगत जननी शारदे जगत जननी शारदे जगत जननी शारदे
Thank you.
That was excellent. So we'll now have the welcome address by Dr. Raghav Dutt, the organizing chairman of OSSCon 2020. Dr. Raghav.
Thank you, Dr. Karthik Engel. On behalf of the organizing committee of OSSCon 2020, I welcome you all to this first ever virtual conference of our South Indian states. We had planned a mega event. We booked a 5-star luxury hotel and we raised funds up to 1.3 crores to do a fantastic event. However, with the COVID and the current guidelines given by the government and the dangers posed because of the pandemic, we had to, on the advice of the EC, convert this into a virtual meet. In the last 2 months, we had to create a program, and I'm sure since yesterday for the first time we have introduced the PG training program, and this morning also we had a very interesting CME. With this and many more events, along with a few more non-academic sessions, I hope you will enjoy this scientific feast. Welcome once again to all of you.
Raghav, I'm unable to start my video. Somebody has stopped.
We now invite Professor Nalli R. Yuvraj, the Secretary General of OSS, to give his annual report of the association.
Why is this coming again? Yeah. Yeah, can you put off the yes, yeah.
We now invite, could you hear me when I
Yeah, yes,
invite
yes.
Professor Yuvraj?
Yeah.
All right.
Okay. It is are you able to hear me? Yeah. It is difficult to write, think, or talk about anything these days without focusing on how COVID-19 has changed us. For the same reason, the YSS TraumaCon 2020 and the YSSCon 2020 is being held virtual. We have learned a lot about virtual education over the last 8 months. And although as an educator, I cannot wait to get back to more face-to-face meetings and conferences, there are certain things that will stay with the post-COVID-19. Definitely, I think a conference as good as this, I think this is another way of educating our members. I think I'm sure this method of education is also going to stay for some time. There certainly will be things that do not deserve to live after COVID-19 as well. Now, going into the report of the activities of the association over the past 1 year, it was on 24th August 2019. Dr. S. Pandian took over as the president of YSS from Professor A. John at Puducherry, and that is the cabinet, the office bearers, and the EC members. And that is the membership status. In all, we have 7,223 members with 352 new members enrolled this year. Now, the annual conferences were a regular feature of all the associations, and fortunately, this was before the COVID-19 crisis. So hence, the annual conferences were held as usual. POA-Con in January, including the Kerala Orthopedic Association Conference, then the OSAP Conference in the February beginning, along with Tamil Nadu TNOA-Con also, and the Karnataka Orthopedic Association Conference again in January and extending on to February. And the TOSA-Con was from 24-26 January, and myself and our president were part of this function, of this conference. It was held in a very grand manner. Now, there are two EC meetings. Originally, we had planned to have the meetings in April, but unfortunately, because of the COVID crisis, we had to postpone it, and then we had to hold them virtually. The first meeting was on 17th May 2020, and the second was on 9th August 2020. And both meetings are really very productive. A lot of decisions were taken, especially in this period of crisis. These meetings are very useful on planning the various activities which we wanted to continue without any interruptions. And we were successfully able to do that only because of the various deliberations which took place during these virtual EC meetings. Now, because of the COVID crisis, we had to have the virtual YSS TraumaCon, a very well-organized program. The team of the TraumaCon was non-union and mal-union, and nearly we had a 5 hours program. 5 hours program, very well organized, and there were good response around. You can see the number there. Tamil Nadu accounting for 285 members, and nearly 450 delegates attended this program, and they had obtained credit points also from the Tamil Nadu Medical Council. Now, of course, the virtual conference, the YSSCon, which we are enjoying now, again, a virtual conference, a very well organized one. So these are the various programs, how nicely they've organized it. I think I should congratulate the organizing team for coming out with a wonderful conference as good as this. And then the most important activities during this period were the bringing out the YSS bylaws. I think we've been following the bylaws which were framed by our senior members, the founder members, and this has been in vogue for so many years. And now we have come out with the fresh set of YSS bylaws. There was a need for it because a lot of ambiguity is there in the various rules that were governing the functioning of the association. Hence, we wanted a clear guidelines on the management of the affairs of the association. Hence, this need was felt, and the present EC group went into it, and then we were successfully able to come out with the set of YSS bylaw. And I request our president, Dr. S. Pandian, to release the YSS bylaw. Can we have him on the screen? Patrick, anyway, we can have him on the screen. I'm not able to see him here. Switch on the camera.
Unable to start the argument. He's not able to start the video and so on.
Okay, you just leave it. You can just leave.
Start my video.
Yes, that's it.
Yes. Shall I read it out?
Yes.
Ali, sir? Are you're done, sir?
Yes.
Yes. So I'd like to now invite Dr. S. Pandian, President of OSS, to give the presidential address.
No, 1 minute, Karthik. We are not finished yet. Now, our president is releasing the bylaws booklet.
Right, sir.
Yes, sir.
Good evening to everyone. The Orthopedic Association of South Indian States started in the year 2002, has over the years grown both in number and stature. The association has been functioning under the guidance of the bylaw framed by our founder office bearers with the necessary amendments periodically. With the growth of the association, the need for a comprehensive and clear constitution and the bylaw were felt by the members over the years. There was a lot of ambiguity in the interpretation of the rules and regulations, which led to minor confusions in the functioning of the association. Efforts are put in by the president's set of office bearers to come out with a more comprehensive bylaw, which will enable the association to function in a more efficient manner. We thank the association for giving us an opportunity to lead the association and come out with an updated new bylaw.
Thank you, sir. That is the bylaw booklet being released by our president. Thank you, sir. Now, the Journal of Orthopedic Association of South Indian States. We've been putting in efforts. I think our president-elect was the previous editor, and he has put a lot of effort to bring out these Journal of OSS, and it was really a tough task, in fact. And now this set of executive committee went into this problem and into the details about the problem, and we were able to come out with a solution. And then this publication of bringing out this journal was handed over to one of the most prestigious publishers, the Walter Cloovers, of course, with the help of Raghav Dutt again. And we were able to convince them to bring out this journal on a very nominal amount. And hence we were successful in negotiating. And then the first issue of this online journal, we also have a few hard copies also, and this is going to mostly being online. And this was released on, it went online on November 15th. And I request our president-elect to release the journal on this occasion. President-elect Dr. Raghav Dutt. Raghav, why don't you say a few words? Raghav, you can say a few words.
Congratulations to our association and also to the efforts of Dr. Suresh Pillai. And now, though we paid the money many years ago, fortunately now we have started this publication with Wolters Kluwer. And I'm sure under the guidance of Dr. Suresh Pillai, the journal will take a turn for the better. And hopefully in a couple of years' time, it will slowly move towards the direction of getting indexed. I declare the journal be circulated to all our members. Thank you.
So the next issue is going to come out in another 2 months. And then yearly, we plan to bring out 2 issues that will enable us to get this indexed. And Walter Kluwer has also promised us that they'll put in a lot of effort, their full effort to get this journal indexed. I'm sure another 2 or 3 years, we are going to have index journal for YASS. Next, we have the YASS newsletter. I think this is a way of recording our activities annually. This is only the second newsletter. In fact, we had the first newsletter released in Pondicherry during the YSSCon 2019. And this newsletter is in the website. You can go into the website and then you can have a look at the first YSS newsletter. And this is the second newsletter. And I would like at this moment to thank Dr. Roshan Kumar, the secretary of the Karnataka Orthopedic Association, in bringing out this journal at short notice. And I request Dr. R. Selvaraj to release the journal. And
Please share again.
Sir, his voice is not coming, sir.
Sorry, I think it's a video. Anyway,
Again,
yeah, 1 minute.
just share again. Share with computers on. Click.
Sir, no sound, sir.
Anyway, sir, there's some problem with the video. So he has released it. Yeah, thank our senior vice president, Dr. R. Selvaraj, for releasing the journal, releasing the newsletter of the YSS. Okay, now this is the journal of YSS 2019 with great, there were a lot of hurdles in bringing out this, and finally we were able to release it. And then we have sent a copy, PDF copy, to all the members by email. I think most of them would have received by now. And we have also, along with this, we have sent the fellowship details also. So this is the YSS Traveling Fellowship. This was lying idle for nearly 4 years after institution, and we have now set in motion this fellowship, and these are the various dates there. And we have sent the details about this YSS Traveling Fellowship along with the application form also to each and every member by email. People who are not able to access this, you can go into the website. Website is yssortho.org. So you can go there and you can go into details and also download the application from there. Then the activities of the member states, starting with the journals of the individual states, member states. The Kerala has its own journal which is indexed. The Karnataka has one, and the Tamil Nadu has the Journal of Orthopedics and Joint Surgery. Once again, making a lot of efforts to get this indexed. And then the two monographs are brought out by the OSAP. They are the open fractures, another one is on orthobiologics. These are the various academic activities of the Tamil Nadu Orthopedic Association. Quite a big list there. And during this period of COVID crisis, a lot of webinars were held, which was a regular feature of all the member states. And you can see the series of webinars organized by the OSAP. There were a few from Telangana. And then around 37, I think the 32 now, 32 PG teaching programs held on Tuesdays and every Fridays. And this is going on as a part of the TNOA PG teaching program. Karnataka has its series of webinars also during the COVID lockdown. And Pondicherry, a small state as that, also has its own webinar. So the bone and joint activities were seriously taken the various member states taken part in the bone and joint activities of the IOA. And I am not going to the full details because these are the few, there were other social activities also as part of this bone and joint activities. Thank you. That is the Secretary's report. Thank you.
Okay. May we invite Dr. S. Pandian, the President of OSS, to give the presidential address. Dr. Pandian.
Yes, sir. Am I audible?
Yes, sir.
Yes. Respected Secretary General of ISS, Dr. Naliv Raj, respected Presidents, Secretaries, and Executive Committee members of ISS, senior members of ISS, delegates attending this virtual meeting. Good evening to all of you. The YSS was started to share our experiences and to use this platform to put up our members to represent in IOA in the best way. I'm happy to record that I have been up to these goals to the best of my ability, even with the hurdles of COVID pandemic. Needless to say, I've been able to function only with the assistance and good guidance of all office bearers of the YSS. I thank all the members who have their unstinted support in all the endeavors unhesitantly. Particular mention must be made of Dr. Naliv Raj, the Secretary General, who was of invaluable assistance to me on the execution of my activities as President. But for him, I would not have continued as the President of ISS. He helped me to do my job with his utmost efficiency and to the satisfaction of all the members of ISS. It's also the time now to move on and let the new president take over, organize, and further the activities of ISS. I sincerely welcome Dr. Raghav Dutt, the incoming president, to continue the activities of ISS. I'm sure with his efficiency as a past president of ASSI, he'll put the ISS to the next level. I place before you my sincere thanks to all the members and office bearer for their support, especially in the recent months, which has put several restraints owing to the COVID pandemic. I bow down to the organizing team who has put up a fantastic meeting of ISSCon 2020 in Hyderabad. This conference will be a memorable one in the history of ISS in all aspects. They were not able to provide Hyderabad biryani and visible above, but on the other hand, we have received an excellent academic fees for all the members. We have lost one good orthopedic surgeons in Andhra Pradesh during COVID pandemic. I thank all the members of the AP and Telangana for their untiring efforts to help him in all possible ways during that time. We have brought out the ISS bylaws during our period, thanks to the efforts of Dr. Naliv Raj and Dr. Selvaraj. Thanks to Dr. Suresh Pillai for his excellent job. I doubt even a regular conference would not have brought such amount of good papers and live demonstrations. I once again thank the organizing team and wish all the delegates an excellent 3 days deliberations. With these words, I thank you and thank one and all. Thank you, sir.
Thank you, sir. I'd like to now invite Professor A. Srinivas Rao to address and to inaugurate the conference. Professor A. Rao.
Sir, unmute, sir. A. Rao, sir, unmute.
Sir.
Sir, unmute, sir. A. Rao, sir.
A. Rao, sir, press unmute.
Unmute. Sir, unmute, sir. We are not able to hear, sir. A. Rao, sir.
Yeah.
Please speak now, Professor Srinivas Rao.
హలో
సార్ మీ వాయిస్ రావటం లేదు సార్, మీరు వాయిస్
అన్మ్యూట్ చేశాను మరి.
Yes, sir. We can hear you, sir.
ఇప్పుడు వస్తుంది సార్.
Please speak.
ఇప్పుడు వస్తుందా?
ఇప్పుడు వస్తుంది. Now it's
Shall I-
coming, sir.
Shall I speak?
Yes, sir.
Yes,
Please
sir.
go ahead, sir.
Yeah, I'm very happy for that I'm given an opportunity to speak at the inauguration of this conference. I happen to be the first president of the OASIS, so I would like to recollect some of my thought process which I had in my mind at the beginning. We had a feeling in South India that we have been neglected at the national level. So some of us felt that we should have our own association. With this in mind, some people have made an effort rather, to have an association, but they failed. The association never started. So at one point of time, I started thinking why our efforts are failing. So I realized several causes. One of them was that all the stakeholders were not involved properly. The second one was that we did not have a document to register the rules and regulations of the association. So next year it never took off. So with this in mind, wherever I went as an examiner, I used to instigate people that we should have an association. And there was a lot of encouragement. And finally, when myself and Dr. Annamalai of Chennai, we were examiners in Mysore, we sat at length early morning with a cup of tea, how to go about. Then we took the help of Dr. Vijayaraghavan of Chennai, who cooperated with us and made an effort to start an association. So invited all the members with common interest from all the 4 states. Those days only 4 states were there. We invited them for a meeting. To make it more official, we invited the president and secretaries of the respected associations. We formulated a constitution and read about it and then discussed at length and gave a birth to the association. The Andhra Pradesh, the United Andhra Pradesh at the time, came out with an emblem for the association of the 4 states. The Tamil Nadu Association came out with the final constitution, and the Kerala Association came out with the name OASIS. That's how it started functioning. We had a meeting in Chennai in Radha Hotel and finalized everything. And then they asked who will start the first conference. Then immediately I said there were only 3 months time, but still I said we will start in Andhra Pradesh. And Dr. Vijay Ramarao, my colleague, was the organizing secretary, and we had the first conference in Hyderabad. At the general body meeting, again we discussed the constitution threadbare. This is the 3rd time we discussed the constitution. That is how we involved all these stakeholders, and it became very strong. Then I suggested the qualified orthopedic surgeons were not presenting papers, and they were asking their postgraduates to present papers. To avoid this, I said only qualified orthopedic surgeons will present papers in this conference. But Dr. Annamalai objected to that and said PGs are a backbone for any conference. So we had a compromise and said 2 sessions will be allocated to the postgraduates and rest of them should be presented by qualified orthopedic surgeons. But I don't think this is followed by the present day conferences. That's a point to be verified. Then to avoid problems in the association, I analyze them to be collections and elections. Election of president is a big problem. So what we thought, every year each state will elect one candidate who will be the vice president and he will go up the ladder and finally will become the president. That's how the states will elect the presidents. So the problem of confronting people and elections were avoided. And collections, it's a very difficult job to collect funds for the association. So what we thought was each state association will give an amount to the central fund and all the members of that state will automatically become members at that point of time. And now in future, we thought the state will collect 100 rupees and send to the center. That's how the collections were minimized. The problem of collections was minimized. And then the association started, and I was elected as the first president. I was the founder president. I was very lucky. I think my dreams have come true, and the association has become very strong and is going uh, as you see, as all of you see, is going very strong even today after so many years. I think with this recounting of the history of the association, I wish the association all the best and inaugurate the conference.
Thank you, sir.
Thank you very much.
Thank you very much, A.S. Rao, sir. I now invite the chief patrons, Dr. Ved Prakash and Dr. Jairam Pingal, to address. We will start with Dr. Ved Prakash first. So you have to unmute, sir. Ved Prakash, sir, you have to unmute.
Am I audible now? Yes. My greetings to all the members of OSCs, the Association of South Indian Surgeons for Orthopedics. I remember everything which Dr. Srinivas Rao has mentioned and their untiring effort for the first conference, which was extremely successful. They conducted in a very peaceful manner, and even now that association is going on, but there was some talk about, you've got to put new blood inside, and somehow I think we should again boost the association. That's not a good sign to, for a subject at this time. But in this difficult time, I'm glad there's such a good response for the virtual conference. It's, I'm sure, because of the sincere effort made by my colleague Raghav, and to get all help needed for this is done by him mostly single-handedly, but the institution, Uday Omni, the IT department has helped him in conducting it, but nothing can be done alone. You need some help. But he's constantly engaged into academic activities at the expense of his practice, which was was a concern for me, but his attachment to academics is so great that he does it regardless. I congratulate him for this untiring effort and to bring about this conference in such a grand manner and so well done online. Being on the teaching side, for any subject, for that matter, let aside orthopedics, because I'm mostly being a senior man now involved into spiritual practice, to teach somebody regarding that, you need more knowledge and clarity to be able to understand that subject. And Dr. Srinivas Rao has been one of the ideals in orthopedics for teaching in our part of the country. And selection of subjects and selection of proper speaker requires involvement with academics. I congratulate Raghav again for doing such an excellent job, and I hope the conference becomes a big success. I don't want to take a lot of time, so go ahead with the next speech. Thank you.
Thank you very much, sir. I now invite Dr. Jairam Pingle to say a few words.
Can you hear me?
Yes, we can hear you.
Okay. Well, I would like to welcome all the candidate people who came to the conference, and it's an exceedingly wonderful conference. I've been listening in but not interfering, and we have got almost 1,260 registrations this year, Karthik tells me, and this is the 19th annual conference of OASIS, and it was I'm very happy to have heard Srinivas Rao to give you this information about how OASIS started. And I think this was very good for all the people who attended to know the history. History is very, very important whenever it comes to any conference. I congratulate Dr. Pandian and Professor Nalli Uraj for their presidency and the Secretary General. And 10 years ago, Raghav, you remember, we had a wonderful conference here, last conference in Taj Krishna, and it was a real grand success. And you were the organizing secretary and I was the president at that time. And I have to say that the scientific committee, scientific papers have been excellent. The CME, the papers that are there right on time, and everything went off well, because in the old days we used to find, but I know that OASIS, OASIS always we were very particular about time, and everybody should stick to time. And this has occurred, and the CME was extremely good. And I congratulate you, Raghav, for the excellent management, as always you do, and tirelessly, that is, as Ved Prakash said, and Dr. Ved Prakash, and Karthik and Kaushik, I know, I've been working night and day, and I have seen them, and they're hardly here in the hospital. They've been working for this conference, and I congratulate you both for the excellent work that you have done. I don't think this was mentioned, but I'm saying it. And so we all have a few further wonderful conference. We have another 2 days of extravaganza in scientific. And as Dr. Pandian mentioned, unfortunately, because of COVID, we can't have dance and song, but we'll have to make do with this. And one thing I would like to say to all of you is never stop learning. This is what we need to do. Thank you very much.
Thank you. Thank you very much. I now invite Professor Nalli R. Yuvraj, the Secretary General of OASIS, to introduce our President-elect, Dr. Raghav Dutt. Sir, you need to unmute, sir. Nalli, sir.
Yeah, it is time for change now. It is customary for the YSS to have its president changeover during the inauguration. I don't think we see this in the other conferences. It was so planned by our founder members and the office bearers in such a way that the new president takes over and conducts the conference. I think it's one of the good ways of conducting a conference. So sticking to our protocol, we now have the changeover of the presidents. So I take this opportunity to welcome Dr. Raghav Dutt Mulukutla, who is going to take over as the president of the OASIS. To introduce him, I think I really do not, he doesn't need any introduction as such, but I think there are a few things which we should know about him as he is going to be our president for the next year, 1 year. Dr. Raghav Dutt is a student of the Osmania Medical College and Kakatiya Medical College. He went to UK in 1987 and trained in Royal National Orthopaedic Hospital, London in spine and scoliosis units. Trained in centers of excellence in United Kingdom, Europe, and USA, he returned to India in 1994 and joined the Uday Omni Hospital and later the Apollo City Hospital. He is the past president of Association of Spine Surgeons of India, and during his tenure from 2017 to 2019, he has a lot of achievements in the Association of Spine Surgeons of India. And similarly, we are going to see a lot of things happening in the YS also, as he has done in ASSI. So he was the one who started the Indian Spine Journal, which is on its way to get indexed. He started the spine and outreach programs, taking spine surgery to 2-tier cities across all regions of India. We started the ASSA Connect, which is a means of discussing the difficult cases through the, we can have this in the mobiles. And he published 9 monographs. I think this is a wonderful task, I should say. Very well prepared monographs. And there are many more activities in ASSI which he has contributed. He is in the editorial board of Asian Spine Journal, and he is the one who started the Twin Cities Spine Association. And he has conducted around 10 national and state conferences. And you can see the way he's has conducted this virtual conference. And he's got chapters in 6 national and international textbooks and around 250 guest lectures and orations. And he is a member of prestigious organizations like AO Spine International and the Indian Orthopedic Association and the Indian Medical Association. With these few words, I now invite Dr. Raghav Dutt to take over the presidency of the Orthopedic Association of South Indian States. Raghav.
Thank you so much, Professor Yuvraj. I will now invite Dr. Raghav Dutt to say a few words.
Thank you.
1 minute, Raghav, 1 minute, no? Raghav? As I think as a mark of, we normally should have exchange of the President Jewel, and as a symbolic way of handing over, Dr. Pandian will take over his President Jewel, and probably we will hand it over. I think Raghav has promised a wonderful first EC meeting in Hyderabad, which I'm sure is going to be something like a conference again there. And during that time, we will have the exchange of the President's Jewel. So now we request Raghav to take over now.
Thank you for your kind words, and thank you, Professor Pandian, for guiding us in the last year, during the last year. Professor Pandian, Professor Nalli Yuvraj, Dr. Ved Prakash, Professor Srinivasa Rao, Dr. Jairam Pingal. Another president is taking over today. It is a happy occasion for me, but for the organization, we need to ponder. Where were we yesterday? Where are we today? And where is this organization heading? Whenever we speak about Oasis, there are tears rolling down our eyes. Still, none of us attend our annual conferences. We hardly participate in the activities. And it is sad that We talk and do nothing to improve this organization. We talk about our journal all the time with pride, but neither we do spend the money for the journal, nor do we give a direction to its editors. None of us know about our trauma cons, which happen and finish. And above all, the very purpose of getting South Indian states represented at IOA doesn't happen, and our candidates do not get elected to IOA, and some of them very worthy candidates. So whom is Oasis serving? Have we lost it? Can anything be done at all? This is the 19th year. We crossed our infancy and we crossed our youth also. We are in our adulthood. These are some of the questions that came to my mind today. We need to bulldoze this organization. We really need to bulldoze this. We are caught in the web of laws and bylaws. And forming a South Indian association, we still look like, let us have 2 members from Kerala, 2 from Pondi, 2 from Andhra, 2 from Telangana. We don't want to upset anybody. We want to please everybody. This is something we need to discuss. It is time we say we are South Indian states. That's all. We shouldn't talk anymore about individual states. We need to plan. We don't have a plan in place. And that plan needs to be implemented. What we are going to do, because the term of the presidency is very short. Mine is even shorter because I'll be handing over in August. What is our blueprint for the next 5 years? How come there are hardly any members attending the conference in Pondi and Kerala in the last 2 conferences? Of all the members of this organization, I'm the only one amongst others who attended all the previous 18 Oasis cons. I've never missed one. That's my record. We need fresh minds. We need new ideas. This cannot go on. It is time we shake Oasis out of its slumber. And I'm sure together we can do it. Let us act, let us change, let us improve, lest we perish. I'm sure I will try my very best to inculcate some of my ideas and prepare an action plan for Oasis at least for the next 5 years. Long live our beautiful organization.
Thank you, Dr. Agadat. I will now give the vote of thanks. Good afternoon to one and all. Greetings from OasisCon Virtual Conference 2020. Now, we all know that COVID has changed our world from physical to virtual. And when my chairman, Dr. Agadat, informed me that the Executive Council of Oasis had voted that this become a virtual event, we were a bit perplexed because organizing a conference of this magnitude was new to us all. We have virtual platforms like Zoom, Google Meet, etc., but we were not used to using it. And I initially learned quite a lot from my kids, from their school virtual platforms that they use for online classes. So initially we expected about 400 or 500 orthopedic surgeons to attend, but we were overwhelmed when 1,238 orthopedic surgeons registered as of yesterday. We have 266 faculty, 22 of them being international, and we received a record 863 abstracts. 500 of these abstracts were sent on the last day of receiving the abstracts. Due to time constraints, only 163 papers were selected for oral presentation. 540 of them were posters, and some of the oral presentations were converted to e-posters so as not to cause disharmony amongst some of the postgraduates. We face challenges in surgeons asking us, how do we record the talks? How do we send them? And we all learned from the IT people as well as from ourselves. But we were very ably supported by our event management company, CIM Global, in particular, Mr. Kiran Lella and Supriya, who worked day and night to bring this shape to the meeting. Now, my consultant colleague, Dr. Kaushik Reddy, who's been with us for 10 years, has been one of the backbones of this, working tirelessly all these months and deserves a huge round of applause. Professor KJ Reddy and Professor MV Reddy have been instrumental in bringing shape to the scientific program which you've seen part of today. Now, Dr. MV Reddy has sifted through hundreds of abstracts over the last few weeks, working, streamlining them, and then sending them to the subcommittees. All of the subcommittee surgeons are surgeons from within the state as well as from outside South Indian states, as well as some from within India. I'm also indebted to Dr. Raghav Dutt for giving me the opportunity to be the organizing secretary. And I'd also like to thank the chief patrons, Professor A.S. Rao, Dr. Ved Prakash, and Dr. Jairam Pingle, my father. Thank you. With this, we conclude the inaugural function.
Thank you very much. Thank you all.
See you tomorrow.
No, we still have a lot of program.
We still have a lot of program till about 8 o'clock tonight.
Oh,
we'll now go on with the remaining program in various halls.
Yeah.
8 o'clock we have the EC meeting also. EC meeting. Yeah. 8 o'clock we have the EC.
We have an EC meeting at 8 p.m. and we also have various sessions now.
Paper sessions.
Paper sessions.
As well as the oration.
As well as an oration. And the most important, the who's who of OASIS speaking about how to get OASIS out of its coma. One of a kind discussion will be taking place for about an hour. Please join us. We need your inputs. We need your help. We need your guidance.
DOSA team congratulates Dr. Raghav Dutt, and we convey the deep condolences to the family of Dr. Rangachari.
Yes,
Thank
we will
you.
announce that in the EC today and also in the GBM tomorrow. We will do that.
Thank you.
Thank you.
Hearty congratulations, sir.
Thank you, Sudhir.
Raghav, sir.
Thank you.
Congratulations, Dr. Raghav.
Thank you very much. Thank you.
Thank you. Thank you.
So we will now go ahead with the scientific program. We now have Professor Sudhakar Shetty Memorial Oration. Dr. Gopakumar is here.
Yeah,
So
he's
would
here.
you like to start off proceedings?
Yeah. 1 minute. We have another 5 minutes, in fact.
Congratulations, Dr. Raghav, on taking over.
Thank you, Ajay.
I watched the whole program, but I was muted.
That is being done from Delhi, not by us.
I think most of the discussion about the coma is over there.
Yes. Yes.
Let's see. Let's see. Okay.
Congratulations, Raghav.
Thank you. Thank you very much.
Good evening, sir.
Good evening, Ajit. How are you?
Fine,
You have
sir.
taken my subject.
I thought you would ask some questions there, sir.
Yes, but I was unable to reach you.
Acha, okay, okay.
Somebody had muted my.
All right.
Yes, so it's okay. But I'm really surprised that you have not got better results. Because
We have good results as regards union, sir, but avian is still persisting.
But I tell you one thing which I wanted to tell you.
Yes, sir.
Avian is commensurate with very long, painless squatting and going about work.
Very true, sir.
Is that for 18 years I have got a lady, and then she said, now I want it.
That's right. That's
Yes,
very
but
true.
these are not as often as you have said. They are less often.
Yeah.
Less often. They are about 10 to 15%, not more. Not
Okay.
according to my series of 62 cases which are recorded
Right.
in 2007. Thank
Okay.
you.
Thank you, sir.
So we'll now have the Professor Sudhakar Shetty Memorial Oration by Dr. Gopkumar TS. I invite Dr. Raghav Dutt to give a brief on the biodata of Dr. Gopkumar.
Okay, do you have it with you?
Yeah,
The biodata?
You have?
Yeah, I have it. Yeah.
Go ahead and read it.
Yeah, I will introduce him and then you can invite him.
Lovely.
Okay, yeah, okay. I have great pride in introducing Dr. T.S. Gopakumar, who is presently the Professor of Orthopedics, MES Medical College, Perindalmanna. Dr. Gopakumar had his MBBS education from the Trivandrum Medical College, both MS as MBBS, MS or from the Trivandrum Medical College, MCH Auto from the University of Liverpool, UK, and he has undergone AO fellowship at Tübingen, Germany. He has been the head of the Department of Orthopedics of Government Medical Colleges Trivandrum and Government Medical College Calicut, and he was a past president of the Kerala Orthopedic Association. He has had a number of orations delivered in the various conferences, the Kerala Orthopedic Association Conference, as well as IOCON, and he has had a number of medals won for his presentations, and his area of interest is pediatric orthopedics and cerebral palsy. With this short introduction, I request our president, Dr. Raghav Dutt, to invite Dr. Gopakumar.
It's a happy occasion for me that Gopakumar, who was my classmate during my MCH at Liverpool, I know him from 1991. He was always calm, quiet, well poised, and always soft spoken. And when I came back, we keep meeting each other and bumping into each other in various conferences. And he has achieved so much in the academics of orthopedics. Over to Gopakumar. We are very eager to listen to this oration, and I'm sure hundreds of young orthopedic surgeons who are following this meeting will benefit from your oration. Over to you.
Thank you, Raghav. Should I share the screen or will you be giving the recorded version?
Whatever, the choice is yours.
Okay, then I'll start the recorded oration.
Sure.
Mr. Chairman, respected teachers, senior colleagues, friends, ladies and gentlemen. First of all, I would like to thank
The audio is not coming, sir.
worked with Professor Bentley and earned his MCHO with distinction. He came back to Mangalore and joined the Kasturba Medical College, Mangalore, and continued there for 32 years and retired as professor and head of the Department of Orthopedics. He was a rare blend of perfect clinician, excellent teacher, and a brilliant surgeon. And he was instrumental in starting the Mangalore Orthopedic course. As you all know, Mangalore Orthopedic course is one of the most popular PG training courses in India. He was, after all, a perfect gentleman. I have great honor and pride to stand before you to give this Professor Sudhakar Shetty Memorial Oration. I dedicate this oration to the memory of Professor Sudhakar Shetty. May his soul rest in peace. In your practice, you might see this type of children brought there by their parents, totally disabled and unable to walk. This is another example of such a child. See how difficult it is for the father to carry this child. You have got two options in front of you. Either neglect them or don't do anything, and they will have a miserable life like this. A life with contractures, dislocated hip joint, and pain, scoliosis, and so many other problems. Or try to help them by doing appropriate treatment, and we may be able to make them better. Now this boy was not able to walk. He is able to ambulate himself with the help of a rollator. So the topic of my oration is, let us all try to help them to move ahead. See this girl. See how the father is carrying this girl. So we all know the diagnosis here. It is cerebral palsy. And we are getting a large number of adolescents untreated cerebral palsy with these type of problems. Now, what I'm going to tell you is what we can do to help these children. Now, coming to the talk, how common is cerebral palsy? The incidence is around 2.4 to 2.7 per thousand live birth. It is commonly associated with low birth weight infants and in immaturity. So, to find out the incidence of cerebral palsy in the rural population here, we did a study of under 5s by door-to-door survey. It was a simple method that was used. Arts college students were given the work of going to around 3,536 houses in a single day to identify the under 5s. The nursing students went there to find out patients with neurodevelopmental disorders and epilepsy. And later our team examined 256 children. To our surprise, we found that the number of children with cerebral palsy was around 6 per thousand population. And with cognitive disorders was 10 per thousand population. This means that the prevalence of cerebral palsy in rural India may be higher than national and international average. When I joined Calicut Medical College and started my work there in Calicut, we were faced with a big problem, the large number of children and adolescents with cerebral palsy. Most of these patients are neglected and maltreated, and there is poor infrastructure in the government hospitals to look after these cases, and always there was a lack of resources. So what we did was we looked for help, and one Mr. Ashraf, who owns a BKM trust in Valancheri, was willing to help us, and with his help, we started a child development center in Valancheri in Malappuram district. Our approach was a detailed clinical assessment, pre-intervention physiotherapy, spasticity control, multi-level surgery, post-op physiotherapy, and rehabilitation. And this oration mainly tell you what we did in the past 10 or 15 years to help these children. A detailed clinical assessment was done. As you all know, in cerebral palsy, it is a multidisciplinary evaluation. So we got hold of the specialist in the area, pediatricians, pediatric neurologists, ophthalmologists, physiotherapists, occupational therapists, and all of them under one umbrella, and they examined our cases. The initial assessment was, of course, done by the physiotherapist who detected problem in these children. But another problem was there, that is, all these patients which are referred to us are not really cerebral palsy. Identifying them is important as the prognosis is different. The siblings and relatives may be at risk. Therapy is available for some disorders, and litigation problem is always there for misdiagnosis. If you look at the growth line, the normal is straight, but cerebral palsy almost follows this normal curve. But there are some children who has got developmental regression, and these children are not actually cerebral palsy. There are a large number of neurological disorders and hereditary and inborn errors in metabolism which mimic cerebral palsy, spastic, dyskinetic, and ataxic cerebral palsy. Many of them can be detected by from their dysmorphic facies. But the message which I want to give is not all CPs referred to you are really cerebral palsy. You can detect them by the red flags. No risk factors like prematurity or difficult labor or neonatal asphyxia. There is developmental regression. There is fluctuation in the motor skills, positive family history, and progression of symptoms. And in the examination, the facies may be characteristic, optic atrophy and retinopathy may be there. Pes cavus is rarely seen in cerebral palsy, and many of them will have evolving sensory signs. Of the 2,332 children referred to us, 88.6 were having cerebral palsy, while not 7.1 did not have cerebral palsy. And we couldn't arrive at a specific diagnosis in 4.3% of cases. Coming to the assessment and decision making, initial assessment, as I already mentioned, is by the physiotherapist. This was followed by the pediatric evaluation and the pediatric neurology evaluation. In those cases where it is necessary, we referred them to the ophthalmologist and ENT surgeons. Orthopedic assessment was done by a team, and we did repeated assessment in the clinic, before surgery, and under anesthesia inside the theater. So repeated assessment is very important in these cases. Our method of assessments was depending on the diagnostic matrix, the clinical history, DMFCS, physical examination, necessary investigations like X-ray in indicated cases, especially X-ray of the hip joint, gait analysis, either observational or 3D gait analysis. In the history, we asked about the prenatal history, prematurity, natal history, the birth weight, any history of neonatal asphyxia, postnatal history of convulsions or kernicterus, then prematurity, birth weight, developmental milestones, convulsions, hearing, vision, intelligence, all these were recorded. Orthopedic assessment consists mainly of GMFCS, the muscle tone by the modified Ashworth scale, selective motor control, muscle strength, and the level of ambulatory ability. GMFCS is a very useful classification. In the level 1, the child is able to walk at home, school, and community, and able to climb stairs without using the railing. While in type 2, they are able to walk independently, but they will have some difficulty in running, jumping, and hopping, and walking in crowded places. While GMFCS 3, they walk with a handheld mobility device, as in the case of this child who is walking with the help of a rollator. And in level 4, they, in addition to mobility devices, they need some physical support. And level 5, they are being transported in a wheelchair at all times. As far as the gait analysis, we did the observational gait analysis in many of our cases or video recording, which we looked carefully during our spare time. In the MSCS 2 and 3, we did 3D gait analysis, and this was done from Bangalore, Bimbra, and I'm grateful to Dr. Jayant Sambha, who has helped us quite a lot in doing this gait analysis in his gait laboratory in Bangalore, and all these were done at a subsidized rate. The gait pattern of diplegic as well as hemiplegics were assessed as per the classical descriptions. Regarding the examination in the hip joint, we look for fixed flexion deformity by the Thomas test. We need to find out whether the adductor contracture or spasm is due to the adductors or the medial hamstrings. So flexion, abduction in flexion, extension, and modified Phelps test for use for this purpose. For rectus spasticity or contracture, we use the Dunganelli test. Femoral anteversion was assessed by the Craig test, and the muscle strength by the MRS method. So these are the various tests which we used, and is the Craig test, and finally the Dunganelli test. You can see the pelvis rising on flexing the knee joint. One big problem in the hip in these children is subluxation of the hip joint. The subluxation is usually silent, as initially the hip is inside, and gradually you find that the hip goes out into subluxation and dislocations. This is more seen in children with GMFCS 4 and 5. And radiologically, it can be assessed by the Reamer's migration index. And hip surveillance is a very important part of the assessment of children with cerebral palsy. For hip surveillance, we used a simple screening test, the abduction with the knee extended. If it is below 30 degrees, we did an X-ray. And in GMCS 1 and 2, we need to repeat the X-ray every year till the child is around 4 years old. And in 3 and 4, we need to do more frequent clinical evaluation and radiological evaluation, because it is these children who are prone for hip subluxation. In the knee, we look for fixed flexion deformity, stance face knee flexion, extensor lag, patella alta, popliteal angle, bilateral popliteal angle, functional popliteal angle at 30-degree flexion, quadriceps and hamstring length, as well as coronal plane deformities. So these are some of the tests. The first one, this child, he is not able to stand, but he is able to stand well on his knees, and he is able to walk, ambulate on his knees. This means that the problem is below the level of the knee, and if you correct these problems, he is likely to walk again. The fixed flexion deformity, the popliteal test, bilateral popliteal test, then functional popliteal angle, then patella alta, all these were assessed clinically. For the ankle and foot deformities, we look for planovalgus feet, equinus, equinovarus, cavus, and toe deformities like hallux valgus and hallux rigidus. These deformities are very common, and the silver skull test is very useful in distinguishing between the gastrocnemius and soleus contracture spasticity. As far as the clinical decision making is concerned, see this boy with crouched gait who is not independently ambulating. So after clinical assessment, we came to the conclusion that he may be better off with a hamstring release or transfer, supracondylar osteotomy for his flexion deformity, patellar tendon plication, gastrocnemius recession, and calcaneal osteotomy. So 10 surgeries in one sitting. And again, here in this boy, which you have already seen, he requires a psoas release, hamstring release or hamstring transfer, supracondylar osteotomy, patellar tendon plication, and equinus correction. This is how clinically we made the treatment plan. In those cases with GMFCS 2 and 3, where they are ambulatory children, we did a gait analysis, and we compared the gait analysis with our clinical data and came to the final conclusion as to which surgery has to be done. The management, mainly physiotherapy in young children. Tone inhibition comes be used in those with spasticity, especially equinus spasticity. Bracing, following correction of deformity, we gave them braces. Spasticity management was done by botulinum toxin as well as oral medication like baclofen, tizanidine, and diazepam. Botulinum toxin is very expensive, so we approached the government, and in the Talolam scheme of the Kerala government, we were allowed to give botulinum injection for these children. Multi-level surgery was done in those indicated cases. This was followed by intensive post-operative physiotherapy and long-term rehabilitation. We gave botulinum toxin for 264 children. Now around 100 children are waiting because of the COVID. We are not able to proceed further. And we presented a paper in the POSICON a few years back, which was given the gold medal for the best paper. Conclusions were that it definitely improves spasticity and hence the functional status. A single injection gave significant improvement in the ambulatory capacity, but more doses are often required. Intensive community-based physiotherapy played an important role in improving the ambulatory status. I'm stressing community-based because most of these children coming from a rural background where they cannot go to the physiotherapy centers for long-term treatment. As far as the surgical treatment, even though I worked in government colleges for most of my time, my years of service, I couldn't do much cases there because of the problem in getting adequate theatre time. Because in these hospitals, it is very busy and we cannot get theatre time for doing these single event, multi-level surgery. We approached a private institution and Professor Fasal Ghafoor, who is a reputed neurologist, agreed immediately to give us help. And we were able to operate in MES Medical College even when I was working in Government Medical College. And on Sundays, we used to go there and do these cases. And all these cases were done free of cost because this, the expense was borne by the MES Medical College. Before surgery, we used to discuss the realistic goal with the parents and definitely with the kids. This is a very important aspect. Then they go for the pre-interventional intervention training. They are admitted to VKM Specials, VKM's Child Development Center, where they have got residential accommodation, and they stay there with their parents for at least a couple of months to get pre-intervention training. And the parents are also trained in the physiotherapy and rehabilitation. Trained parents brings a lot of difference. The cases were done in MES Medical College and there was no compromise on quality, as these are done in not as camps elsewhere. These are done in well-equipped operation theaters. We did a lot of procedures in the hip, psoas release, adductor release, reduction of dislocation, hip, varus osteotomy, and acetabular procedures. In the knee, these are the common procedures that were done. And in the ankle and foot, a large number of procedures ranging from gastrocnemius recession, lengthening, tendon transfers of the tibialis posterior or tibialis anterior, and subtalar fusion, calcaneal lengthening, triple arthrodesis, subtalar fusion, corrective toe surgeries. All these are the range of surgeries which we did. The psoas, in ambulatory children, we did only at the brim of the pelvis. After identifying the femoral nerve, we identify the tendon and we cut the tendon at the brim of the pelvis without injuring the muscle. For dislocation hip, it was a big problem because most of our cases are adolescents, children who didn't have any proper treatment, and we had to do a number of cases, open reduction and acetabular and femoral procedures in dislocated hips. In non-ambulant children, we excised the femoral head and did a pelvic support osteotomy. But unfortunately, in my hands, this is not a good procedure as the patients continue to be symptomatic even after this procedure. Hamstring lengthening was done initially, and later we started doing hamstring transfer also. Hamstring lengthening is a myofascial lengthening, and the only problem with this procedure is that it reduces the hamstring strength. Semitendinosus was transferred to the adductor tubercle in hamstring transfer. With stiff knee gait, we did a rectus transfer. And for flexion deformity, more than 15 to 20 degree, we did a supracondylar femoral osteotomy, extension osteotomy with shortening, and this gave reasonably good results. Along with that, we did a patellar tendon plication also. Even those with more than around 80 to 90 degree flexion deformity, we are able to do these procedures. Patellar tendon plication, the only difference is that we used a tension band wire so that we were able to mobilize these children very early. Active knee flexion and extension was started early. Correction of equinus is as per the protocol given in this article. And for gastrocnemius, we did the Strayer's release, and for gastrosoleus, we did the Baker release. For varus deformity, we did for fixed heel varus, we did the tibialis posterior transfer or an intramuscular lengthening of tibialis posterior tendon, as you see here, along with a Baker's procedure when it is indicated. Calcaneal osteotomy was again done in the usual manner. The only difference is that we very often combine it with an intramuscular lengthening of peroneus brevis tendon. So from the same incision, we took a fibular graft which acts as a strap to keep the space in the calcaneum. So bone grafts were not necessary, and the morbidity was much less. Of course, we do not have any allografts in the rural setup. Postoperatively, the early mobilization, physiotherapy, splintering, and education and long-term rehabilitation. Bracing was done. We taught the parents how to repair these braces so that for small repairs, they need to come all the way to the center for repairing these braces. And this is our rehabilitation hall, where you can see that it is the parents or the mother who is with the child and make them do the physiotherapy, of course, under the supervision of trained physiotherapists. And this makes a lot of difference, as when they go home, they are confident for helping these children to do physiotherapy and rehabilitation. We train them in the activities of daily living also. And feeding also was a problem in these children. So when they sit together and have their feeds, they are very happy, and the feeding habits usually improve. Then regarding their academics, many of these children learn. There is a special school attached to this institution where teachers usually come there in their spare time and teach these children. And those who want to join the school can join in the corresponding classes and stay there and continue their studies. We have got a good computer room of more than 25 computers, and these children are very happy and to play with the computers and learn quite a lot. And even the government has also given some work for these children for putting some data and under the Niramaya scheme and all, and they are very happy to do this. We teach them also some skills like making paper cups, making paper plates, making paper bags, which are very useful after the exit of plastic bags, and these cleaning solutions. And they are, in their spare time, they do these vocational training also. They take part actively in vegetable farming, and most of the vegetables necessary for during their stay are obtained from what they have cultivated there in the same compound. They take part in the social events often conducted in the neighboring districts, and they also are taken for sightseeing tours. Our aim is to make the rehab sections playful, and these children are very happy when they have got company to play with. They take part in sports activities in the adjacent districts and at the state level, even at the state level. But at the end of the day, the parents who are getting exhausted. You can see these little girls being carried by the mother. But what about this lady carrying a heavy adolescent child? And it becomes very difficult. To sort out this problem, we started training the siblings to take over from the parents. You can see this little girl brushing the teeth, putting on the clothes, putting on the caliper before going to school and giving a kiss and before she goes to the school. We occasionally visit to their residents to find out how they are coping. To our surprise, many of these parents have bought their own exercising machines, necessary machines, and the parents are